हेलो
हाँ just mute us, no problem.
दादा बोलो
আচ্ছা এবার লাইট ঠিক করো তিনটে ক্যামেরার
Just
We are live now. We can start.
মনিটরে প্রোগ্রাম দাও
I'll mute. I'll go and mute. Wait. Mute कर इसको. Wait.
All our dreams can come true if we have the courage to pursue them. A very good morning. Greetings to one and all present here. Welcome to the third but the first ever virtual AMC. I welcome here to celebrate the dream. Actually, the dream turned reality. AIOR brings to you the technology in action. For the first time in India, a live robotic hip replacement would be beamed from our virtual platform. It's an absolute honor for us to have between Dr. Kriyat Sancheti sir, Dr. Parat Sancheti sir, Dr. R.N. Singh sir, and Dr. Ashish Singh sir. Kriyat Sancheti sir, the Padma Shri, Padma Vibhushan and BC Roy recipient, and his able son, Dr. Parag Sancheti, the chairman and medical director at Sancheti Institute for Orthopedics and Rehabilitation and Joint Replacement Center. Dr. R.N. Singh, the recipient of the Padma Shri, former president of Bihar Orthopedic Association and senior consultant at AIOR. And Dr. Ashish Singh, my father, the chairman and medical director at Anup Institute. I once again warmly welcome you here and everyone, and hope we all look forward to an enriching session. I would be playing an introductory video, so kindly follow the link.
It's 99% hard work and just 1% luck. You have to work to achieve your goal. Never lost patience. What I felt, apna time aayega. So time will come.
Now I would like K.H. Sancheti sir to take over the mic and enlighten us with his words. Thank you, sir.
Hi, good morning. Good morning, everyone. Dr. Arun Singh, the founder of Anup Institute of Orthopedics and Rehabilitation, my student and friend also now, Dr. Singh, and who is the chairman of this course, and so many other delegates. Can you hear me? Can you hear me? Hello?
Yes, sir, we can hear you. Go ahead.
Oh, wonderful.
Yes, sir.
Now, this is the third course. First started with hip and knee, and again on the hip today. As I was discussing with Aryan Singh, in early practice, we were together. I had been there once, and what surgery was done that time and what surgery is done today was difference, both in design, technique, theater conditions, and now on the top of it, robotic. Robotic is one which Dr. Singh has brought to Patna and made the patients more comfortable with this technique. I appreciate Dr. Singh for one reason, that he doesn't want to keep the technology with himself. He wants to teach the people, he wants to let the people know. And this time in this particular course, he is going to show actually live demonstration how the robotic is used during surgery. I'm glad, I'm sure, and more than 300, 400 delegates have joined now, and there will be many more will join soon, and they all will be benefited. This kind of virtual courses are no way less effective than actual conferences which we attend. But I'm sure these efforts will be go long way to educate others and make others comfortable as far as the newer technology is concerned. Dr. Singh was with me in 2005 to 2008 during his period. I remember how he was first person to come in the ward and last person to go, and the way in which he was talking to the patient, the relatives. And one thing I still remember, he's handling the people, nurses, ward boys, mouses. I was also very human. You know, he always believed no one is big and no one is small. He says because of situation, they are mouse ward boys or nurses, and we are doctor. But God has sent us for same work, different kinds of situation. So with this kind of philosophy, Dr. Singh, you have progressed a lot. You have shown a very good success in your life, in your medical profession, and I'm sure Dr. Arun Singh must be very, very proud of you as his son. I wish this particular course a very great success, and without taking much of your time, I hand out the mic to the organizer. Thank you very much.
Thank you, sir.
Thank you.
Now I would like to pass over the mic to Dr. Ashish Singh. Now I would like to pass over the mic to Dr. Ashish Singh.
आशीष को बोलो, आपको बोला आशीष को बोला, नाम से कुछ किसी लॉगिन होता है. Hello, welcome to everybody in this virtual AMOC 2020. As Dr. Sancheti has rightly suggested, was told that this type of technological advancement, when we were early 80s, we were doing joint replacements, and today there's a much difference and much of developments have taken place. This is all because of the technical advantage and adaptation of those advantages into the orthopedics surgery. And first of all, the navigation came. Then there was a time when specific instrumentation for the transplant surgery started. But ultimately now the robotic surgery has come, and robotic assisted arm assisted surgery, which is very precise. And I'm glad that Dr. Ashish has organized this AMOC, that is course, master's course, and this is the third one going on the hip replacement. This is very important, and it will give some new ideas to the new orthopedic surgeons that how the advancement of technology has come in orthopedic practice these days. I wish every person who is attending this particular course a good success, and my best wishes to them. Thank you very much.
Thank you. Thank you. Now I would like Dr. Ashish Singh to take over the mic.
Everybody. As on behalf of Anup Institute, Anup Masters Course, I would like to welcome you all again to the first and the third Anup Masters Course. Now, I have tried to make this conference fully virtual, keeping the safety concerns due to Corona pandemic. And we have stalls, which is all virtual, and you can join this through Ortho TV, and also you can join us on through our website. So please kindly have a good time, enjoy the day. You'll be seeing first time in India robotic live surgery, and at the same time you can individually exit the auditorium, visit individual stalls, go to each stalls, collect their brochures, see their videos, and take it from there. I'm very thankful to my Guruji sir, Dr. K. Sancheti sir, Dr. Parag Sancheti sir, my father, Dr. Arun Singh, the whole team of Anup Institute and Anup Masters Course. And thank you, sir, for speaking few good words about ourselves, sir. So with this, I would like to hand over the mic, and also I would like to thank Lavanya, my daughter, who started the show. And I would like to hand over the mic to Shamsul Hoda, sir, to start the event. Thank you.
Thank you, Dr. Ashish. Good morning to everybody. Good morning, sir. I welcome Sancheti sir, Arun Singh sir, Auto TV team, and Dr. Ashish. So we have our first session from 11 a.m. So shall I start the first session? Do we have our faculty over here? Dr. Rakesh Rajput?
Yes, Shamsul, I am around.
Okay, sir. So our first session starts after 15 minutes. So Dr. Ashish, shall I start right now? So, sir, you can start with your. So, I welcome now Dr. Rakesh Rajput to start his first talk on evolution of THA.
Thank you, Dr. Hoda. It's a pleasure to be on Anup Masters course. The first two courses, I mean, Ashish has been very great and has always invited us. I think Bihar and West Bengal share a very good rapport. Unfortunately, I was always committed to somewhere else, and I couldn't go to his course, and I've always regretted not being able to. And this time, I just couldn't miss this opportunity. However, it's on a very advanced technology, robotic, hip replacements, which I unfortunately have no sort of experience of, though I've got experience of robotic knee replacements. So I was very keen to be here. And Anup, I'll just start screening because we've got so much time to talk. So it's a very esoteric topic at the moment, evolution of THR, and seeing one of our, mentors in orthopedic surgery, Dr. Sancheti, also watching it, will give us some jitters. I have been involved with hip replacements for last 25 years now. And, we have also been a part of this evolution. And honestly, there is so much which has happened that it's almost impossible for anyone to actually cover the whole gamut of changes. But I'll try and make a decent talk of it as to what happened and how we started off. So initially, when people were beginning to have diseases, there was absolutely no treatment available. But in 1800s, people were using fascia lata, skin, whatever they found their hands on, but it was all organic, and they tried to just cover the diseased femoral head. And remember, the disease of during those times, it was mainly tuberculosis. So Gluck was the first one who tried to use a non-fascial implant, and which was an ivory implant. We understandably, the success rates were much less compared to the failure rates, and actually it didn't take it on. And since then, various other surgeons on both parts of the continents kept on developing from small to bigger things. Smith Peterson was one of the first guys who got credit for doing something, and it was actually a mold of glass. And then initially, along with Wiles, he tried to put a metal cap onto it, which is stainless steel. And at the same time, Jude was in Paris, was trying to form acrylic processes, and we do still see a lot of pictures. And this was one process which in the beginning actually gave some sort of success, at least for the first 3 to 4 years. But those were not really good enough. And the one which I really want to highlight in this slide is the 1939. Look at the year 1939 when Thomson and also independently Moore developed their processes. And we in India, we still see this around. So hats off to these two developers that they have given us something which is lasting close to 100 years. So, it's not that always change will be better. And even in UK, even until last 5 years ago, at least I knew these processes were available to be used predominantly for nursing home, and care home patients as a filler, but still available. And most of them, thankfully, were actually exported from India. So it's not still out even in a developed world. And then came the period of Scott Venable. I think Scott Venable, even the trauma surgeons know them very well, developed the Vitalium processes. And Habush was the first one who tried metal and metal refurbishing. Again, go back to the year 1951. Then there were some more developments like Mackey Ferrara sort of hips. And then they went out and then they came back with the Birmingham hip. So imagine like something is there, goes out of window for a period of time, then comes back, and sometimes again goes back. So we keep going on and delving into the past to actually make development for the future. Look at the other processes which is here, which is 1956. Shivas, I don't know if anybody remembers him very well. This was a guy called Konstantin Shivas from Moscow, and he had developed a process. And the bottom left on your picture is that original process Shivas. Now, what happened with this process is it actually didn't get that familiar. He was still competing with the current available process at that time. And this was actually a big game changer during that time. But then, because it was from Moscow, many people didn't notice it. My internet connection is a bit weak. So if I ever go out of connection, Dr. Huda, just let me know. Am I audible and visual at the moment?
Yes, sir.
Yeah.
You're audible,
I'm
sir.
sorry, it's a bit weak there. So Dr. Shiva's discovery or invention, I would say, got then taken over by the Americans. And what these Americans did was actually got more mechanical principles involved in it. And the same astronome Noyes, as we know it, actually got involved with this and developed a bit more. In the end, there was another technology firm which took it over and then made very, very modular. And what you see now, which is called S-ROM, as you see from before, is a far different design than what originally Shivas actually started with. Though the name Shivas or S-ROM, S actually stands for Shivas, is still there, but it has no resemblance to the original processes. But if you look at these processes and the Wagner stem today, you will probably find a lot more similarity between Wagner and this original processes. So, Wagner people took on this process and developed their own way and still had some resemblance to this. And this is the beauty of all these inventions, that sometimes they just evolve, lose complete trace with what the evolution was, and something else will look similar to what the original invention was. So that's a beautiful thing to learn from the past. Now let's come to the era from where the actual modern THR really started from. That was John Chandy. We cannot talk about hip replacements not mentioning this gentleman from Wrightington. Chanley used to originally practice in Manchester, and unfortunately didn't get that much access or support from the actual Manchester, because he was a junior consultant there. So he went off to a different place, actually set up the whole lab from the scratch. And if anybody's been to Wrightington, you'll understand the amount of trouble this gentleman would have gone to actually develop hip replacements. And I personally really believe that he was one guy who probably should have won the Nobel Prize for medicine. He really deserved that. And Charlie's look at the failures. He initially started with the PTFEs, then went on to Teflon. And it was not until he actually got hold of a German engineer who was developing resins at that time and got hold of the polyethylene, that when his actually hip replacement really took off. He also realized during that time that the head size has to be very small if he wants to reduce the wear rates. So he actually developed a 22 millimeter head, and he realized that to actually get good fricks onto them, you need cement. So look at all the current inventions which you think of and go back to the Charlie. He was actually developing it at that time. Also, his contribution doesn't just end there. His contribution also comes to the cleanness and neatness of the actual operation theater. Apart from the antibiotics, they were also developing at that time. Remember, the antibiotics also were not very well developed. Penicillin was discovered in 1944, but went out of circulation for quite a few years until the Second World War actually, was almost finished. Now, so his Charnley-Howard system is still very much practiced regarding the laminar airflow theaters. So Charnley was so much ahead of his time. Now let's come to another few replacements which are also happening, fortunately, in England at that time. So we know the Peter ring processes, which had a screw which go on to actually fix itself in the acetabulum. And at the same time, Mackey Ferrara was also a metal-on-metal replacement which was being developed. Also, Sulzer company was also trying to develop the metal-on-metal. So metal-on-metal was a very established procedure during that time. I remember seeing X-ray of a person who had 45 years of a metal-on-metal processes. I can't remember any other hip ever being lasting that long. So that hip was done almost, in 1960s when I had to be in England and I actually happened to see that X-ray. So, even those ancient designs worked for so long. Now, then let's come to a couple of more important, developments which were happening. So Muller was developing his stem more in the continent Europe at that time, and he was developing the heads which were a bit larger than what the Charnley was doing. So for him, 28 and 32 heads were actually, more of a norm rather than an exception. At the same time, Boutin, who was practicing in France, was actually doing a lot of his operations with ceramic on ceramic. So remember year 1970 when ceramic on ceramic was still being developed, but largely because it was not that popular in UK and in US, his inventions were largely kept on the sidelines. Though they kept on in continent Europe, it was quite powerful, the ceramic on ceramic designs, but it was not that popular in US or in UK at that time. I happened to go to UK in 2004. Even then, the ceramic on ceramic was not really popular in UK. At that time, Muller was also developing a straight stem. Later on, he actually moved to a slightly curved stem. And Boutin then further went on to develop actually a modular ceramic bearing. So you could have a cup, and in which you had a modular plastic, which you could actually modular ceramic, which you could fix in. Now comes another big era, which is coming from the Exeter group. And at that time, the Exeter stem was launched. And remember, we need to really thank here Dr. Robbie Ling, who was developing his processes in Exeter. And I used to work a lot, just about 40 minutes away from Exeter in Bristol. And these two centers were really using a lot of Exeter hips at that time. And at that time, there were still some more developments happening on the actual continent, US. And they were actually trying to develop something else which was not cemented. We'll come back to that later. So at this time, there were some other types of cemented stems being developed, one in Exeter, one in Wrightington, and at the same time, Stanmore, where all the elective surgeries predominantly were being done around London area, was also developing a stem. And a lot of customized stems were also being developed in the Stanmore area. So 3 different cemented stems being developed in just about in UK at that time. So what was the good thing about the Exeter stem? First time, the philosophy became different. So there was one Charnley stem. Only later on, when we started thinking more about cementation, we required that there were these 2 principally cementation techniques which were being developed. One was the Charnley stem, and the cementation technique to them was composite beam, which means that you really had to very good cementation in the beginning itself all around the stem. the compact mantle in such a way that you have no chance to move the stem. So that was, so the stem and the actual cement became one composite structure, and that's why it used to be called a composite beam. Whereas the Exeter model was slightly different. Here, you actually had to put the cement first, put the stem in, and there was still some gap left on which the could sink in. And actually, it got much more stable after it started sinking in. So you had this taper concept in Exeter, where the taper allowed the stem to sink in a bit, and that is why later on developments had a cement restrictor and also a centralizer. It was a centralizer in which the stem used to sink in. So these two were the predominant different cementation philosophies being developed during that time. However, there was a third philosophy which was developing as an accident, I would say, in France itself. And we never understood that what was happening in France. So what was happening in France, they were taking these big polished stems and they were actually putting into the femur in a very good tight fit in the beginning itself. Naturally, what that left was that the cement space was very less. But still, these stems actually performed quite well. So on one hand, we were saying that you need to have a very good cement mantle for the stem to survive, 15, 20 years. On the other hand, these French surgeons were putting in these large stems with hardly a cement mantle there and still performing well. And this is why people never understood how these two philosophies contradictory to each other, but still successful. And it was called a French paradox. It was only on later research it was found that it was not really a paradox. What happened was that because of the actual thickness of the cement of the stem itself, it gave the initial stability. So if the stem was initially stable itself, it didn't rely on the cement mantle itself. However, as more and research happened, we realized that even though they looked very good in the beginning, but after about 10, 12 years, they started failing very, very catastrophically. And the reason for that was there were defects in cement mantle. So if you have defects and you have polywear, we know that the polythene can track down in those defects and cause loosening. So even though these stems performed well for first 10 years, later on they actually became loose because of the debris of the polyethylene which tracked down. And it was only then we started understanding that the cement disease was not a cement disease, but was poly debris. So to make even those stems perform better, it was found that they should have, even if you have a thin cement mantle, what you can't have is a defect in the cement mantle. So now the concepts of cementations were evolving and actually we got better and better. So all these stems were actually making you feel how to actually put a good cement hip replacements. But we understood that there was a problem of osteolysis. So how do we overcome that? On the continent, or the US continent, what they were trying to do is to actually develop a cementless stem system, which didn't have this so-called cement disease. So they started, having various ways. First, having almost no coating, then having a poro coat, then having a hydroxyapatite coat, or having a mixture of it. So various types of cementless designs actually came in. And one of the first ones, which was very popular, was, if you remember, the AML design. However, as the studies came on of the AML design, we found that the AML process was gradually getting loose. Proximally, there was bone resorption and sometimes thigh pains because only distal fixation happened. So this thigh pain was the huge concept in the initial failure of many of these so-called uncemented designs. And when this AML process was realized, it was found that it was actually only fixing distally and not getting adequate fixation proximally. And it was also evolution of this AML design, which ultimately, if you think of one of the companies called Dipui, turned this AML design into called solution hip and actually became a very good go-to revision stem. So when you have already proximal femur destroyed in case of a revision case, the AML stem now turned into called solution stem became the go-to stem. So at that time, you had a Wagner stem and a solution stem, which were your go-to revision stems. So the same concept, which was a failure in a primary hip, became a success in a revision hip. Also, there were other stems which were coming in, Mueller, Eng. But I think one stem which we need to talk about is the 1983, which the Biomet launched. Now, Biomet is one company which was very small in size compared to the so-called other big orthopedic companies, or I would say joint replacement companies, but always came out with very niche products, be it their vitamin E poly, be it their knee replacements like the AJC knees, which was one of the first ones to give 20-year survivals, or be it their hip replacement, which is very least actually spoken about. If you ever see the taper lock design of Biomed, which is somewhere in the middle of my picture, you will realize that all the current designs of hips almost are a copy of this taper lock design, including the core. Now, the core guys might say that, we are, the first very good, successful cemented, the uncemented stems. But if you look at the design, forget about the coating. If you look at the basic designs, it is so much close to a taper lock. So I think in that respect, taper lock becomes your primary stem, which was the most successful one, and still available. So you can go back to 83 design, which is still available even today. Of course, the coating may have changed. We learned a lot more about coating, and we'll come to that bit later. So we now found that the stems was getting very, very stable. Now, what happens to the cup side? We knew that the cemented cups were lasting very well for about 10 years, but gradually with period of time, they were actually disintegrating. So how do we make a cup last longer? And hence the uncemented cups started coming in. The initial uncemented cups had threads which you used to think. Then we had holes for the screw, and then we had such good things that probably we could do away with the actual screws itself. And hence the completely screwless cups actually came into being. So the cups also started evolving. So now we can go according to various things. So the stems were evolving, cemented, uncemented. The cups were evolving, cemented, uncemented. Apart from that, we had the bearing things which we need to think about now, and we'll talk about the bearing options, which I think are equally important. Now, at the same time, in 2002, the NICE, the National Institute of Clinical Excellence in UK, actually set up a committee which will now monitor all the hips. And slowly we found that the lessons learned from the Swedish hip registry were being now learned in the England and Wales also, and the national registry was launched. Now, the ceramic designs which were being very popular in continent Europe also started coming to UK, and now suddenly the UK market was also very rich. Suddenly the ceramic was the go-to joint replacements for the moment, and hence the ceramic also now, because it became popular, it also started rapidly evolving, and Delta ceramic was launched in 2004. Unfortunately, at the same time, when the Birmingham hip was becoming very popular, and Corin had launched the Birmingham hip in the beginning, also Dupuy launched their ASR. So now we had total hip replacements and we had hip resurfacing. So two different forms of hip replacements were being popular. Biomet also launched the vitamin E stabilized polyethylene. Look at the year 2010. It's only for last 6 years or so we've been hearing other companies talking about vitamin E, and only actually last 2 years that tribological studies actually showing that superiority of vitamin E poly even in hips. But Biomet was a company which was doing it even in 2010. So good things. Now let's talk about fixation techniques, cement versus no cement. Cement was one way. Again, the evolution of the cementation techniques, first generation, second generation, third generation. I won't go into details of this. But what we really want to think is that the uncemented THRs were getting very quickly popular. One, it was driven by the American companies. They were also more expensive. So the companies had more profits into it. And also we know that the uncemented cups were definitely lasting longer than the cemented cups. But also I think one should remember that the uncemented stems were slightly easier to put in. They were also slightly quicker to put in. What happens with cemented stems is that there is a third person involved with doing that. And many of the Americans couldn't rely on anybody else doing something for them. So hence in America, it was more into uncemented stems. But also, I think one should not go away with this concept that the uncemented stems were so much good. I think there are plenty of places where you find you just cannot put an uncemented stem and you have to come back and actually put a cemented stems. Also, we have to think about our country. Cemented stems are so much cheaper. For a slightly elderly population, I think they should be the go-to stem. Now, let's talk about the bearing surfaces. So we had metal, we had plastic and ceramic, and we had combination of this you could use as bearing. So you could have a metal on plastic, you could have metal on metal, or you could have ceramic on plastic, or you could have ceramic on ceramic. So a lot of options came, and I think we have different liners, and most companies now give you all these options in one design itself. It won't be good to actually talk about evolution of a THR without mentioning anything about one hip resurfacing, because that has been the biggest game changer in recent years. So Birmingham hip, which was originally being launched somewhere close to early 2000, became very, very popular. And I think because it allowed people to literally do anything. Even if you look at even the current day, even Andy Murray, which is such a famous sports personality, a tennis player, winning Grand Slams, have got a BHR and actually has come back and started playing professional tennis, and he even he's won tournaments, at least in doubles. So it is one hip which gave you so much more freedom. However, it also came with certain cost. A lot of other companies came into designing actually Birmingham hip. Remember, the original Birmingham hip was being designed by a group called Corin. Now, Corin suddenly started manufacturing Birmingham hip in a very different way, and Dr. McMean got very angry about that. So what he did was he formed his own company, which was at that time called Midland Medical Technologies, MMT. And so they started manufacturing the Birmingham hip in the same way as Dr. McMean wanted, but the Corin started forming a different group. Similarly, at that time, the Dupuy ASR also was launched, and there were other companies which started making things. However, the initial studies, which were very encouraging, but when gradually some reports started coming in with complications of metal on metal resurfacing, it was also realized that there were issues with this, including ALVAL and ARMD. And one of the pioneer studies which came out was from Ashley Blom from Bristol, which actually highlighted the ALVAL lesions in and actually said that the huge rates of these failures, early failures in metal on metal resurfacing is not acceptable, and perhaps there should be huge caution attached to it, to such an extent that the NICE actually said to stop using Birmingham hip for them temporarily. Of course, what we have come to realize now is with very judicious use, Birmingham hip can still be used, but not in a with a design change. So ASR withdrawal has been such a downturn event in our current THR scenario that people have burned their fingers so badly with lawyers getting involved, court cases, that I think it will be very difficult for any other company to bring out a new hip resurfacing at this. It would be also not complete talking about evolution of hip replacement if I do not talk about the evolution of approaches. If you asked us about 10, 15 years ago, there were just two approaches which were competing with each other. One, at that time, what we used to call as like approaching the hip anteriorly or approaching the hip posteriorly. Posterior approach, there was really not much of a difference. Everybody almost did the same way. The only change or evolution which happened was stitching the capsule in a much better way to reduce the dislocation rates in a posterior approach. However, if you talk about anterior approaches, one were very confused with technologies. You know, Smith Peterson is anterior, Watson Jones is anterior, and some people even regard Hardinge approach as anterior. Really, Hardinge was really supposed to be a lateral approach. A direct lateral approach was also being coined at that, but I think the direct lateral approach should be a term used for Charnley approach, where you actually did a trochanteric osteotomy. Otherwise, you either approach a hip anterior to the trochanter or you approach a hip posterior to the trochanter. So let's forget about these two approaches. The other approach which has come in a very big way in a vogue recently and getting very popular with the younger surgeons is the direct anterior approach. By saying that you don't cut muscles, you have very minimal tissue plane dissection, the scar is small, and the rehab is very quick to such an extent that people can almost walk normally the next day itself. So this is something I think we still need to wait in time and watch, that it should not come at a compromise of the longevity of the hip replacements. So that is where the test of this approach will be. So let's wait and watch. But what has thankfully not taken off is this minimal invasive hip replacements, which was being industry-led, which was being used as a marketing tool, which certainly had higher complication rates and thankfully been abundant in current day and age. I will not go too much into other advancements, but I will just mention here because I think that the later on speakers will be talking in them in details. We need to talk a bit more about navigation. Navigation also came in hip. Technology of navigation was also evolving. However, the only trouble with navigation in the beginning was that we apply navigation in a supine position, then we tilt the patient, and because most hips are now being done on a lateral position, and then things change. So unless you had intraoperative navigation where you could adapt, it was difficult. Moreover, there were other things that in spite of navigation, people didn't know what you're doing is right or wrong. You knew that you planned something, you knew that you've done the operation also according to plan. What you don't still know is what you planned was the right or wrong. And hence you need some bailout options. And these bailout options, one of the biggest things which have happened in current day and age is the dual mobility cups. And I think for revisions, it is just the go-to way for the revision hip scenarios. Also nowadays, when we used to find some cases of disasters in the beginning and we didn't know what to come across, we used to find bone banks and actually take over a head and put it. Now we have trabecular metals. And I think again, they, to me in my book, they are godsend. Also, we have now cups, which will give you radial fixation and not just roof fixations. And these cups are also very godsend. You can actually put screws in ischium, you can put screws in pubis, and the primary stability is enhanced by the secondary stability, which is given to you by the screws. Also, we have seen evolution in the technology of templating. Digitalization has happened, and we have softwares like TraumaCAD, which can actually tell you what should be the center of your hip rotation, where should your cup be, what will be the size of your cup, what will be the size of your stem, what will be the offset, how much stem you have to sink in. So I was really amazed going to Exeter and seeing how to utilize this templating digitally and actually creating exactly the same what you had planned in the even up to 1 or 2 millimeter sinkage of the stem. Really impressive technologies. Of course, robot has come today. Probably most of the day we'll be talking about robots, so I'll just skip past. The other thing which is now coming in a big way is the custom-made implants. We did have custom-made instrumentations, which we used to call PSI or patient-specific instrumentations. But now we have custom-made implants available. And I think I'll just take you through a few of these examples I've just mentioned. This is the case of transverse acetabular fracture, which was initiated with the pin traction, then with fixation. Unfortunately, the posterior wall just gave way, superior dislocation of hip, which was left for 4 months like this. And naturally, there's complete erosion. And we had now had a defect, which we classify as a 3A defect, which you have to go and actually apply some augment. Luckily, we have this trabecular metal, so you have nothing to actually do carpentry on the operation table. You can just apply this metal and you can actually unitize the actual cup and the augments. Similarly, if you have a bigger defect, this is again a 4-month-old acetabular fracture, which was again dislocated hip, which has completely eroded through the posterior column and also posterior wall. So what we have done here is actually put a column augment, or we call a roof and a wall augment, which will actually bail you out immediately along with your cup which has rashed. Here's a case which initially you think 10 years post-rheumatoid, the left side is protrusio now. So you do all your tests to see whether the vascular structures are intact. But when initially you think this might be a 3B defect, but when you took out the whole cup, you realize that there is actually a pelvic discontinuity or type 4 defect we talk about, and then you go and put a cage here. You also have sometimes very bad defects. I think if I can play the video, you'll probably see that this hip is almost unreconstructible in any other current technologies we have. You have a complete displacement of the ilium, which is in 3 splits. The articular surface is 180-degree overturned, and the hip is migrated close to 5 centimeters above the usual articulation area. So what we did in this case was we actually initially did an extended iliofemoral approach, got and actually converted the proximal part of the ilium into one sphere, derotated the articular surface, and actually reduced the size of the actual defect. And at the same time, we realized that there is no cages which are going to cover you at this, and you have to do something called customization. So I spoke to the biomedical engineers in Warsaw, and slowly we designed that we had to fit a very large spacer inside. We got to fix this spacer to the intact ilium, which is in continuity with the sacroiliac joint. Then you put in this spacer and you go ahead and actually go to the operation theater and put this spacer in. And a situation which was almost hopeless, you managed to give him some sort of hip for him to continue his activity as a bank manager. So friends, I think the evolution in hips have come to such a state that I think impossible is nothing, is not something very far off from current day. So my advice to any juniors who are listening to this talk is that it is not good to be the first one to rush to every new technology, but my advice is also don't be the last. Embrace technology, because change, it will be the only constant you are going to come. But do not become a slave to this technology. You cannot leave your head aside and say, okay, fine, my robot will do everything, or my navigation has planned everything and I'll just put my head. There are times when things change, there are times when scenarios change even during operation. So be aware, use your technology and make a slave, but don't let them become your masters. I think with this, I'll probably stop. I've covered my 15 minutes. Thank you very much. If I'm allowed, I can take questions. And Ashish, thank you very much for allowing me to speak.
Thank you, sir. Thanks a lot, sir. In the meantime, when we are switching for the next talk of Dr. Friedrich, can I request Parag sir to say a word? Parag sir is there?
Yeah, hello. Good morning, everybody.
Good morning, sir.
Yeah, good morning. So excellent, and thank you, Dr. Shamshul, Dr. Ashish. Thank you, Arun Singh, sir. It's a great pleasure to be on this platform, even though I don't do much of hips, but it was a very interesting talk, Dr. Rakesh. Very well spoken, and I'm happy to be on this webinar today and congratulate Anup Institute, Dr. Arun Singh, Ashish Singh, everybody for bringing this together. And one thing I've seen with Ashish, he's always on top of technology. Whatever is new, he wants at the Anup Institute. He has been our student. He's an alumni of Sancheti Hospital, and I also was in close contact with him when he was doing his training in UK. Always a bright student, always wanting to learn new things, always open to ideas. So today his dream has come true and he has launched the robo. So Ashish, congratulations, and congratulations also to his daughter who spoke very well, and his father, Dr. Arun Singh, who's been my mentor. So all the best, and I wish this course all the success. And I'm sure this is going to change the way the hip replacements are done in India, and also the arthroplasty. I think robotic technology is coming, and added with the computer navigation, what we heard Dr. Rakesh speak, is going to be the new era. And I think earlier we are on the bandwagon for this, the better it is. So congratulations again, and I wish this course great success. Thank you, Dr. Shamshul, for having asked me to speak. Thank you.
Thanks a lot, sir. Now I request Dr. Friedrich Pickard. Sir, do you have your presentation ready, sir? We have this talk about TCAD navigation in 2020, what we learned with that.
Can you hear me?
Yes, sir, please.
Yeah.
Please make it full screen, sir.
Yeah, I'm going to try to put it full screen. So it should be, can you see it now?
Yeah, yes, sir. Please go ahead, sir.
Well, good morning, everyone. It's a very early morning for me. And I'm very pleased to be with you all, at least virtually. And I'd like to thank, obviously, the chairman, Professor Sangheti, and his son. And this is a real pleasure for me to be with you all. And I'd like first to thank Dr. Ashish and Arun Singh for inviting me to talk about what I've learned, what we have learned, and what are the evidences and outcomes of total knee replacement using the technology. What I'm going to talk about is knee replacement. It's not hip replacement. I am an orthopedic surgeon working at the Golden Jubilee National Hospital in Scotland, which is the biggest arthroplasty center in the UK, probably in Europe too. We perform more than 4,000 joints a year. And I'm still performing a lot of hip replacement, but our main focus is on knee replacement. And let me start with my disclosures. I've been working in this field for almost 30 years now. I've got license and with different companies, and I've been very fortunate to have been part of the first pioneering team developing the first CT-free or image-free navigation technology for knee replacement. I work with my good friend Francois Leitner, who is an engineer, and we designed the great-grandfather of the autopilot, which was the first CT free navigation system in the 90s. And I was also very fortunate to perform the first ever total knee replacement using the technology on January 21st, 1997. And you see me on this picture. I was young at the time with Prof. Saragalia behind me. And we published the first results in core in clinical orthopedic in 1998 with my good friends, David Stodberg and Brian Davids and Scott Dell, who are all working in the field as well for a very long time. I'd like to show you now what the number of publications around the time between 1980 and 2019. And obviously, the technology started in the mid-90s and was clearly visible by 2000. And by 2007, there were enough publications out there to assess the technology. And that's what this man did. This man's name is Robert Siston. He's a graduate from Stanford, and he's now professor at Columbus, Ohio, in the States. And he did a fantastic work looking at all the publications out there on navigation and total neural placement. And he published this paper in 2007, which was twice awarded by the International Biomechanics Society and the Association of Biomechanics. And what he found at the time was, first of all, there was no more risk or complications using this technology already at the time. There was an improvement with the coronal and sagittal alignment. The rotational alignment was still controversial. It was still unclear whether the technology can improve this aspect of total neural placement. Ligament balancing was improved. That was considered already a very excellent teaching tool. The cost was an issue, but there was no answer about whether we can improve the functional outcomes, whether the long-term was improved LC using this technology, and finally, whether there was any differences between systems. So we looked at the evidences for the navigation in 2020. And I'm going to start this review with this shrugging face, this skeptical face that I've seen over the last 30 years every time I have been presenting and showing this technology. People were and are very interested, but there is always a but. And I'm going to do this presentation following these but questions. So what about the risk and complications? One of the main criticism is obviously the possibility that there were more fractures. What are the evidences? Looking at this paper in 2015, published by Thomas et al., out of 321 knees over 31 months, there were no major complications recorded during this follow-up and no fractures. This very interesting paper from Kenneth Krakow, who, as you may know, has been involved a lot in the design of the Striker navigation system. And they published in 2017 this report with his team. And out of 3,100 knee replacement, they found only 2 fractures, both possibly related to actually the trackers and the pins. There is maybe more affection. Well, in 2017, in the journal of Arthroplasty, this team looked at the pins and whether there was more complications or not. And they confirmed that, in fact, the pins required for navigated assisted arthroplasty have a low complication rate, and that was for hip and for knee too. This is maybe a longer surgery. Well, this review from Callahan, published in the Journal of Arthroplasty, out of 3,573 cases, compared to more than 100,000 primary conventional knee replacements, they found that navigation did not increase the operative time in their series. They had no significant differences in terms of short-term readmission rate and length of stay. There is maybe more bleeding. We published in the knee in 2011 a series of patients morbidly obese over 40, And we found that actually navigation reduced the blood loss by more than 300 mils. And this more recent paper, published in 2016, concluded that the primary TKA with computer navigation was effective in reducing HB loss and blood loss, but had no effect on transfusion requirements compared to conventional primary total knee replacement. And our team, led by Mr. Nicoli, one of our consultants in the department, looked at our activity in the department before 2016, and he found that actually the two main factors who were involved in the reduction of the transfusion were first the introduction of the tranexamic acid by year 2005, and also the implementation of the enhanced recovery program by 2007. And currently our transfusion rate is around 0.4%, very low. Yes, but what about the DVTs and the Ps? Well, there is not much in the literature. This is why I'm reporting my own results. I perform between 250 and 300 knees a year, primary knee replacements. And that's my data from the Scottish Arthroplasty Project, which is the national registry between 2009 and 2016. And the blip or the glitch you see are my DVTs and Ps. And compared to the national registry, it's about a tenth of that. So the national DVT rate P is around 1%, and it's for these patients, it's 0.14%. What about the computer crash and failures? Well, it does happen, that is true, and it's very rare. And fortunately, we have a few computers, several computers in the department, so we can switch and swap immediately if we need to change it. But this is truly a possible problem. What we like the most in using the computer technology, and especially for knee replacement, is we don't have to use any intramedullary rods, neither for the tibia, nor for the femur. And the reason is because we expect to not see this big, large, round umbilus, as you see here in the heart, which has been demonstrated in the literature. So avoiding intramedullary reaming can mitigate perioperative blood loss, as I explained already, but may reduce the dissipation of marrow umbelli, and so reducing the inflammation related to that. And one of the most recent paper published in 2018, looking at two groups of patients, 44 CAS and 53 conventional knee replacement, basically showed that measuring the inflammation markers, they found that CAS TKA had a low level of inflammatory markers, maybe due to the fact that we don't use any intramedullary rod. What about alignment, which is a big hype topic at the moment? As you know, obviously, the premises of navigation was to reduce the outliers that we can get with conventional instrumentations, which are even in the best hands around 20%. And navigation can reduce this number of outliers, at least that was what was the premises, in order to reach the ideal goal. We are still wondering what is the ideal goal, mechanical alignment, anatomical alignment, kinematic alignment. But what the literature said, and that was published already for quite some times here in 2011, and all the following meta-analysis have confirmed this item. The use of navigation technology can significantly reduce the number of outliers compared to conventional instrumentation. That is true for coronal, but also sagittal alignment. So overall, the number of outliers is less than 12%, which is better than PSI and better than conventional instrumentations. And the most recent data in the literature, published in 2012, just confirmed that. We published in 2017 a series looking at more than 220 knee replacements, and we measured them using CTs, and we found less than 5% outliers. There were more variation on the femoral coronal alignments, but we had around 1% only outliers for femoral and tibial rotation. Talking about rotational alignment, it's still controversial. And I'm sure you are familiar with the work of Kim in Korea, who published this paper in 2018 in Core. He and his team reviewed an RCT performed between October 2000 and October 2002 on 296 bilateral total knee replacements using the Vector Vision CT-free brain-live navigation systems. And they reviewed more than 95% of the patients over 15 years, and they found no difference in rotational alignment of the femoral component. Their survivorship was around 99%, which is great after 15 years. And they observed at the time 4% of femoral notching. And that was the reason why they were not recommending the use of this specific system at the time, because the company has made many changes since because of the number of femoral notching. I'm sure you are familiar with the work with Kim and All, who also published in 2009 a similar series showing that he had no differences with respect to leg alignments, and he was actually one of the only one in the literature showing this. So still controversial. What about ligament balancing? This very good paper published in Journal of Arthroplasty in 2018, looking at 103 patients randomized in two groups, measure resection technique, gap balancing technique. And this Australian team found after 5 years, the resultant changes in joint line was better maintained using the gap balancing technique. However, they could not find any significant changes to function or quality of life. I'm sure you are also familiar with the work of Dr. Muleji, who published in BJJ in this year, a series showing that basically computer navigation can help a lot in not only the alignment, but also the balancing of a knee alignment. And this team from Yoon and All from Singapore, I think, looked at a navigated assisted gap balancing technique using the autopilot system. And they found that they had satisfactory short-term outcome. And finally, more recent studies based on postoperative axial radiographs of the distal femur, they found that the postoperative flexion balance was better using gap balancing than the mesure resection technique. So what about teaching? We reviewed with my good friend Jean-Yves Jenny the literature at the time, and we published this in 2017. And our conclusion was the literature did support that navigation might be an efficient teaching tool for both experienced orthopedic surgeons and trainees. And the trainees may have a better understanding of the procedure and learn standard techniques with a shorter learning curve. And this was probably due to the immediate feedback of navigation systems. But however, there was still a learning period around 20 or 30 total knee replacement, depending on the systems. The 3 papers quoted below are more recent and confirming this state of the art. What about the cost? It costs more, but navigation cost much less than robot. And that was already demonstrated in 2007 by this excellent paper from Kevin Bosick and team. And he said that computer-assisted surgery was both more effective and more expensive than the conventional systems, but conventional cost saving was achieved if the added cost of computer-assisted surgery was only 629 or less per operation. That was for navigation, not for robot. In 2009, Mike Swank confirmed that and found that using navigation, overall, it was not more expensive than the conventional instrumentation on the overall charges, the length of stay, the discharge, and using obviously the American system of Medicare and Medicaid Service National, which is specific to the US, obviously. What about the functional results, which is obviously a very important question? Well, the literature is still ambiguous, and one of the most recent paper here in 2013, looking at a meta-analysis, concluded that they were encouraged by a few recent midterm reports of functional improvement with TKA. However, at the time, they remained discouraged by the study's design flaws in the research. However, in 2014, this team from Columbia University in New York in the US looked at the image computer navigation on more than 1,314 patients in 8 different RCTs. And they found that this technology provided superior short-term functional outcomes after 2 years. And again, the same paper I already quoted earlier from Kim, he said that they had no functional outcome differences between navigated and non-navigated knee replacement. And one of the reasons probably is because obviously Kim and his teams are excellent surgeons. What about the long-term results? One of the most important and recent landmark paper is this one from Rich de Steiger, published in 2015 in JVGS. And he found that after 9 years, there was a statistical difference between computer navigated knee replacements versus conventional knee replacement. For patients less than 65 years old, the revision rate was reduced. And in order for you to understand this a little bit better, that's what they found more recently. Out of more than 600,000 total knee replacement, they found that for patients less than 65 years old, they obtain revision rate reduction by 33%. And for patients over 65 years old, the reduction was close to 25%. Is there finally differences between systems? Yes, absolutely there are. We don't have much time to talk about them, but as you know, they are image-based or image-free systems. They are using optical, EM tracking, accelerometer, passive or active technology, using pins or using screws. They are using different type of registration techniques, bone morphing, pinpoint, or the use of brushing techniques. The touch screens and pointer and foot pedals are also different kind of systems. You can interact with the machine. And also the softwares are different, especially whether you are using the measure resection technique or gap balancing technique. And finally, you can start with femur first or tibia first. I personally like to start always with tibia first because, like I said, always when you start a house, you usually start with the basement, not by the roof. And the different systems offered the possibility to combine all sorts of techniques. This is why it's very important for you to understand what is behind your computer system or your robotic system, because robots is actually just a kind of cherry on the cake, because the navigation technology, the registration are exactly the same. The only difference between navigation and robot is the robots is done by the system, whereas the navigation, the surgeon does the job. And so overall, what are the evidences in 2020? There is no more risk or complications using this technology, and there is potentially less complications. Coronal alignments and sagittal alignments are proven to be better using this technology. There is still some controversies about rotational alignment, but it seems though that conventional CT-based navigation is better for obvious reasons. Ligament balancing is improved, teaching is improved, the cost is maybe less an issue than we thought in the past, especially for CT-free navigation technology. Cost is an issue for robotic, and I'm sure the speakers later on will talk about this issue. The functional outcome seems better, but we still need to have better studies to demonstrate that. Long-term seems better. And as you may know, for example, in Australia now, the number of knee replacement performed using this technology is almost reaching 40%. And finally, there are differences between systems, and I would really recommend you, when you start using whatever systems, robotic or navigation, to understand what the system does. Because indeed, like this computer scientist said in 1970, he said, computer science is no more about computers than astronomy is about telescope. Well, you can exactly quote the same sentence, saying that orthopedic navigation is no more about computers, and that's the same for robotics, than astronomy is about telescope. This is a measuring tool, and you have to make sure that you use it well and you know what you want to do and what you can perform or not with it. Thank you very much for your attention.
Thank you, sir. Thanks a lot, sir, for a wonderful talk. Do we have Dr. Manoj Chaudhary, sir, here? No. We invite any questions from any panelists. Dr. Ashish, would you like to say a word?
Dr. Huda, can I ask a question to Dr. Picard?
Yeah,
please,
before you ask your question, I would like to congratulate you for your presentations. It was really brilliant. I really enjoyed it.
Thank you so much.
Please.
If cost is not an issue, if you had a choice between, I'm sure you like navigation more than conventional, but if you have a choice between navigation and robot, and if cost is not an issue, what would you choose for your patient?
that's a very good question. The first answer would be, when you look at the evidence out there on whether robotic is better than navigation or not, there is nothing. There are just 2 papers out there using the Omni robot named the Praxim robot, comparing the conventional and the robotic technology and the navigation, and they found that robotic seemed to be a little bit better. So today I cannot use evidence to answer that question. Now I guess you are asking me personally what I think, and
Yes.
I would say this: for very complex needs, it is interesting to have probably a pre-operative CT scans to assess very well, the morphology, the bone quality, and all the items around the knee, and potentially the use of robotic is a possibility, as long as there is soft tissue assessment during surgery that would allow me to adjust my soft tissue balancing. Because obviously, when you do your preoperative planning, you are going to define the sizes of your femur, of your tibia. But then we all know that when you assess the soft tissue balance during the knee, that may change because the gaps could be different and then the size might be different. So in other words, robot is a possibility, but for regular cases, personally, I'd rather prefer to use navigation, especially imageless navigation, because it's easier, it's straightforward, and there is no issues. The third thing I would like to mention, though, is, as you know, there are 2 different types of robots, especially in knee. There are the CT-based or image-based navigation, and the CT-free or image-free navigation, robotic, system. And then there are, at the moment, in the literature, no evidence on whether one is better than the other. So I hope I answer your question.
Thank you.
Hello?
Hello?
Ashish?
Yes, sir. Just a small question that what do you say in terms of pain? I mean, definitely what I feel that there are papers and the pain is very less in the sense because of the haptic boundaries which the robot guides us, especially in Mako. So can you enlighten us on the pain? Any studies which you have come across?
Well, most of the studies looking at the pain, especially with Mako systems, and we have a good team here in Glasgow who assessed the technology, the Mako system. They found that it seems that the pain, the early pain, is maybe reduced because obviously we can't reduce the approach of the knee, but there is no statistical difference after 6 weeks and 3 months. So in other words, maybe it's an original interesting positive factor at a very, very early stage within the first few days. But I don't think on the long term it makes any difference. And the second point I'd like to make is it also depends of the protocol you are using for early recovery. It depends of whether you use local injections, local infiltrations, whether you use an intercanal blocks. So I really think that the main factor is how you can control your pain management at a very early stage, surgically with the infiltrations, but also with your pain management team.
Sir, for coming to the AMC platform.
Oh,
I've seen
thank
you
you.
after a long time, sir.
Thank you very much, Ashish. I thank you very much for inviting me.
Yes,
thank you,
Ashish,
sir.
I think with all the bone cuts being same, whether you do conventional or navigation or robot, I think it's the soft tissues. If you are getting your cuts right and you don't have to release soft tissue, that is the area where I think you can reduce the post-op pain. Otherwise, the bone cuts are going to be the same.
Exactly. But navigation robot would be very much the same, and that we need further studies just to demonstrate that or not. But, yeah.
Sir, how is the experience of both? We were with the Google's technology, then the Mako at the Jubilee, where you're doing a large volume center.
So we are performing a lot of Mako system. We had also the CT image-free Navio system, which is the now the Smith and Nephew robot. I think we are still on our early stage, and it's we still need to collect the data and look at them. But we can say that the experience has been quite satisfying, and the surgeons who are using the different systems are happy with it. It's as you know, with the robot, it requires for the patients to have a CT scan and a team intraoperatively just to operate the system. So it's a little bit more cumbersome than an imageless navigation system. Now it's working well. We need to still collect the data, as I said, and see what it does over the next few years. You know, it's difficult to give you an answer. We still need a few years just to answer all your questions.
Actually, I think with robots, if you're planning for a mechanical axis, the X-rays look good. But if you are planning kinematic axis, sometimes the X-rays look a bit funny.
Yes, sir. But what I feel that both has got advantages, since we have both the platforms at the moment. So we just sent a paper to one of the journals in which we could manage to do supracondylar fractures, and then using the navigation platform and putting a plate and coming out in a single stage. About 6-7 cases done like that. So it will be published. It's lacking because of 4 years data. So we'll publish it soon. So, but what I feel is got like robot has got some advantages in one service, and then navigation is always image free. You have to understand what you are doing and take it from there. Actually, but planning is essentially good on city based. This is what I believe. Yes, sir.
I agree. CT based. One of the disadvantages is obviously you have to take the CT, and it's a little bit more cumbersome and it's more costly. But on the other hand, you have a lot of good information that you can use just to plan your surgery. I agree.
Yes.
But you cannot take all this information for granted. You have to still assess your knee intraoperatively, just use the numbers just to improve the quality, the overall quality of your surgical performance. But and especially on the soft tissue balancing side, because you know as you know, when you measure the gaps intraoperatively, that they might be they might change completely. You know, the overall sizing, and especially on the femur side.
Especially on the femur, yes, sir.
Yeah.
Yes, sir. Dynamic planning we have to change. I'm doing a study comparing it as well, sir.
You use the robots currently for the knee and for the hip, both, correct?
Both, yeah, and for the unique compartmental as well.
Okay, very good.
But I have the navigation striker precision as well. So we are doing a comparative study, and it depends. So, I mean, hip I am loving it more. Knees also I am loving it somehow.
Yeah.
Yes.
Very good.
And
That's great.
yes, it's
Good job.
all your teachings. Yes, the teachings and the course.
Very good. Good job. That's fantastic to see you working so well.
Dr.
I'm very
Picard,
pleased. Very pleased.
where is Kamaldeep?
Oh, he's gonna come. He's gonna come later on. he's our hip navigation guru, and so he will he will be with you later on. I think it's later on this afternoon. I think yes,
Sir.
yeah.
Yes, sir. Thank you, sir. I'll hand over the mic to Kailash, and I'll also move for the slide surgery, sir.
Yeah,
Get
over to
ready
Dr.
for the
Kailash.
same, sir. Yeah.
Okay.
Kailash,
Thank you.
I'm just logging out here. I'm logging. Stop video. Yeah.
Thank you, Ashish. Excellent session. Great day to start the AMC conference, and I really congratulate Dr. Rakesh Rajput, Dr. Frederick Picard for an extensive overview of the navigation as well as the robotics. We will move on to the next session, which is going to be about the basic parts in total hip replacement and planning, convincing, and also robotics in total hip replacement. May I invite Dr. Sahil Sanghvi, is a young total hip arthroplasty surgeon from Sancheti Hospital, and a very promising young gentleman, and he will be talking on planning in total hip replacement. Dr. Sahil Sanghvi, can we have you online?
Yes, sir. I'll just share my screen.
Yeah. Welcome, Sahil.
Thank you, sir. Is my screen visible?
Yeah. Can you switch over? Yeah, that's good.
Okay. So, good morning, good afternoon, everyone. I'll be talking about planning in a primary total hip arthroplasty and the basics of which what all we should see in a patient pre-operatively and the process of templating that we follow at our institute. So pre-operative planning essentially involves a detailed history and physical examination, a radiographic workup, pre-operative fitness, counseling, and implant selection. So when you're taking the history of the patient, it's important to note the age and the activity level, which will help you in deciding the kind of implant you want, the occupation of the patient, if there are any other joints which are involved, is your patient already using walking aids? And most important part of the preoperative planning also includes counseling your patient. The patient expectation, life expectancy, implant choices that you have in mind should match with the expectations of the patient after surgery. If a patient has any neuromuscular issues or history of substance abuse, which makes them at high risk for dislocation, it would be wiser to opt for a dual mobility, perhaps. In physical examination, we assess the gait of the patient, the ROM, and importantly, the abductor power. You assess other joints, that is the contralateral hip, ipsilateral knee, the lumbosacral spine. Limb length discrepancy should also be assessed, whether it is true or apparent, that is secondary to an adduction or an abduction deformity. And most importantly, ask the patient if they already feel a difference in both their legs. You also need to assess the pelvic tilt. Is it because of a hip pathology or a spinal pathology? And a simple way is to evaluate the patient in the sitting position. So in the sitting position, if the pelvic tilt is still present, it indicates that there is an issue with the spine of the patient. And also assess the neurovascular status. So preoperative planning, and as Benjamin Franklin said, by failing to plan, you are planning to fail. So the essence or the crux of preoperative planning is to avoid any intraoperative issues, and you don't want to be stuck on table regretting that you missed out on something preoperatively. So the goals of templating are to assess the limb length discrepancy. You want to restore the offset and the biomechanics. It is actually an estimation or an anticipation and not really a prediction of implant sizes. You want to estimate the position and the insertion depth of both the components to reproduce the hip biomechanics. And more importantly, you want to be able to anticipate potential difficulties and optimize your implant position. So the procedure of templating essentially starts by obtaining appropriate radiographs. You correct the magnification factor. You evaluate the limb length discrepancy radiographically. Then you template the acetabulum. And lastly, we template the femur. So when we obtain X-rays, We want the pelvis with both hips antero-posterior view in about 15 to 20 degrees of internal rotation and a cross-table lateral view. When we are taking the antero-posterior radiograph, we keep the height of the tube at about 100 centimeters, that is 1 meter. And the reason we keep it is because this gives you an approximately 20% magnification with the cassette 5 centimeters below the table. And as a result, this was a standard way in which X-rays were taken, because of which commercial templates have an inbuilt magnification of 20%. What you need to bear in mind is that magnification would directly be proportional to the distance between the pelvis and the film. So in obese patients, you would have an increased magnification, whereas in thin patients, you would have a lesser magnification. Thus, magnification is very subjective. So how do we navigate this problem in a conventional way? Is we use a magnification marker that is a cylindrical rod of about 100 millimeters, that is 10 centimeters, and we place it at the level of the greater trochanter in the coronal plane of the hip joint. If you position it superiorly or inferiorly, again, it will give you an inaccurate magnification. Internal rotation is done mainly so that you negate the native femoral anteversion of 15 to 20 degrees. So thus, the profile of the neck would not be parallel to the film or the cassette if you do not internally rotate the leg, and this can lead to errors in measurement. So internal rotation makes the neck parallel to the film, and it allows the entire true length to be imaged and measured. Here you can see why it's important to internally rotate, because it even affects your offset measurements. When you have an internally rotated leg, look at the distance between the center of the femoral head and the greater trochanter, which would reduce slightly more in neutral, but again, which decreases drastically in the image on the right when you have an externally rotated limb. So this is the technique that we follow using our PAC system, where we have the marker placed and we calibrate it. So we assign a measurement of 10 centimeters to this marker. Once we measure this 10 centimeters, we feed it into the system. So here you can see we are feeding a calibration value of 10 centimeters, and the system then recognizes how to magnify the X-ray. Secondly, you explain to the system the cassette size you're using, which is a 14 by 17 inch cassette here, and then you click on the true size. So then you can see that the image is automatically adjusted to give you a true size image of 100% magnification. Next, when you're taking an X-ray, you want a well-centered X-ray. In the coronal plane, you can assess this by the level of the anterior superior iliac spines or the inferior level of the SI joints, but more commonly or easily seen is the base of the teardrops and the ischial tuberosity. In the transverse plane, you can draw a line through the center of the sacrum and the coccyx, which should coincide with the pubic symphysis, and you can assess for the symmetry of your obturator foramen. Here you can see the obturator foramen are unequal in size, and the pubic symphysis is not really coinciding with the center of the sacrum. So this could lead to an error in templating, which you can avoid preoperatively by obtaining a well-centralized X-ray. Then we calculate the limb length discrepancy. So the red line or the horizontal line is the inter-teardrop line. And from there, we measure the distance to the tip, the proximal tip of the lesser trochanter, and the difference in both the sides would give us an estimation of the limb length discrepancy radiographically. Alternatively, you can even compare it to the proximal tip of the greater trochanter. And if the teardrops are not well visualized, you can go for an horizontal line through the base of the ischial tuberosity, which is the interischial line, and then again compare it to the level of the lesser trochanter. Then we proceed by templating the acetabulum first. So when we're templating the acetabulum, what we really want is to place our cup in about 40 degrees of inclination plus minus 10 and about 15 degrees of anteversion plus minus 10. However, there is newer research which concentrates on the functional safe zone, which takes into account the lumbosacral pelvic mobility. So first, while templating the acetabulum, we want to determine or define our horizontal reference line, which could be the base of the teardrops, since it's more accurate because it's closer to your center of rotation. You want your interischial line you can take, or the most distal aspect of the SI joints can also be taken in case the teardrop is not visualized well. The acetabular landmarks for placing your cup positioning. Firstly, the line that I mentioned previously goes through the base of the teardrop. Secondly, you define your Kohler's line or the ilioischial line. And thirdly, you define the superolateral margin of the acetabulum. So these are the three components which tell you how you want to place your acetabular component. So what we do is we mark a point at about 40 degrees measured with a protractor, which is about 5 millimeters lateral to the teardrop. And then we place the acetabular template at an inclination of 40 degrees. The inferior margin of your cup should coincide approximately at the level of the teardrop, and the medial border of the cup should not be medial to the lateral lip of the teardrop or the Kohler's line. So you can avoid your component being excessively medialized. You want to maximize bony containment and minimize removal of the subchondral bone. So we usually template the affected side, but if the anatomy is distorted, you can template even the normal side. While templating the femur, for the stem selection, the size should match the diameter of the femoral canal and the offset as per the patient's anatomy. For stem alignment, we place it along the long axis of the femur or parallel to it, centered in the medullary canal, and then we mark the center of rotation of the femoral head. We attempt to coincide it with the center of rotation of the acetabulum by moving it proximally or distally. If you realize it is not matching the center of the rotation, note the change, whether it's superior or inferior or medial or lateral, and then we proceed by marking the level of the osteotomy, which is the red dotted line. So when we are templating the femur, we measure 3 parameters. The first parameter is measured from the proximal tip of the lesser trochanter to the level of the osteotomy, which is the yellow vertical line you can see here. And this will give you an idea of your level of the osteotomy. Secondly, we measure the vertical offset, that is from the proximal tip of the lesser trochanter to the center of rotation of the prosthetic head, will give you an idea of the vertical offset, which will help you in selecting the size of the head accordingly. And thirdly, you can measure the width of the calcar medial to the stem at the level of the cut. So if this is shorter intraoperatively, you can suspect a varus malalignment, but if it is greater, then you could suspect a valgus malalignment. The lateral X-ray will help you evaluate the femoral bow and get your entry point right. So you want to avoid any eccentric placement, which could lead to a perforation or a fracture intraoperatively. And you can also use the lateral image for sizing your component. When we're templating the femur, again, we assess whether we're using an uncemented stem or a cemented stem. So if you're using an uncemented stem, you want to achieve a proximal fit and attain optimal contact between the lateral and medial endosteal cortex of the proximal femur. Whereas with a cemented stem, on the other hand, you would keep a space of about 2 to 3 millimeters, which would account for your cement mantle. Now, if on templating, you notice that the center of the prosthetic head is lying medial to the cup on templating, this could lead to an increase in the offset. Whereas if the center of rotation of the prosthetic head is lying lateral to that of the cup on templating, this will intraoperatively produce a decreased offset. Similarly, you can even have a superior or inferior mismatch. So if the center of the prosthetic head lies superior to that of the cup on templating, this will lead to an increase in your limb length. Whereas on the other hand, if the center of rotation of the prosthetic head lies inferior to that of the cup on templating, this would lead to a decrease in limb length post-operatively. So you move the femoral stem template vertically until the center of the head is at the same height as the planned center of rotation of your acetabular component. And then accordingly, you can plan your osteotomy level and insertion depth of the stem. You can use the DOR classification where you can type A or B, you can use an uncemented stem. But if you're going in with a type C femur, it's important to have a backup at least of a cemented stem if you're biased towards using an uncemented stem. Templating would really cause you to anticipate difficulties. Now, if you see this X-ray, we templated the cup size and it was a 42. So here the patient was counseled for a ceramic on ceramic, but the problem is that only cup sizes 44 onwards will allow you to use a ceramic on ceramic. So you can anticipate this difficulty and even counsel your patient that even though we want to use a ceramic on ceramic, we may have to opt for ceramic on poly intraoperatively. Similarly, on the stem size, if you have a narrow canal like this, you want to keep your dysplastic stems like a size 6 corail ready, which would sometimes require a special inventory as well. And you would even want to keep modular stems as a standby. Secondly, you also need to account for a pelvic inlet or outlet view. So in an inlet view, you can have an end-on visualization of the pelvic brim, which is the dotted circle in the image on the left. Whereas if it is an outlet view, you can judge it by an end-on view of the pubis. That is, the obturator foramen will be more oblique here, whereas in an inlet view, they are extremely narrow. So this will alert you to the possibility of any spinopelvic issues that a patient would have, like in an ankylosing spondylitis case, you more commonly see an outlet view. We also calculate the acetabular offset, which is marked by a baseline, which is through the interteardrop level. This horizontal line is drawn first. Secondly, we draw a perpendicular line, which is BC, which is along the lateral margin of the teardrop. And then we measure the point A, which is the center of rotation that we had marked for the acetabular component. And this distance will give you the acetabular offset. Similarly, changes in acetabular offset can affect your optimization post-operatively. If you have a decreased offset, that is excessive medialization of the acetabular component, could lead to a limp or instability, whereas increase in offset could cause a laterally positioned acetabulum, which may overload the cup. Similarly, you want to account for the femoral offset. You draw a line bisecting the canal, and then you measure the distance AB, which is your femoral offset. So if you decrease the femoral offset, this could lead to a limp or instability and dislocation, which could have increased force required by the abductors, which could lead to discomfort and easy fatigability of the patient and lead to premature wear and loosening. If you have an increased offset, you could overload the femoral stem, and this could lead to abductor pain and greater trochanteric bursitis. So you want to have your combined offset correct, that is the femoral plus the acetabular offset. Lastly, I'd just like to cover varus and valgus hips. So when you have a coxa vara, the problem is a high femoral offset, and you want to aim to restore the high offset without lengthening. So a solution here is to take a lower neck cut and have a low stem insertion position, which will allow the stem with a low neck shaft angle or a high offset stem to restore your biomechanics. You can also compensate on the acetabular side, which is the last option, and opt for a larger cup, which is positioned laterally, or a lateralized liner. In contrast, in a coxa valga, the problem is a low offset and more length. So you want to maintain the length and the offset. So here the solution is to have a higher neck cut and a shorter neck. So low offset stem with a short head, or you can even opt for a slightly more proud stem insertion to avoid shortening. You could also medialize the cup slightly here, which would again be favorable to restore the combined offset. So thus to conclude, templating hips in initial cases can be helpful to develop a precise plan. It could avoid complications by anticipating difficulties. With repetition in a systematic manner, it becomes easier and faster. And then with experience, you can see the X-ray and gauge your component positioning, sizes, and the offset. So preoperative planning is an essential part of modern day total hip arthroplasty. And with proper preoperative planning, you can improve your patient outcomes and your surgical intraoperative ease as well. Thank you.
Thank you, Sahil. That was quite an extensive and elaborate description of how you go about and plan, and a lot of doubts probably must have been cleared because of in-depth analysis and planning technique given by you. That was an excellent lecture, Sahil. Thank you so much.
Thank you, sir. Thank you.
I would like to go ahead with the program and invite our next speaker on how the most important part of any kind of surgery is not the planning, not the surgery, not the post-op, but how a patient can be made to accept that he's going to undergo a surgery, and how you convince the patient that yes, you require this kind of operation. And our very next speaker is esteemed Padma Shri Dr. RN Singh, a stalwart and a pioneer in orthopedics, as we all know, father of Dr. Ashish Singh. And may I invite Dr. RN Singh for his next lecture on convincing a patient for joint replacement in day-to-day practice. Dr. Aryan Singh, sir, please come online. Hello. Hello. Hello.
Hello. Listening?
Yeah, I can hear you, sir.
Yeah. Do you hear me?
Yes, sir.
Now, I have been giving the topic of convincing the patient for total joint replacement. It's just like being a salesman. When the product has come in the market, after a lot of research, as we have seen since this morning, a lot of lectures, that the product has been produced, its application has been described properly, but it's now time that a salesman should come and will try to convince the patient that you should have it. This is very important aspect, because unless the patients are convinced that the joint replacement is necessary for them or is essential for them, they won't get it done. Because obviously, if you go there, that once you have to make the patient, convince the patient that what is this disease, why this joint replacement has evolutionized so much, and why this is necessary today in this world, that every person should think about knee replacement or hip replacement if their joint goes wrong or joint gets arthritic. So arthritis is one condition which affects hundreds and millions of people worldwide, because it's a degenerative condition. Whenever you buy a car, once the car gets old, there's some part of it gets damaged or needs replacement, or sometimes it needs throwing out and buying a new car. But we cannot do that in our body. Therefore, we must realize the fact that how does this arthritis affect the millions of people worldwide, and accounts for huge burden of pain, the functional limitations, loss of productivity, disability, and loss of quality adjusted life expectancy. Now, what happens if a person is getting joint pain, he doesn't want to move because of the pain. His daily activities, ADL is affected. He cannot sleep in the night. And ultimately what happens that he cries for his pain and takes a lot of painkillers, which ultimately affects his other organs of the body. Therefore, this is a huge burden for any national health organization or even the private sector. It is very difficult to be managed. So the incidence of TKR and THR for OA is increasing. I mean, because of the degeneration that is taking place, because of the age expectation is going higher, and therefore these osteoarthritic changes are there more and more. More than 6-fold increase expected by 2030 in the US itself. And this is by this reference. Now, if you see this, it has been said that the total joint replacement does not bring years to life, but it brings life to years. This was said by Lomander. Now, why this is so? Because once you are crippled with joint problems, if you are crippled with pain, you may not move, and therefore, whatever expectation of your life is, it becomes frustration. Therefore, if you improve that, if you get the patient pain-free, it gives them the life, and that but brings the life to years. This is what is to be made to understand. This particular thing has to be understood by the patient itself. Now, I'm not going in the scenario of US or UK or other parts of the world. What I'm trying to say about the present scenario in Indian health. What's the problem here? That the age is advancing, no problem. First of all, the average age was 60, now it is more than 70. And a lot of people are getting arthritic problems. But the problem is that the Indian scenario, health system is different. And that is what I'm saying, that what is there that it comes to science and technology, India is rising at unbelievable heights. But in the fields of healthcare, and large portion of Indian population is still not aware of the health emerging issues. Because of the unawareness and ignorance is an issue. And this particular unawareness and ignorance has to be taken care of before we make them to understand what is the need of these new developments in orthopedics. Now, issues. What are the issues? Poverty is the much and reality in India, illiteracy, and then unawareness. Now, what are the key considerations that we can have? The first is the limited resources. The second is lack of education, lack of awareness, and then the budget. And after the budget, patient can arrange money, everything. Then the fear in their back of mind is the concept that it may not work. After spending so much money, the whole thing cannot work. Now, I have gone through that particular era whenever I used to tell people that yes, you should get knee replacement, they used to tell me, when the Prime Minister's knee could not be all right, then how can you suggest and tell that my new knee will be all right? So it was a great problem for us to convince them that even if Prime Minister was replaced with the knee, he had no pain after the operation. He may not have that particular mobility, but he did have a relief of pain. This is what is more important. And this concept of failure has to be eradicated from the patient's mind, and they must be understood that yes, failure takes place in anything. Even today, we had a mission for going to moon, and we failed at the end of it. So that does not mean that we will not try. But this is what has to be, patient has to be convinced about. And then the patient, when it comes to the market, he's lost. Somebody says that go there, go there. Somebody says, no idea, I'm not sure, I'm uncertain, I do not know what to do, I really too much of distance. So the patient is lost. Here comes the role of a good counselor, who should make understand the patient that yes, this particular surgery or this particular method is the best method for the treatment. Wherever you go and you want to get it done, you must get it done. Now, awareness. That's why awareness is very important. Patient education. Now, there are a lot of patients in our practice who comes for the knee replacement. They are there. They are convinced. But they say that I'll get it done in 1 year or 2 years, and I'm trying to manage money and this and that. Their patient must be made to understand, must be educated that if you are delaying it, if the joint is getting more mechanically rearranged, then the treatment will be difficult. And if there is a lot of osteoporosis, the ground on which you are going to make your house is not good, then ultimately the result will not be good. Therefore, patients' education, make them understand that how important it is to get it done as soon as possible is very important. And awareness through media or radio, awareness through press, these are important things that the joint replacement should be done. But then it comes to the in Indian scenario, it's very difficult because health organizations in private or in public, it's not very important for them to have this joint replacement done. Then there are so many other issues to be taken care of. Therefore, the joint replacement awareness programs by media or radio on a government basis not possible, rather very difficult. But on the private issues, on the other party, it can be done. Because awareness through press and media is very important. And then it is very important to realize that word of mouth means that somebody has done one good knee replacement, and if he walks home, his other patients who see that this is good result has been there, then obviously they are convinced that they could get this. At our centers, we normally what we do, that at a certain interval, we arrange a seminar type of thing. We get all those patients who are expecting to have their knee replacements. They are at the borderline whether I should get the operation done or not. We call them. And then there is a group of patients who have already had the replacement. We call them too. And then we make them understand, and we can interact with the patients who had already got the operation done. And then they develop confidence that yes, this is a good operation, and the patient who is not able to walk, they can now go to the market, they can drive cars, and ultimately, so their word of mouth is very important, and you must be able to convince the patient on that line. Then mass awareness programs, wherever there is a good operation done and the patients are, so there are press media and others, you can do that. Now, awareness camps necessary where you can make patients understand, And there are certain days like World Arthritis Day, we had a march and we make patients aware of the fact that what is important, why it is important, because there are so many comorbidities that develop once the patient is not able to walk and they are bedridden and they are house arrested. Then in that situation, we must make them understand through this public awareness programs so that they can get the benefit of the advantage or benefit of the surgery that we are having in our area. Now here I come with the counseling. It's very important to make the patient understand what we are going to do. The models, the outcome from the different patients, they should talk, give them telephone numbers of the different patients who have got the operation done. They can talk to each other, they can find out. They should develop the confidence that the things are being done. Then you must tell them that what are the advantages or the developments that we have and what are the latest technology that we have got to get a best result out of this operation. So counseling is very important, and counseling is actually the work of the activity of the counselor or the professional who counsels people, especially on the personal problems and difficulties. Every patient has got his own problem. Suppose a patient of rheumatoid arthritis has got a very bad knees, and she cannot or he cannot walk out of the room, and is very difficult life to lead. Now she is a patient of age only 30 or 35. If I suggest them that, all right, you get the knee replacement done, at least you will be able to have a pain-less joint, you can move out of the house, you will have to continue the anti-rheumatic drugs, but your knee will get better, then you can make your social life, sex lives, and other part of the activities that you can have in a better way. Then age is no consideration. A lot of people ask us that at this age, how can I get this knee replacement done? I'm only 34 or 35. There's a patient of 25 years old with a bad hip, with advanced ankylosing spondylitis. Their life is crippled. But if I suggest them that now get the hip replacement done, whatever life you have, you will have a life. So this is what is very important, to make them understand every patient's own difficulties and make them feel that like a personal physician, you are trying to convince them why it is important. Now, patient education. To create a discrepancy between the regions and against change, it is paramount that the patient reaches the conclusion on their own accord with guidance. This is very important. We must make the patient understand that if you have got the knee replacement done or hip replacement done, you cannot squat, you should avoid squatting, you should avoid sitting on the ground. There are some patients who sit there, but I must tell them that if you are going to do these activities, your joint replacement life will be reduced. You may do it, but your life will be reduced. Therefore, if you buy a new car, if you drive on a good road, it will be good for the many years. But if you buy a new car and drive on a village road where there is no road as such, then obviously the car will go wrong within 1 or 2 years. So this is what has to be made understand. The patient has to be made to understand. And then, what are the patient's priorities? Now, a lot of questions. First of all is the prolongation of implant. Bhai, kitna din ye jod rahega? Now, there have been so many discussions we have heard from this morning that how this whole thing has developed. We make them understand that it's now we have got the experience of total knee and total hip expectancy for more than 30 years. And so that is what is the matter of convincing the patient. Then comfort, potential complications. This is very important to make them understand that there are complications. And whenever a patient comes to me and tells me I'm very fearful of the operation, then I tell them, go along in the outdoor, and there are hundreds of patients sitting. Find out a man who is not fearful of any operation, including me. So fear of complications is there for everybody. And it is the counselors or the professionals' role to make them understand that fearfulness is important, but in this particular condition, these are the priorities that we take care of, and there is no such chance. But still, there is chance of potential complications, so you must make them understand. Then what about pain? Post-operative pain, kitna rahega? A lot of people say that it will be very painful. Then you can always convince them that yes, any operative post-operative patients of abdominal operation or any other operation, they do have post-operative pain. And likewise, this is the mobility pain. I mean, post-operative pain you will have. As far as the mobility is concerned, a lot of people ask that how long I'm going to be on bed, how long I cannot go to the toilet. Now, today, with this advantages or advancement of orthopedics and this MECO arm assisted surgery, we make them patient and stand the same day or very next day. They can go to the toilet even. So these are the things that patient needs to be told about, and ultimately they should get convinced. Now, quality of life. Now, make them understand that there are certain limitations, but the overall quality of life is very good and better than what you have today. But not last but not the least is the cost. Every patient wants to know how much it's going to cost. Now, if in Indian scenario, we buy a machine and tell them that this is the normal operation charge, and with this machine, if I do, it's going to be this much of charge, extra charge you are going to have, then patients will be financial limitations, they will say that I could get this one. But what we are trying, or what we should try, is to make the patient comfortable and make them understand that these new developments is going to help them, and ultimately it's not going to cost them much. So this is very important. Then ultimately, the last thing which I must say, you must make them understand with the models how it is done. It is not the joint replacement. It's not like that, cut the joint, throw it away and put another joint in it. No, it's the resurfacing of the joints, and both in the hip and knee cases, and make them with the pictures, with the models, make them understand what you are really going to do in that patient. Now, joint models, implants, and how do they work, explain about the procedure time, importantly, understand the expectations. Most important, what is the expectation of patient? If you have got a patient who has got bad knee on one side and very good knee on the other side because of the post-traumatic degeneration. Now, if you do them good surgery also, but there is a 5% of pain, he will compare with the normal side and will say that, no, sir, it is not like this one. There you have to make them understand that, yes, we are operating it, we are going to replace it, but we have some difference between the two. So what is their expectation, and make them understand. It's not, you should not come forward to say that, no, you'll be 100% all right. You must tell them that there are certain limitations, but you will be much, much better, maybe as good as the other side, but you will have improvement. And be frank what you can offer. Don't be unrealistic. If you are unrealistic to a patient, you make them understand big things, and if it doesn't come out, then that particular patient will be a very good, big obstacle for you in your practice, and ultimately they will not allow any other patient to get it done because of the fact that he has not got the things done according to his expectations. So make the patient what you can do, make patient what you cannot do, and prior to surgery, the patient and the physician should discuss the complications that may arise as a result of surgery, and discuss each complication one by one, pros and cons with the patient. And how do we discuss the complications? Throw a ball in the patient's court, involve the patient, and then expect how to talk to them. For example, infection. Now, what about infection? A lot of people ask questions, infection ho jayega to kya hoga? Then we always say that John Charlie has said, we're still, however, a long way from the agreement on what most basic of all questions, whether post-operative infection is acquired in the operating room or not. Now, in Indian scenario, the number of attendants, number of visitors and others, they lead to this sort of problem, but all is attributed to the surgeon's side, not to the patient's side. And then good operating room and quality of operation theater is very important, and that also convinces the patients very well. And then cleaning of hands, you must make them understand that these are the things that we are going to take care, and you must make some pamphlets which patients should get, and they should go home, they should study that. When there were any complications, any questions, they can come back. Never be hesitant to talk to them twice or thrice Wherever they want, you can discuss, you can make them understand what they are not understanding. But at the same time, I must say, for example, do not forget to get the consent. If you are going to, the patient is ready, that they are going to operate, you must get the patient within 24 hours prior to the surgery. Not that 10 days ago you have taken the consent and today you are going to operate upon. No. And it should be always bilingual. So that the patient may not be able to say that, yes, because you know the judicial system is here so much that there is a lot of advocates will be there in between you and the patient. And therefore, it should be very much important to have a bilingual consent to make them understand that, yes, preoperatively you have been told about all this. Now, one thing I must say in my experience, that arthroplasty surgery is not to be sold by a doctor. It must not be sold by a doctor. It has to be bought by the patient. Because if the patient has got too much of pain, their life is, and your body, they cannot work, then they will himself come and say, Doctor Sahab, kuch kar dijiye, to get my pain off, relief. Because I cannot walk, I cannot go to the toilet, I cannot sleep, my night sleep is disturbed. So please get it done. So make them, convince them, but at the same time, you should always be in this, you have got a thin line there, that you must not sell the surgery. Let the patient buy it. Like a good salesman, you keep it on the counter and let the patient decide that yes, he is going to buy. That is very important. And there are certain supportive counseling exercises, the physiotherapists and booklets and pamphlets that we say. And ultimately, you must say that you are their lifeline, we are your helpline. That is very important. Take-home message will be, the complete care program must be explained to the patient. Together, everybody achieve more. It's a teamwork. And that team, everybody should make understand. The physiotherapist, the other persons of the team, the counselor, everybody must discuss with the patient everything, and then only they can be more convinced. Especially care coordinators should be there. Pre-operative total joint education class should be taken. If you have got good practice and cases are to be taken, 3-4 cases, then all of them sit in a seminar room, discuss with them jointly. They should discuss with each other, find out the problems, and be true, not and realistic, but not promise to the patient that you will get everything all right. So thank you very much for patient hearing. Any questions? Thank you.
Thank you, Dr. Arun Singh, sir. That was quite an interesting lecture by you, and a lot of pearls of wisdom shared during that lecture, how to convince a patient. May I invite our next speaker, Dr. Thadi Mohan, to speak on preoperative planning in robotic platform. Dr. Thadi Mohan, are you there?
Yes. Can you see my screen?
No, I can't yet see your screen. Yeah.
Okay now?
Yes.
At the outset, good morning to everybody. Oh, is it good afternoon? And thank you, Dr. Kailash. Thank you, Dr. Ashish Singh and Dr. Arun Singh for giving me this opportunity. My talk today is on preoperative planning in total hip replacement with the robotic platform. And I am a clinical professor at Amrita Institute of Medical Sciences. My name is Thadi Mohan. This is Amrita Institute of Medical Sciences in Kochi, Kerala. You can see it's got plenty of greenery and backwaters, and all of you are welcome to visit Kerala and Amrita. Amrita has got an advanced center for robotic surgery, and we have the ROSA and the Da Vinci for many years now, and CyberKnife more recently. And that's how the Mako robotic system for arthroplasty also came in. We got it in 2017. We first got the total hip and partial knee software, and in 2018 we got the total knee software. Incidentally, sorry, my slides seem to be moving. Incidentally, the Mako robot is named after this shark, which is commonly found in the Florida waters where the original company is located, the Mako company. And I'm happy to say we were the first in India to acquire the Mako robotic system. It's an extensive platform, helps us to do total hip, total knee, and partial knee replacements. It has got the main robot as well as the Mako camera stand and a guidance card, which is part of the whole system, which has to come into the operation theater when we are doing any robotic case. And an interesting development I wanted to share with you, this is a 50-year-old male bilateral OA, probably due to dysplasia, and I just did a bilateral simultaneous total hip replacement 2 days ago, thanks to the Mako robot. It's probably the first robotic bilateral simultaneous hip replacement in India, which is exciting to know. So the 3D pelvic reconstruction is the basic premise on which the whole replacement is done. It's a digital bony model, as you know, and all patients undergoing robotic surgery have to have a CT scan according to the protocol. These takes a few minutes. It's not very difficult. 1 mm slices are taken, images uploaded, and based on the images, a personalized 3D reconstruction of the pelvis is done. So every patient has his unique 3D reconstruction done. At present, the pre-planning is being done in Hong Kong and USA, so it takes 3 to 5 days. So CT scan has to be done at least a week in advance before the robotic replacement. What are the advantages of CT-based planning? We know from several papers that CT scan is superior to plain X-rays in component size selection, accurate determination of the 3D angles. It's highly accurate in restoring the hip rotation center and femoral offset, which are very crucial to placing, the acetabular cup precisely. And these are the angles which can be accurately determined by a 3D CT as inclination, anteversion of the native acetabulum, inclination, anteversion of the planned cup, the femoral anteversion angle, the planned stem anteversion, and something called CCD, which is really the central column diphysial angle. As you can see on this image on the right, it is an angle between the neck and the shaft, really. So here we have 3 situations where there is obviously a varus neck here at 145 degrees, a neutral neck angle at 128, and a varus neck angle or CCD at 119 degrees. We have to be beware of these situations. Most of the patients we know are quite suitable, but in these conditions, such as a large bony defect, there is a difficulty in cup installation, and robotic planning is not always successful with big bony defects. A fused hip is also difficult if you have to establish a hip model. If you can see a little bit of the joint, that's very useful. But having said that, there is a situation as in Ang's Pond where in addition to fused hip, you also have a fused spine. And that I find, the Mako robotic system is still not versatile in telling you, in giving you the perfect angle or anteversion if there is a spinopelvic deformity. I believe Stryker is working on that, and in the next version of the Mako, that will be addressed as well. That will be very useful. Large periarticular osteophytes will affect precision of the intra-bone registration. So that is one situation where you have to be careful. And bilateral hip disease, as I noticed when we did this case, you don't have a control site to compare with. It's easier if you have done one side and then you are trying to match that on the other side. A small video which shows the 3D planning. So this is how a 3D model of patient's hip looks like after the CT scans. I'll try to reduce the volume here. Yes, what you can see here is the default inclination of the cup, and the default version of the cup is 40 degrees and 20 degrees respectively. So 40-20 is something which the planning is also done. Most of the plannings are done at 40-20. Of course, you can always change it. Now, what this superior, medial, posterior is telling you is how much you have to place it superiorly, or how much you have to place the cup medially or posteriorly. So now, how did they decide that? Now, that is decided based on three cuts, basically: the transverse, sagittal, and the coronal views. So in these cuts, as you can see, the 3D model can be moved around, and you can decide how well your cup is seated, whether there's adequate coverage, whether there's adequate bone stock, and ultimately what we are trying to achieve here is place the cup in the most adequate position. Another important thing is when you plan a cup, usually it is placed in accordance with the patient's original cup size. So in a coronal view, the acetabular cup is selected according to the patient's original size. I told you about the default position, and you can move it. The surgeon can finally, if he's not happy with the position, you can move it vertically, mediolaterally, and superior inferiorly. The transverse view also, you're ensuring adequate coverage, and whether there is too much overhang, then you can move it inwards, and whether the shell has been medialized to the bottom of the acetabulum, that also you can get a very, very good view. I mean, that is how the CT scan gives you a very versatile idea of a three-dimensional idea of how your cup is going to look. So much so that even before you have actually done the surgery, you can get a pre-op X-ray to view how the cup position will look once you have done the surgery. This is how your cup is going to look. And that green dot is the center of the cup. And this is the reaming view, which tells you that this much of the bone will be removed when you actually ream the acetabulum. So all the green will be reamed away, and it will turn into white. So that is how you know that you have reamed it adequately. And I'm sure my subsequent speaker will be talking about that. So it tells you whether you're reaming adequately, whether you're reaming outside the boundaries. So it gives you a very safe idea of the plan even before you have actually started the surgery, which is very reassuring. And coming to the femoral stem planning, that also, just like my previous speaker, Sahil, has spoken about templating, this is all done computerized, and you can actually decide on the femoral stem size, femoral offset, femoral head size very accurately. You have to make sure that the implant is centered inside the femoral cortices. There are two kinds of workflows here on the Mako system. One is called the express workflow, which is what most of the surgeons follow because it's much more easier and faster. The enhanced workflow involves putting some more arrays on the femur, but though it's more cumbersome, it gives you more information with regard to, it gives you a guide to the neck resection level, the broach version, combined anteversion, combined offset, and the reduced leg length. So again, a short video of how we are looking at the CT scan pre-op. Here you can see the stem. We are seating it adequately within the canal. The version is, of course, you can decide on it, but in this case, the pathology did not warrant any change in version. So we are looking at how the stem, whether it is fitting within the bone adequately. You can play with the stem sizes. So here you can see there is a stem size 6. If you change it to 7, it will change then the neck length, etc. That may not be conducive for you. You may find that your offset has increased. So we go back to 6, and we find that by doing that, we are not lengthening the hip, and offset is also maintained. So that is how stem size can be decided upon. So in all, it's a very versatile system which allows the surgeon also to make plans on an individual basis. So finally, the reduced implant planning shows in a 3D mode how the total hip will look once it has been done, and you have an X-ray mode also, which gives you a pre-op X-ray as to how the replacement will look. And based on this, you can decide if you're happy with the final plan, and then you can go ahead. So a couple of cases. One is a Nigerian 28-year-old male, bilateral hip involvement. Left is worse. He had shortening pre-op of 1 centimeter, and so we planned his cup position and stem so that it could be the shortening could be minimized. I think finally we ended up with 2 millimeter longer limb length on the final position. It was 2 millimeter longer, and offset was just almost equal. So this is a bilateral avian in a 41-year-old male who had undergone core decompression in the past, and the one side was replaced using a manual method, and we did robotic on the left side, as you can see. So gradually we have tried various indications, inflammatory indications as well. So here's a steroid-induced avian in a SLE nephritis, 26-year-old female, and fairly straightforward hip replacement. This is a policeman at 48 years old, secondary OA, again robotic. It's helped us equalize his limb length and give him a perfect hip. This is a more complicated one where you have a protrusion in a 62-year-old male that has been well planned out, and a good hip has been given. And gradually we have gone into slightly more complicated cases with limb length discrepancy here, 3.2 centimeter limb length discrepancy in a dysplastic hip, probably old birth weight, and it has been equalized thanks to Beko planning. And a more difficult case, a 4.5 centimeter LLD in a 33-year-old Pro 3 female patient, and we managed to get the hip limb lengths equal. So in other words, Beko pre-planning ensures that the cup placement is always in a safe zone. You can see on the left side, the robotic hips are all in the safe zone, whereas on the right side, conventional total hips, there are a lot of outliers. There's a good paper on this by Seth Jerabek of the Hospital for Special Surgery in New York, where he has said that robotic total hip provides excellent accuracy and precision with regard to planned cup position, hip length, and offset. We had the unique opportunity of meeting up with him and spending some valuable moments. And I just want to share with you my journey in this. Thomas Kuhn is one of the pioneers in robotic surgery, Yogesh Mittal and Ross Crawford. They have all been our mentors and proctors during this journey. I must not forget the role of the makeup product specialist. In this photograph, you can see Sharad Bajpai, who's been with us right from the beginning. You cannot start a robotic case without the MPS or the makeup product specialist, very crucial. They discuss all the cases with the surgeon, and the plans are discussed pre-op, maybe the previous day or sometimes just before, half an hour before the surgery actually starts. They are responsible for setting up the robot and moving it into position and inputting all the technical data throughout the steps. And they're also responsible for training the OT staff, for which I'm very grateful. And that's me with the Make Robot, and that's my certificate, which I value. Thank you very much.
Thank you, Dr. Thadimohan. That was a great lecture, and we've heard Dr. Sahil Sanghvi speak on the manual way of doing it, and Dr. Thadimohan speaking on how to do it robotic. I would like to move further on as we are reaching the live surgery session quite soon. And I would like to invite Dr. Sushil Singh for his lecture on Mako Total Hip Review. Surgical steps, bone registration, case planning, and execution on the video platform. Dr. Sushil Singh, may I have you online? Dr. Sushil Singh? Hello?
Yes, sir. Hello?
Yeah, can you
Hello?
hear me?
Yes, sir. Thank you, Dr. Kailash Patil, sir.
Yes.
Thank you. Just I start with my topics on surgical steps in robotic surgery.
Yes.
Yes. Just a minute.
Can Dr. Singh?
Yes, sir.
Can you share the screen? Yeah, that's good.
Just a minute, sir.
Yeah, no problem.
Yeah. Hello.
Yes.
Good afternoon to all of you. I'm just discussing the surgical steps according to the Mako Robotics, and I'm Dr. Sushil Singh, consultant orthopedic surgeon in Anup Hospital, and I just thank to Dr. Ashish Singh who is giving me the opportunity to be a part of his team and a part of the AIUR. And we start with the AMC in orthoplasty. What we want from the orthoplasty, we want with the accuracy of positioning of the implants. We want for confidence and reproducibility and flexibility of the patient. And what is the surgical treatment for the hip orthoplasty? As we all know, with the previous discussion, we have the conventional or we have the next generations like navigation and robotics. So we come with the total hip replacement. There is the conventional method for total hip replacement traditionally. Then we come one step ahead with the navigation, and we have latest advance with the robotic surgery. Now, what is the difference? The why to achieve and adopt the new tradition when old tradition is doing fine? Because we are going to be gradually change with anything, with the implant, with the techniques, and uh, with the advancement in orthoplasty. The total hip replacement is done over 30 millions every years, dramatically reduce the disability of the patient, and provide the happy and pain-free life, and patient to be returned early to his activity. Modern joint replacement Modern joint replacement technique will provide early weight bearing mobilization of the post-operatively 6 to 8 hours, and patient feel less pain post-operatively, and patient most of the patient going home within 72 hours, and patient take less physiotherapy, and he continue with his daily activity. The technology come in action in recently. The problem with initially the problem with hip orthoplasty was either dislocation, either leg length discrepancy, either impingement, either early loosening, or polythene wear. All are due to malpositioning of the implants. So in recent traditions, we achieve a stable, well functioning joint with well balanced tissue, so which is last longer to the patient and give pain free life to the patient. The hello.
Yes, we can hear you.
Yeah. For this, we distribute this for taking the good outcome. We take a component fixation well, the well bearing surfaces, and we compensate the leg length discrepancy, offset, center of rotation, orientation of the cups. The component fixation is the surgeon choice, and bearing surface what we use. Either we use with the ceramics, either we use with the steel. Leg length discrepancy, offset, and center of rotation, orientation of cup or femur. These are the most important parts, which is take care in robotic platform in intraoperative period. So complication are everywhere. Everywhere can we do better with like dislocation, leg length discrepancy, component loosening, and bursitis of pain. So solution for these is come in action to the robot. The there is a comparison between robotics and conventional. We all fulfill with the robotics, but less thing we fulfill in the conventional. Like leg length discrepancy, we check it in intraoperatively, anteversion, retroversion, combined offset, preoperative implant planning, intraoperative measurements, and radiographic measurements. All we are seeing intraoperative period. This is the positioning of implant. In we plan preoperatively and do intraoperatively with robotics. All are come in living safe zone, but we do in conventional method. This is the scatter diagram, which shows in measurement of leg length discrepancy preoperatively, planned and postoperatively. We use a guide pin here, trochanter, and we use a uh, the combined offset and version. We calculate the combined offset of the we calculate the combined offset, either acetabular offset and femoral offset intraoperatively, and also we compare the version. To understand all these things, we to understand all these, we needed to understand workflow of THA. The workflow of THA will start with the Mako robotics. The part of robot was a cutting system, Rio robotic arm, camera, and guidance modules. The first we do with the registration of 3D model capture before the surgery by 3D CT, then patient specific planning done with the robots, and wound preparation done with robotic arms. The first step was to plan and broach the femoral stem. Second step to combine and calculate the anteversion assessment, intraoperatively placement of the cup, and robotic intraoperative cup planning and robotic cup placements, and quantify the surgical report after completing the total hip replacement. Preoperative planning, we defined cup size, liner type, head size, stem offset, and acetabular size. We all are calculating these things preoperatively with the help of 3D CT. The acetabular planning, we in acetabular planning we calculate the in acetabular planning we saw here is 3D model intraoperatively, and we calculate the size, orientation of cup, inclination of cup, version of cup, medialization, superior migration, or the medialization of cup. We all calculate intraoperatively, just like just saw this arrow shows you in this video. This is the transverse plane we used to see intraoperatively, and go with the sagittal plane, and also we go with the coronal plane. All three plane we saw the placement and orientation of the cup. The cup was placed exactly in position, not overhanging superiorly or inferiorly, not breaching the medial wall. Then we stem planning, preoperative planning. We also see the position of the stem in all three planes, and with the femoral version we calculated, and these all things are you see in intraoperatively before we doing the surgery. And this is the planning landmarks, the placement of the trochanteric array, and uh, placement of the array at the knee, and pelvic array for verification of acetabulum, and acetabular checkpoints, cup reaming, femoral preparation, and trial reduction results. Patient position and approach. It is very important to ascertain the patient position. Ideally, at this time, the operating surgeon should assure himself that the patient is ideally placed. The layout of the OT room, there is a patients lying down the lateral decubitus position. There is a robot, there is the camera, and we place array here to transfer the data to the camera. Pelvic array placement. Just I show the video. To place the pelvic array at iliac crest, at the anterior side of the iliac crest. Just insert the pin and second pin and place the array, who give the data to the pelvic area to robot. Then surgical approaches. There is freedom to do you do any approaches, either posterior, lateral, or anterior. But Dr. Ashish was doing here is a posterolateral approach. So make the mark over the trochanter, take the incision line. Then after completing the incision, we place the checkpoint over the trochanter, anterolateral part of the trochanter. Is a femoral checkpoint. Then measurement of leg length by doing the femoral checking the femoral checkpoint and checkpoint over the knee. Then we place the acetabular checkpoint at the superior part of the acetabulum and give the data to the robot. Then finally we dislocate the neck, dislocate the head of femur and cut it as previously planned. Then expose the acetabulum at 360-degree overview. Acetabular registration was started. Just here, we give the registry to the acetabulum by this point and bony registration by the blue points. This is the intraoperative matching. This is the registry of bone on the acetabulum. Then the robot, after giving the data to robot, and then robot come in, robot arm help to assess the reaming of this area. And we have the pre-operative decided angle 42-20, and we create intraoperatively we match the data here to exact that point and we do the reaming. Then impaction of the acetabular component. After complete reaming, there is a robotic arm you saw in 3D model, and impaction was done by hammering this portion after proper positioning of the acetabulum. This is the pre-operative data. Here is the post intraoperative. Then robotic guidance, visual feedback, green, white, and red. You ream the green area, not going to white and red, because tactile feedback and audible feedback is given by the robot to prevent the cutting of the normal bone or go beyond the haptic boundary. After placement of the acetabular component, then we re-verify these things. The checking of the impaction result, re-verification of the position of the acetabulum component. You verify at 360-degree, and finally you got a result here. And combined antiversion assessment, femoral antiversion is around to 10 to 15 degrees. Acetabular cup version was the combined antiversion male is 25 to 45 degrees range, female is 30 to 50 degree in range. Then we go with the stem preparation. After cutting the neck, we use a broach to broach the femoral canal and posterolaterally. And we have the predefined stem size, as Dr. Thadiman sir was discussed previously. Preoperatively, we have assessed the size of a stem, and then we broach at that level and put the stem after that. This is the enhanced version for checking the femoral component and doing the This is the cutting area which is guided by the robot. Is the array. You check this area predefined for the neck cut, and this is the implant positioning, and we re-verify it by placing the neck. There is a combined NT version, and this is the final positioning of the implant and with the plan, and we have actually find it. So pre-operative and post-operative data we compare intraoperatively after implantation, and there is other points we discuss in spinopelvic dysfunction. These points discussed in a later topic by Dr. Ashish Singh. And what is the navigation versus robotics? The difference is navigation is the guidance system, intraoperative feedback, navigation surgery, surgeon performed and controlled. Robotic surgery, perioperative 3D planning, which is more accurate than X-rays. And the type of robot is active robot, so driven itself, autopilot robot. Semi-active haptic is the Mako, which is defined boundary, surgeon still in control, but robot strict for the surgeon's error. Some results and review of the literatures shows the accuracy and study of cup orientation, as you previously saw in a graph. Accuracy and study of anti-version, just accuracy and study of anti-version in femur and acetabulum, or combined anti-version. More accuracy we found on femoral version and stem version or acetabular version in robotics as compared to the conventional. More accuracy in computer navigation and advanced robotics. So this is the accuracy. Bone preservation. The result may suggest greater preservation of the bone stock using robotic THA compared with the conventional THA. This may reflect increased precision during the reaming process. The functional outcome, Bukowski et al.'s paper on showing on 2016. The outcome study, Patel et al. And Geop Robotics and Component as a Surgery, 2018. References, we have some references regarding the robotic orthoplasty is comparatively more precise and more more accurate. The conclusion is why then we are still using traditional conventional technique despite all the evidence. If you are a patient, what would you choose your surgeon to do? 60 to 70% accuracy or more than 95%? Timing in technology adaptation. Advanced technology adaptation take a time. And this is our data for time from registration to the impaction of vestibular component. On an average, 20 minutes, 15 minutes, 20 minutes, 20 minutes, 35 minutes. So change is always a law. We all adopt the change. It is coming already and happening in some surgical procedure. Progress is inevitable. Technology is here to stay. This is a case of ankylosed hip, fused hip, 23-year-old gentleman, and perform a surgery, mobilize 8 hours after surgery, full bed bearing mobilization. Only the form will change and become smaller than with the time. Nature's law, those who embrace the change will survive, those who don't will press retired. Hello? Hello?
Hello.
Hello.
Yes, sir, we can hear you.
Yeah. So that was a good discussion. Can you hear me now?
Yes, sir. Yes, sir.
Yeah, that was a
My
good
video.
demonstration of how you go about the Mako robot. And we end this session with a good note with excellent lectures by Dr. Sahil Singh, Dr. Aryan Singh, Dr. Thadi Mohan, and Dr. Sushil Singh. That was an complete overview of how you go about planning a total hip replacement, right, up to doing a total hip replacement with a robot and going through all the finer points and details of how you go about it. Thank you, all of the panelists and speakers. What I would like to move on to the next session, which is a live surgery session.
Yes,
And
sir. Yes, sir. Thank you, sir.
yeah. So, hello.
Yes, sir. Yes, sir. We move on live surgery, sir.
We'll move on to the live surgery session.
Yes.
So,
Sir.
can you take us to the theater?
Yes, sir. Just a minute, sir.
Hi, good afternoon. I'm Dr. Rakesh Aulia, one of the coordinators in this live surgery session. So let's hope we get, I will be doing this along with here and Dr. Johan Prince. I see he is also here. Excellent. Yeah, hi. So we are just waiting for the live streaming of the from those who are, and Prince or Dr. Maldev, would you like to add something on?
Yes, good afternoon, everyone. I've been listening to the last session, very interesting, and good to see you, Rakesh. And unfortunately, Mr. Sarungi is not able to join us. He's got a busy on call going on, so he sends his apologies. So without the delay, I can start with the
My
live
voice
surgery.
loud and clear?
And Dr. Prince, can you add something if you want to?
At the moment, nothing. It's very, very interesting. It seems to be the way of the future. From my side, welcome from South
हम लोग का आवाज
Africa.
वहाँ जा रहा
Hello,
है क्या?
boss.
जा रहा है, हम
Boss,
लोग clear है.
and well
Please
done for
confirm,
putting
or
this all together and
I'm
teaching
not
us a
able to
bit
hear
more.
their voice.
Ashish, we are here and we can see you very well. We are listening to your voice. Hopefully, you would be able to listen our talks in between. Are you able to listen to us? Yes.
Yeah.
Yeah.
Yeah, excellent, excellent.
Good.
So may I take over the mic, please?
So I, along with Dr. Kamal and Dr. Hi, pardon me? Are you with me?
Yes, sir.
Ashish, yeah. So I, along with Dr. Kamal and Dr. Johan, are here. And Dr. Rakesh Rajput is also live with us. Just go ahead and tell us something about what are you planning to do and what things are there.
Yes, sir. First of all, focus on me. Sir, we at AIOR are doing a live robotic hip replacement surgery, and the patient is a 49 years old gentleman who has presented about 2.5 months ago with a fractured intracapsular neck of femur fractures. Due to COVID pandemic, he was hesitant to getting surgery, and we have scheduled. So the basic thing in a Mako surgery is, first of all, we'll introduce to our team. We have a head end, Dr. Anu Narayan ma'am, Dr. Shailesh, Dr. Purushottam, this is Avinash, and myself. So our Anu Narayan ma'am is the lead. I mean, she's the head end lead. And I will just show you the planning which we have done and where far we have reached. So can you show the planning software?
Can you show the screen?
Yeah, show that screen. So is my voice clear? So we are we have planned for a 52 with a 32 head and a stem size 4. So basically, when you talk of the MECO, the city-based planning, the surgery essentially starts before the surgery begins in the CT scan. And we know, and we do a dynamic planning of what we are going to get and then add over the table what we do. So I have just opened and exposed the acetabulum. That was done because we are running 15 minutes late. So I thought that will be the point. Approach does not matter. I approach with posterior, I approach with direct anterior and the anterolateral as well. I have been taught by all the my gurus who are there on the dais, Dr. Kamal Deep, Martin Sarangi sir, and everybody. So with the robot, actually what happens, you have to give a 3D coordinate to the computer and the computer combines it with the CT scan. So segmentation of the CT scan is done. So here is the plan, and actually this is the post-op X-ray which we'll get, which you can see on the screen. So as Dr. Sushil sir directly explained you what have we done. So first I have in this case used a posterior approach, more versed with it. Now I exposed the acetabulum. The first part was to put the pelvic array. Please zoom on this. As shown by Dr. This is the pelvic array, and this captures signals to that screen, the Polaris camera, which is there. And then things are transmitted from here to there. And now we will go with, we plan the leg length, and there was a discrepancy which we can see. And at the same time, now we will, as in any computer assisted surgery, we need to give the coordinates to the computer. And I'll show you how we go in the hip, and we'll take it from there. Any questions up till now?
Ashish, many of the delegates who are online may have not seen this robotic surgery. Just half a minute, what is there or who are set, where do you place and how do you go ahead so that people come have a very good.
First of all,
Just zoom
this is
out and
the
show
MECO
it to them.
robot. This is, it's roughly to the height of my chest.
Just zoom out and show it to them where you place it that people are, because they should know what you are doing. If they are not aware of the OT setup.
Okay, so yes, OT setup is very important. So here is the robot. I like coming the robot from the opposite side. That is your choice, the surgeon's choice. Then we have the MECO product specialist, and he is there to help us because this is an FDA approved real robot. So you need a person who is FDA approved trainee. This training cannot be done in India. So this is the robotic arm, and actually we do it, it's under guidance. People have the temperament that you sit on the computer and the robot will execute. No, it's not like that. But you have to feed the coordinate to the computer, and then the computer will guide you. The CT is matched. It is seen on the screen. If you want to go ahead, you can see on any screen. And this arm can be interchanged with a saw, can be interchanged with a burr, and it is a robust arm actually, what I'll tell you. And you have everything in front of you, 5 steps ahead, and you have so many things so that you give the best. So I will show you now. May I now proceed to the registration, sir?
Yes, sure.
Thank you, sir. These are the MECO instruments. I mean, there's nothing much except the robot and some stuff, but rest are the hip instruments. So let's focus. I'll keep my head apart and we'll be very slow so that everybody gets a chance. So we have done the leg length discrepancy test, and we have put markers as shown by Dr. Sushil, one in the greater trochanter and one on the supralateral part of the acetabulum. That is for the matching. And now we'll confirm the pelvic array and take it from there. Pelvic confirmation.
Pelvic array.
Should
Detector. Detector.
Just a second, sir. Yes. So now I'm giving data capture. We re-verify it. Capture. Sorry. Yes. Yeah, done. Now
So this is
can see
basically the
screen.
pelvic
Yeah. So
pin
now
that
you can
we
see the screen that
confirm
we have
again.
the 3D model assimilation of the CT pelvis of the patient. But as Kamaldeep will be knowing better and making the people understand, for any system to work, you need to give the computer the data. So how are we giving it? I'll show you now in just 5 minutes.
Absolutely. Ashish, you can carry on with the surgery as well, and we can keep explaining things. Yeah.
Yes, yes. So just a proper exposure of the acetabulum. The basic rule of acetabulum exposure is it should be 360-degree visible. And I hope you're not happy. We're happy with the acetabulum. So now I will take the probe
Yes,
and mark
it's
accordingly.
good.
Posterior? Huh? Do it from that.
Hold this.
Just keep on doing. So focus on this.
Yes,
I'll
it
move ahead.
all
Go ahead.
looks good. One of the things is that around the vestibular margin, we need to be very clear.
Capture.
The capsule needs to be taken off a little bit so that we can go to the outer margin of the acetabulum, where you will be doing the matching points.
Capture.
Just
Capture.
focus here. Don't focus on me.
Capture.
And focus on that screen.
Capture.
Focus on that screen.
Capture. 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 Okay. Capture. Capture.
So while we are doing these points, capturing, the initial 3 blue points are very, very important, and they have to be pre-planned with your representative.
Capture. 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 Capture.
Screen and either.
Capture.
So Ashish, I usually plan with the ants where the initial 3 points are going to be in the notch or ridges rather than just on the plain surface.
Yes, sir.
Because they determine your accuracy.
Capture.
Yes, sir.
Capture. Capture. वहां से
Yes, capture. 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 Capture, please. Capture. Capture. Capture.
So at the moment, Ashish is matching the anatomy to the CT with the pre-plan. You also have
okay.
Capture. So foot pedal is an alternative that you can press the foot pedal and you can just register the point yourself.
Capture. Capture. Capture.
Yeah. Match blue.
You're okay with it? Okay.
Okay. Go ahead.
Works. Leave it.
Just focus on the screen.
So this process of matching has to be within 0.5 millimeters of matching of the CT accuracy and your intraoperative accuracy. You don't make any gross mistakes, and the robot
I'll
knows
take a
exactly
pause.
where you are.
Sir, may I take a pause for a while and explain you what we have done? So
sure, Ashish. Yeah.
In the meantime, we'll roll the robot in. So the first step which we did.
Good, Ashish. Thank you.
First step which we did was that we matched the CT scan, and then the second, the blue dots were the matching with the first was registration, second was with the matching with the CT scan, that is in the range of 0.05 mm. And the third thing here in the Mako is to rim. You can rim directly with, we are on the 52 cup. And the best thing which we like to tell, roll the robot in. So you can see the robotic arm is coming, and we are with the robotic arm, and it goes inside, and you can focus on the screen, and one on this part. Huh. So probe, Shailesh, I will just verify the robot. Done. Yes. So see, now, sir, Martin sir, may I Kamal sir, may I like to explain you that I'd like to request you to explain that what do we see on the screen, green, blue, and everything, so that you can explain in a better way.
Yes.
So you can
Yes.
take a wide angle view and show how the robot is placed and we're matching with the actual and planned. So we had planned 40, 20, but now we are arranging it that the robot does not allow us to go out of the boundary, haptic boundary, and we are on the 52. Any comments, sir, Dr. Kamal, sir?
Yeah, no, excellent. That's going very well, Ashish. And
maybe proceed.
As you said, off. So go slowly with the reaming, and the robot itself will prevent the boundaries. As you can see here, the green is gone and the white is remaining. So basically that's your reaming done. Now, would normally do is use two sizes of reamers. First, one size lesser, and the second, the final size. It's useful in the hard bone.
Is okay?
But with soft bone, you can go directly. So that looks good, Ashish.
और होगा कुछ और होगा
Reaming और होगा.
चल लीजिए आ जाओ go ahead.
Have we
Yeah, we are just doing it. We interior नहीं हुआ. Go for interior. 20 20 20 44 को तुम हाँ. Yeah, go for it. बस छोड़ गया वापिस आ जाओ. Yeah, can you focus on me? Now, Purusham, take care of that. We can show the stablum. So, I mean, this
I'm
is
not sure if there's a way of increasing the size of this operative screen like we do with a PowerPoint presentation.
Sir, you can see the
On
screen
this
now,
camera
yeah.
only.
Now you can see this.
Yeah.
You can see the ribbing.
Yeah.
So with one single thing, we are ready. Get the cup 52.
Get the cup 52.
I am happy with the stuff.
Now look up them. Straight impactor. Straight impactor. 52
Just
size
focus
cup.
on me and the screen. So you can see this on the screen that we have rimmed it, and we are we have tried to make it like it's about we had planned the distance away from the teardrop, and we are using a trident hemispherical cup. So that is we rimmed.
Yeah.
Focus here. Focus here. This cup gets fitted on the robotic arm.
So with a trident hemispherical, I would normally ream a millimeter lesser than the real size.
I
Especially with
do
the
2
porodic
mm
bone.
lesser, sir.
But you can ream with a whatever size
rimmer
you're
हम
comfortable
मैंने
with, choice.
ये जल्दी देखा last rimmer है.
We are just loading the cup holding arm onto the robotic arm.
Manual. You can see how it is being fitted. Show there.
Yeah.
50. Wait. See how it is fitted. It's not the robot that is doing it. You should understand. focus on that, the robotic arm. Either. Go ahead. Clean it. All set?
Confirm the point and the robotic arm with your tracker and place the cup inside.
Can you focus on the screen, because it will show you that how much outside we are. Not now.
Lockdown.
Yeah,
Okay.
yeah. Lock कर दी.
So the arm has now locked it into the pre-planned orientation.
Yes. Now, if we move this, the robotic arm will move.
Yeah.
Impaction.
Yeah, yeah.
Huh.
Go. Just focus here. You see on the screen?
Yeah. When we are going with the hammer, it can be 1 or 2 millimeter proud on the readings. I would leave it to 1 millimeter proud, but not more than that. Medially with the arm so that it actually sits properly. Sometimes the cup can be a little bit proud and the periphery has already held it. So to seat it, initial positioning is very, very important when you bring the arm in, that you go to the medial inferior point and then hammer it in rather than start hammering from the top. What do you think, Dr. Prince?
Yes, I agree with you there, Mr. Deep. Just a question here for the uninitiated as well. Does when they are reaming, with the robotic arm, does the robotic arm prevent overzealous reaming so that you don't break out medially into the pelvis? Does it do that, or is it still surgeon dependent?
We'll wait for 2 minutes.
Especially in your very osteoporotic bone, because there's always a danger, specifically if your medial wall is very thin. Does the robotic arm prevent overzealous reaming?
Sir, we have done with the impaction. So I'll show you the cup once, focus it in a good way. This is the cup which has been impacted. And now we will do the calculations, whether it is how much we have done corrected. So can you do it?
Yeah.
Just focus here, I'll remove my head. Capture?
Capture.
Yeah, I will get it right.
Capture. Capture.
So, Dr. Prince, going back to your question, yes.
Thank you, sir.
It does prevent you doing overzealous reaming because the color on the screen turns red as soon as you are beyond 0.5 millimeter of your depth.
Dr. Kamal sir,
fantastic.
Sorry to interrupt.
No, it's all right. Yeah.
Sir, you can see on the screen that we have achieved a version of 23, inclination of 40. We had planned inclination of 40 and a version of 23 degrees, but it is 1 mm proud, as you directly told, and which at this point of time, to all the surgeons and to all the doctors who are looking here, you have to check it with your thumb whether the cup is fixed or not. Generally, if you feel the bone is good, the cup is well seated, you should not put a screw, because when you do studies later or take out the cup, there is maximum sclerosis around the screw. And in Golden Jubilee, we had without holes any established cup. And here we are given with the cluster holes. So this is done. I am happy with the cup. We can confirm the inclination and the version of 40 and 23 degrees. And now I'm on with an X3 polyliner with the final impaction already done. We are not going to put screws. And yeah.
Yeah, so we were saying the kind of feedback. One is the like visual feedback with a color turning red. Other is haptic feedback as well. You feel the resistance.
That's on the arm.
When you try to read anywhere else.
Probe.
Yeah.
Anything,
Thank you,
anything
Mr.
to
Deep.
point, anything to point. Yeah. We check with the this instrument whether it is fixed or not. And secondly, if you can see here, Kotri, please. Kotri. You can see here, this is the TAL. I'll show it with you with this is the TAL and this is parallel. So according to Beverland et al. Study from Ireland, your cup should be parallel to the TAL. If it is too inserted, it is put deeper. If it is outside, then you have not done medial ribbing. And in this case, with robotic guidance, with our own intellect, we are able to achieve a documented things, and you can see the TAL. So this is the very important thing which needs to be focused. Here down at 6 o'clock, you see the TAL. The robotic placement you can see on the plane. The good part is that if you move your hand either other, I mean up and down, the body moves. For example, when the patient is not been fixed and the patient goes droops anterior or posterior, the robotic arm will also go posterior and anterior so that you don't go wrong. And it will not rim apart from the haptic boundary, which is predetermined. So you not very bound to go wrong. Second thing is that what is very important here is that it has got a free arm system. And in the free arm system, you take the smaller reamers, get your version and inclination, and go there. I mean, but in this case, we did the direct 52 number reamer, 50 rimmed, and generally I keep 2 millimeter less and go for the trident. But it is according to the experience and the bone quality. It is never like it is the rule which is given in the book. Because if you go for Corel Pinnacle, it is line to line rimming. If you go for Merrill, it is line to line rimming. But you have to see the quality of the bone and take it from there, which will come by experience. Now, in this case, we have used the express system to do this case. You have the enhanced version and you have the spinopelvic disruption, that is the new system version 4, in which you have the pelvic tilt features, which Kamal sir and I will also show some x-rays in which we converted a ankylosed hips, couple of ankylosed hips with the robotic platform. But let me go with the stem. So, and in the meantime, I hand the mic over to Kamal sir, my Guruji, and we'll take it from there. All yours, sir. I'm going for the stem, which is going manual.
Thank you, Ashish.
Yes, sir.
Very well done. That's good. Now, as versions, express version and enhanced version. In the enhanced version, we can actually do the femur first. So do the rasping of the femur first. Then we record where the antiversion of the femur is, and we can actually dial in our cup antiversion accordingly. So if the femur is retroverted, very anti, change the cup antiversion before we start reaming it. So that's an advantage of the enhanced version. Yes, you are. So Ashish is now he's doing the express version, in which we do mainly the acetabular reaming of the robot and placement. Plus, you can get the leg length and offset points, one on the trochanter and one on the knee where you put the ECG dot. You do that pre-op as well as once you've done your so that you are in the identical position, and it gives you the change in the leg length and offset. The enhanced version is it gives you the anti-version as well as the neck cut, where you should be putting the neck cut in order to adjust your leg length and offset. Any Rakesh? You want to put any points?
Absolutely, you are doing it very nicely. Nothing more to put in. They are almost doing it perfectly.
Minus.
Minus.
We are on the standard.
Yeah. So
ये क्या zero दिया ना?
doing the trial now, which is good.
हाँ?
In there.
ये क्या दिया है?
Size क्या मिला? 0.
This
So
is the
one thing, robot is
And zero
okay
है?
with the uncemented as well as the cemented versions. So you can use the Accolade or you can use them as well.
So 0.5 will be prodded, right? Because coating will be there. 0.5, 0.5, 1 mm coating will be there. 1 to 2 mm. We have planned 3 and 4, right? 4 and 3, 1 mm coating. We are all good. No problem. एक मिनट सब करो.
Hook.
सब.
Right, Ashish. So after reduction of
yes, sir.
there is the leg and offset.
Yes, sir.
Are you
Sir,
in the region where you have planned?
Yeah. Actually, I'll show you now because I am on with the original size 4 implant. So here I will just take till the implant open. I will just show talk to you for a while. Now, initially we have a paper in which we plan things and write it. So for the stem, we were on 4
wait.
and we were on 4.
We
After
should
doing
go
that,
5. We'll go 5.
happy. Nikalo. Breathing
Okay.
space. So size 4, please.
Size
So-
4 stem.
Yes, we did the leg length matching and the offset on the table with the size 4 with the trial. So we are on size 4. We planned for 52. We put a standard trial which was planned and we are happy. So going into put a size 4 and we'll be on a 0. But I'll do a trial again after putting the stem and trial with the minus cup and go out with the final. But I am actually, I'll just wear a new pair of gloves.
Yes, that's right. Important to feel your clinical situation as well. So stem size usually goes the same, but the neck size can actually vary.
Yes, sir.
Although the robot has told you with a pre-plan.
No, but
the
neck angle and neck size
clinical
both
feel
can
is
vary.
important.
So 4. This is 127.
Yeah. 0. Last one. Yeah.
127. We have put the trial final stem. This is the trial which we get, which the robot tell. But now I'll see. One thing is navigation, one thing is robot. But at the end of the day, it is your brain and your experience. Shucks test, very important. Shucks test, flexion like this. Put your 2 fingers. Are you able to see me? Put your 2 fingers. Feel the tension. If you start feeling the tension when you are assisting somebody, then you will understand how much tension you have to give. Then it has to be checked in flexion, something like this, something like this. So it's not going out. So this is what we have achieved. Shucks test happy. Clinically, I'm happy with the coplanar test.
Coplanar test.
And leg length, which will.
Ashish, just show how do you check the leg length. And
Yes, we are doing it. So now we have put it on 90 degree. We have got a probe here. Yeah.
Yeah, show it, and also show the screen on your navigation screen on half of yours.
Capture, please. And then we have a mark here. I'll teach you both the methods of doing the normal. But first I'll show you the remove. Now first thing to match the leg length is put both feet in a vivid flex position, match the heel. Show this one. Heel should be parallel and then you put your arm here. So clinically by this, you can feel the
Yes.
leg lengths are equal. That is your clinical aspect. But even if the leg lengths are longer and shorter, and if you feel that yes, the hip is stable in that, being it longer, or if you put it a longer head or something like that, you will increase the, it won't be reducible. Go for increase or decrease in
Minus
leg
also.
length, and stability is important. In this case, clinically, I feel the leg lengths are apparently equal, but let's focus on the robot. When we focused on the robot,
We'll check with the original implant also.
uh,
We'll check with the original implant
yeah,
also.
we'll change with the, we'll put with the original implants and do it. Bone hook.
Suck.
Okay.
Wait.
We have to use a, if everything
So
is
the
right.
positioning of the leg is important when you are looking at the second point. It has to be the same position of the leg which you registered when you started your surgery.
Final implant, -4.
-4. Final implant. Yes.
So the femoral implant is in, and the next size you're going to put it is -4 now, is it, Ashish?
You have to, at this point, you have to make sure the acetabulum is cleared. You do not have any bone spicules or cement inside, because that will give third body wear. Apart from using and everything, important thing is clinical judgment. And then,
Yeah, it's important to keep your clinical brain open all the time. Robot is fine, but clinically you have to check the things you normally do, even in the conventional.
we'll give you the robotic calculation in 2 minutes. Clinically, I'm fine.
Yeah.
Capture, please. Leg at 90°.
Okay.
So it's V-bit 5 millimeter, but it is very stable. See, it is stable like this. So I'm happy with this, because it is more important to have a stable hip rather than anything. So actually the case is over. So
And
we'll do
question
with the
answer you will
closure
do
and
answer.
discussion with the MPS, and we have the robot. We can show you for people. See, a lot of viewers are there. There is a hesitation. What is robot and what all things? It's like a Robocop, or it's something like Iron Man. So it's not like that. So I think Kamal sir, can you take it from here? I am just standing for questions.
Stand here.
Yes.
Yes,
Thank
sir.
you, Ashish.
Camera that side.
Well done,
Total
Ashish.
operating time was 45 minutes.
Ask any questions from the audience.
45 minutes we completed the total hip replacement.
Kamal sir, good afternoon.
Just
Hi
10
Rakesh, how are you?
Fine, thank you. Since we last met, I have lost hair and you've grown longer.
So do you have any comments, Rakesh?
Yeah, I do have some questions. Yeah. So I've not actually done robot for the hip, but I've done it for the knee. I do have, Ashish. One, you said about putting a marker over the superior lateral acetabulum, one on the trochanter. But if you have these two markers only, you have a lot of stress being placed on the same position of the limb, which is actually critical. Or is there the circumference which you've done of the acetabulum also helps you for the leg length pre-op and post-op determination? That's number one question. And number two question is that because you are stressing now so much, because you have such a big tool with you on the leg length and the offset, but you have a limitation with the implants. They don't come with varieties of offsets. So in trying to match the leg length and offset, sometimes do you feel that you would want to actually change the company and put some other company's implant rather than the company which is on table with you? Or preoperatively you determine that you want to go switch the company actually? So I think both these questions, Kamal, you can probably answer these closing.
Okay. As far and the trochanter, these are verification point pins that you're talking about. So these are just to make sure that the
checkpoint
the checkpoint has not moved, and we can go back and again check that you are within that 0.5 millimeter boundary of the registration of the anatomy. In the Express software, the entry point also has one of the points for the leg length and offset measurement. So there's one trochanteric point and one ECG lead at the knee. So you can cross-refer both of them, and automatically calculates the coordinates and gives you the leg length and offset change. So that's the main 2 points. As per the change of implant, do any change of implant, and I haven't heard any other surgeons who've used Mako as well. And the reason is because of the pre-op planning. Because on the CT, you actually plan and offset, so it usually fits very well with your pre-op planning. So you don't have any gross deficiencies during the surgery. You don't find that it's too loose or it's too tight. And the reason is just because of your pre-op planning. I hope that answers. Is that all the questions were? Yeah.
No, I just heard a talk actually by another very famous surgeon who actually changes his implants based on his pre-op planning. He chooses the company. So I was thinking whether what does the Mako guys do?
May I pitch in for a while, sir?
Yes,
Yeah,
Ashish.
Ashish.
Sir, actually, in the enhanced planning, we do the femoral stem planning first because there is nothing known as the target region. I mean, everybody has got a different establer antiversion, which according to paper by Archibald ranges from 20 to 30 actually, and on the basis of which Mr. Beverland actually wrote his TAL differentiation. So, I mean, we plan the stem first and plan the estabulum then, and do a combined antiversion like 40, 42, 30 to 40 is the range. So, in the next version, that is the version 4, which I'll show you in my talk, you can see on table the flexion, extension, impingement, sitting position, how the X-ray will look, and is it impinging or not. Depending on that, you have variations in the antiversion or the of the femur or the stem or the leg length or whatever you want. Now the good thing in that is that they have combined with pelvic tilt because this is a very big platform, and one question is always asked that how do you manage your version in ankylosed hip, how do you manage your version in stiff hip or post fusion hip spine which has been fused. So in those cases and in pelvic tilt, pelvic slope. So now in the next year ASAP, the version 4, which might be in England as well. In the version 4, we calculate the spinopelvic tilt and all the X-rays and do some calculation. And on this screen, we have even in enhanced, we see the flexion extension. Where is it going to impinge? Everything you see it so that you can change, so that results are better. That's what I think.
Yes, absolutely correct. With the enhanced version, you can see the anti-version and dial in your cup anti-version as we were discussing previously. Any more comments, questions?
Just from my side, gentlemen, Ashish, well done. Excellent work there and good discussion. What has become abundantly clear throughout the discussion around the operation is that there is no substitute yet for good clinical experience. So if you are going to rely on your computer system, doesn't matter what system that you will be using, be mindful of the fact that you had good training, that you are still a doctor, you're not a machine. So you have to bring in your clinical judgment every step of the way. And that starts by doing the pre-op planning as well. And if the pre-op planning doesn't fit in with what you want, go back and do it again, I think. because at the end of the day, it is still your patient and your handiwork, and you need to be absolutely happy with that. Doesn't matter what the computer tells you. And that is what Ashish did intraoperatively as well, and all the other commentators also commented on. So well done, Ashish.
No, before we take anything, we should discuss something on the planning. Can you focus on the screen? So we will show in details how planning is done, because if you talk to anybody, failing to plan is planning to fail. So we take the X-rays. That is, as Dr. Sushil sir said, he is also here. He can come in the. Ajay. So we do the planning. So by planning means that we know everything, and now do the established planning. So we have the cup. We can see how where it is being seated. So we want to have approximately distance from the teardrop. So we plan how much we have to medialize or keep it lateralized. If we want to keep the cup inferior or superior, we plan everything. Same thing happens in the broach. Show us the broach. So the broach also, this is the knife which makes a mark. In this case, it was 1.8 mm. So we calculated and we cut it. But point is that we calculated it and then matched it, and then we are a bit more confident that yes, you should not go to 6. It could be 4 or 5, but not 6. Next is this one, X-ray view. The X-ray view, if you have confusion in CT problem, then you do X-ray view and then match everything like we do in the ortho view software. And then the post-op X-ray, you show the post-op X-ray. So this is the post-op X-ray which will be coming like this, according to the plan. So before going in, we are quite sure. So planning is important. And when you have more advanced planning with the enhanced or the version 4 spinopelvic dysfunction, you anticipate more problems, you are more cautious. At the end of the day, we want to give everlasting hip, not a long lasting, like you say, everlasting youth cream. It's everlasting hip. And believe me, all patients are mobilizing within 6 hours. Average 6 to 7 hours, full weight bearing, day 1 stair climbing, and day 3 going home in COVID times. So that is what we have got achieved, and the confidence is given by technology. I'm not saying it's Mako, but any technology, if you assimilate, things are getting better. What I believe, and I have been taught by Mr. Kamal Deep sir, Dr. Frederick Picard, and all the other teachers, and we have to adopt. Everybody is using Google and applications, so I think it's the way to go ahead. Thank you.
Actually, hello.
Yes, sir.
Thank you, Ashish.
Sir, we miss you here. Actually, Kamaldeep sir. We miss you here in Patna. Rajkumar sir and Johan sir.
Thank you.
Next year we'll meet again. That's for sure.
In March, we'll do something on knees.
Well, hopefully,
I see Dr. John.
Corona would have
Question from
we
Dr. John,
person
sir.
association. That's the best.
No, I've just joined, so
Yeah,
okay.
we are about to invite Dr. John for his next talk.
Okay, that's pretty good timing. Actually,
Good afternoon. Yeah.
webinar I was in before was really running very late, so I just got out of it. Okay, I'm glad to know that things seem to be running on time here.
Are you happy? Stay.
So tell me when you want me to start. I'll start.
No. Do you have any questions, John? For
well, I've just joined in, so it's a bit difficult to come in at this time. But I think essentially, I think these are all tools to help you improve your eventually, hopefully, to improve your clinical results, because I think there's a lot of evidence to show that you may get your alignment better, etc. But eventually, it's the clinical results that we need to look at to show that it's really making a difference in our management.
Sure, sir. Now you can start with your topic of lecture. Kamal, should we ask Dr. John to start with his lecture?
Yes.
Yeah.
You can first start by saying, how is he looking so lean and thin?
Yes, I think.
Thank you, guys.
Well, I had
Thank you
actually
very much.
lost some more weight, but the last month or so things have got busy.
Share it.
Yeah, I'm just starting it. So actually, I have put on some weight again. not going as good as it was earlier. Okay, so I'm going to keep this fairly brief, hopefully. I think we're looking at robotic assisted arthroplasty and how it's going to help us as orthopedic surgeons. And what we need to be aware of is that if you look at the USA, every year it's around 700,000 total knee replacements a year, and it's increasing at almost 10% a year. So you can think of the phenomenal numbers of knee replacements being done, but the overall satisfaction rates with total knee replacements in various studies. I think there's some background sound from somewhere. Can we?
उधर में कहाँ बैठने हैं? हाँ?
Okay, so the satisfaction rates are still in various studies not above 90%, and even with the newer designs of knees, etc., this has not increased significantly. So I think we know that the use of artificial intelligence is rapidly growing in every field, not just of medicine, but healthcare is no exception. We know that navigation has been used for many years, and although a lot of these studies have shown benefits in alignment, there's no clear evidence in clinical results. So the question is, can robotic surgery show definite advantages in terms of clinical results and an improvement in the longevity of our total joint replacements? So how do we define a robot? I think starting right at that is, if you look at the definition by the Robot Institute of America, it's a reprogrammable multifunctional manipulator designed to move material, parts, tools, or specialized devices through various program motions for the performance of a variety of tasks. Or if you look at the Webster dictionary, it calls it an automatic device that performs functions normally ascribed to humans, or a machine in the form of a human. So I think all of you are familiar with the robots that we've seen in various films, etc. But what is the application in orthopedic surgery? I think the idea is that it should allow surgeons to more dexterously manipulate surgical instruments, but the surgeon should eventually be controlling the instruments with either directly or through joysticks and telemanipulators. So this should be what we aim to achieve. Now, if you look at computer-assisted surgery, categories. One is computer-assisted navigation, which we've had for some years now. Then in the robotic surgery, you have fully automated active robotic systems, which perform autonomous movements under indirect supervision of the user. So you can actually work it remotely. And then you have the semi-active robot-assisted technologies, which require the surgeon directly to be handling the tools, but you have more sort of, the robot has control over what you're doing in terms of precision. And then you have simulations systems, which are really used for medical training. So you can really divide it into these four categories, and you can classify them based on different factors. You can place them on the level of function. There's the passive type, which really guides the surgeon through fixation and cutting block resection stages, but the actual cutting is done by the surgeon. And the active types, where the robot is actually doing the cutting as well. And then you have the semi-active types, which are somewhere in between. And you can classify them based on whether they are image-guided or image-free systems. You also have other classifications like the autonomous system, the haptic system, or passive surgical system. So there are various ways you can classify these robotic systems. And the difference between the image-guided and image-free, I think both of them do require CT for the planning, but the image-guided ones, you are relying on the CT images to actually help you with the cutting of the bone and doing it on the basis of your images, while the image-free ones is that you do not need additional radiation or CT during surgery. So you get the anatomical registration points intraoperatively, and you have a database of knee CT scans in which the knee position, cutting, jigs, etc. are positioned. So that's the basic difference between the image-guided and the image-free systems. The steps that you would take in robotic-assisted total knee replacements would be preoperative cutting, preoperative creating a patient-specific model in image-based systems, intraoperatively registering the patient to create a final model, and then using robotic assistance to make your bone cuts and carry out the procedures. Now, going through briefly the history of robotics really started from DeWall in Louisville, Kentucky. This was the Unimate sort of robotic system. And then eventually the father of robotics, Joseph Engelberger, acquired the modified DeWall's robot into an industrial robot, formed a company called the Unimation in 1960. In 1985, Puma 560 was the first robotic surgical system created, which allowed CT-guided precise neurosurgical biopsies. And in 2000, the FDA improved the first robotic surgical system, the Da Vinci surgical system. And this is still used, especially in things like prostatic tumor surgery, etc., in that region, where it's really, I think, an area where it's got the maximum utility if you look at where robotics have been used in surgery in general. When you had the Casper system, was an early autonomous system. It was used for total hips and total knees, which was similar to RoboDoc. And the initial results focused on mechanical access of the long leg during total knee replacement. These less advanced robotics clearly showed that robotics can have a potential to there were some problems which often led to more risks than their benefits. And therefore, these kind of fell into disrepute. You then had this RoboDoc solution for total hip replacements in 1992. And gradually, I think the system started getting refined, and the first RoboDoc total knee procedures were performed by Professor Martin Borner in Germany. Okay, so what were the results of these studies which showed that there were satisfactory bone cuts for cementless implantments of both tibia and femur in 76%. The alignment of knee was restored to a planned ideal mechanical axis with 0% error in 97%, but they were still unable to show any difference in patient-reported outcome measures. Okay, they did take a slightly longer time. The initial average time was 25 minutes longer. They also required increased time for planning, registration, and milling. So the increase in operative time could be considered as a potential risk factor for increased risk of infection. We then had the Acrobot, which is the active constraint robot from London. And this utilized CT-based software to accurately plan total knee replacements. This was a non-invasive anatomical method that was used. There was active constraint control, limiting motion to a predefined region and allowing the surgeon to safely resect bone to accept a total knee prosthesis with high precision. I think this company was acquired by Stanmore Implants Worldwide in 2010. And then finally, Mako Surgical acquired the assets as part of a confidential patent infringement settlement in 2013. So this is how the Mako system came into being. And there are some other systems like which are successfully have been used in clinical setting, the Navio PFS, which is the Smith & Nephew system, the iBlock robotic cutting guide, which is OmniLife Science, the Mako robotic system, which is now with Stryker, and the Rosa knee robot system with Zimmer. So you had this evolution in the robotic systems, which have generally gradually improved the performance of these advancements in science and artificial intelligence to the total joint replacements. I think there are some other robotic systems which are used and some newer ones which are now being used for spinal applications such as MesoX, etc. So there's a huge variety of these systems gradually coming into being. Okay, so looking at the Mako system, this is a haptic system available for compartment knee replacement, total hip replacement, and total knee replacements. It is an image-based system, CT for preoperative and intraoperative planning and adjustment for component size, position, bone resection, and haptic feedback during resection to prevent bone resection outside the desired plan. Okay, so the advantage over manual techniques, it overcomes technical challenges, it increased accuracy in placing of your tibial components, it decreases the learning curve with traditional instrumentation, improved outcomes have been shown with cruciate preserving robotic assisted bicompartmental arthroplasty, and although this is early days, possibly reduced revision rates with the Mako assisted unicompartmental knee arthroplasties. So I think the components you've probably been through already in the introduction to the surgery. So you have the robotic arm, the camera stand, the guidance module, there are different softwares which are available, the instrumentation, again, the balancing kits, the power system, the attachment kits, the positioning for the legs, and the sterile disposable. So these are all components which you require for the system to work. And you have the integrated cutting system. The total knee application utilizes this Mako integrated cutting system. It powers a saw blade specifically designed for Mako platform. You need 3D planning capabilities of the system. You need to be, it allows you to predictably reproduce an intended surgical plan, and thus provides safety and precision in your surgery. And some of the things we've been able to achieve come from these studies where you get better limb alignment, better flexion extension gap, and also being able to manipulate and fine tune your bone cuts accurately. Okay, so all these achievements have been sort of possible with the use of this robotic systems. Okay, I think, but eventually it is the survival and the clinical results which become more important, as I mentioned, because the total knee replacement numbers are steadily increasing, and then the revisions increase as well. We have an aging population, and therefore we will have an increasing need for these replacements, with people being more sort of aware and more desirous of continuing to be mobile even into their later years in life. And therefore, proper component alignment, rotational position, soft tissue balancing are all going to be critical factors in determining the implant survival. So even though you may not have enough clinical studies to show an advantage, one has to assume that if you get everything right in terms of alignment and soft tissue balancing, hopefully these knees will do better and last longer. So I think the advantages which are there with it include reduced post-operative pain, less blood loss, increased precision for more accuracy. You can eliminate human error to an extent. You get a faster recovery, shorter hospital stay, which then should hopefully lead to a lesser risk of infection and possibly a greater range of motion. However, there are some limitations. I think cost is definitely a factor, especially in a country such as ours. Also, the training may be expensive. They still take a bit longer, but I think this is something which will improve with time once, as with navigation, once people got more used to it, the amount of time that you needed extra reduces. So we still don't have systems which are directly able to perform soft tissue balancing, and the surgeon must still retract the soft tissue, or you can have damage to the soft tissue in the planned path of resections. So eventually, these systems are still only as good as the data which is provided to them, and therefore, if your registration isn't correct, you will end up with problems and could result in disasters. I think the future is definitely there for robotics in healthcare. I think you have to have innovations that simplify the process and minimize the learning curve. You need to have systems which rely on CT. We currently have systems which rely on CT, but hopefully the next step would be to go beyond imaging to appreciate the kinematics of the operative joint before it is altered by the pathology of arthritis. You will hopefully have navigation guided retractors. You may have streamlining of the operating theaters, therefore reducing operative time. And eventually, you may need less staff involved in doing the surgery so that they can be freed up for more pressing matters. So eventually the question is, will robots replace surgeons? Not yet. Might be in the future, we don't know. The robot doesn't yet control the scalpel. Technology is still a long way from delivering totally autonomous surgical robots. However, I think learning machine is changing medicine in ways that will affect surgeons and in ways which we would only be imagining 10 years ago. So I think also you need to carefully define what a robot and robotic tools are. Majority of studies so far have shown that computer-assisted navigation improve alignment. As I said, controversy still remains in terms of improved, whether this improved alignment leads to additional clinical benefit. So I think there are some studies which show some improvement in terms of definitely in terms of the alignment, but in terms of actual clinical outcomes and scores, we really need more time to be able to say for sure. So I think eventually, I think these robots or robotic surgery enables surgeons to execute planned component positioning and getting better limb alignment with improved accuracy and reproducibility. Computerized systems, machine learning, and artificial intelligence may be able to correlate this input data to output data. And I think artificial intelligence offers an avenue for using outcomes to select ideal patients for surgery. I think eventually, hopefully, this is all going to be of long-term benefit to the patient, both in terms of function and for increasing longevity of the prosthesis. And if that is there, the robotics is definitely here to stay. But there are certain things that will certainly need to be managed by humans as for now. Thank you. Okay, so I will stop share.
Thank you, John. That was excellent talk.
Thanks. Well, I have to admit that this is not from too much hands-on experience. It's a lot from the literature rather than hands-on experience. Although we do have navigation, I've not personally done any robotic surgery to claim to be an expert on it.
That's excellent. Actually, you've very well summarized navigation is the basis of robotics. So robot is, apart from a cutting tool, it's again based on the navigation.
Based on navigation,
yes, it does enhance planning, but yeah, that's the basis of it. from the audience? I
Yeah,
see Mr. Picard is in the audience as well, so I would
Oh,
like to
okay.
hear his thoughts about the future. Fred?
Yes, I'm here.
Effort.
All right, great.
Yeah.
Okay.
No, that was an excellent talk, and I can only concur. Clearly, what the first thing to say is I would like to emphasize what Kamal just said. The robot is just the endpoint of the navigation technology. Actually.
Sure.
So it means that if you haven't planned well your surgery, whether it's pre-op or intraoperatively, you will end up with a disaster. That's
Yeah.
all. The only thing is the robot will perform the disaster, not the surgery. So this is why I would also obviously confirm that it's extremely important to understand what the system does and to check and verify all the steps, not just with your computer, but what with your brain. Your surgical brain has to be involved 100% of the time, and especially in the robotic technology, because we can end up with a terrible disaster if we don't control that. And the second point I'd like to make, and you actually made it, is when we use CT-based navigation, it's very good to assess the bone and to define what size we're going to use. But we have no kinematic data, absolutely no kinematic data. And we all know, especially for knee replacement, that the soft tissue balancing is a very important part of your knee replacements. It is true as well for hip. And we have just seen an excellent example and surgery from Ashish, showing that you have to assess, your offset and the tension of the tissue. The robotic technology cannot assess that today. It's still in your hand. And this is why all these instruments are extremely good, and they're going to be part of what Tony Diggio, I worked with many years ago, said that all these navigation systems, computer, robotics, are part of a surgical toolbox, and the surgeon will decide what tool you're going to have to use to perform your surgery. Today, we're using a reamer, we're using a KOR, but we know why we're doing this. And that means that maybe some of the cases should be done only using PSI, patient-specific instrumentation, or only navigation, only robotic, and that's what is fascinating today is we're implementing all these systems and we are collecting hundreds and hundreds of data. And like you rightly said, these data will be compared to the patient's outcome. And that way, retrospectively, we will be able to say, well, that case has been a success because such and such and such. We are not at this level, even though we are collecting hundreds of data in knee replacement, particularly, and we start to do this with hip replacement. And we are, all this data with AI will pinpoint the mistakes and also fine tune what we're doing for every single case, which are all different.
Yeah, excellent points. Thank you.
Yeah, absolutely correct. Any other comments or questions? Hey, it seems we all had a very good session. Ashish, thank you very much for the live surgery. That went very well and well done.
Thanks.
Thank you, John.
Great to see you again. Yeah,
Hopefully see you next year.
Absolutely. Hopefully in Patna next time.
Thank you, John. Thank you, John.
Thank you,
Kamal.
Rakesh.
We should now hand it over to Rahul or Ashish, who is taking over for the exhibition walkthrough. Anybody there? Thanks.
Thank you, Johan. Thank you, Rakesh.
Thanks. Purushottam or Ashish?
Yes, Kamal. Thank you,
Anybody
Rakesh.
there?
Hello, sir. I'll share my screen. I will give you a walkthrough exhibition.
Yes, Ashish. Carry on from here.
Yes, sir. Now we are moving forward to the next session, and just a minute. Hello.
Yeah. Hello.
Yeah, we are moving for the after live robotic surgery. We have a tremendous exposure, and we saw very good surgery with help of the robotic. Now we are moving for the next session. I would like to invite Dr. Rajkumar Natesan sir for discussion on the man alignment in total hip replacement. Either be correct with the navigation or robotics, which is problematic in manual THR. Dr. Rajkumar Natesan sir.
Are we starting now or at 3 o'clock?
No, sir. We continue with next session, sir.
Okay. Are the other speakers are all aware of this? Because I was here, it was told that it is starting at 3 o'clock. I'm okay to start now, but I need to know whether if the other speakers are there to continue with my talk. Because it is mentioned as 3 o'clock. I don't know whether they are available on
Ashish boss. Just a minute, sir.
Yeah, no problem.
Well, the people following you are Kamal and Ashish, so they are definitely here. Dr. Adarsh.
Yeah, he is not there, sir.
Okay, he's the one who's not around, so I don't.
Hello, sir. We were supposed to show exhibition grade, so should I show it back then? Actually, it was scheduled like that way.
No, anything is okay. It is you and Ashish can take the call.
Hello. Hello, Rajkumar sir. Hello.
Yes. Yes.
Sir, actually, we are getting schedule is getting a bit late, so there was a half an hour time for this one what is a stall exhibition. So we'll make it. So we'll make it like 5 to 7 minutes for a stall exhibition. Then we'll start the session, next session. Is that okay, sir?
I'm there. Yeah, I'm there. I'm okay with that. Anything is okay for me.
Sir, extremely thank you for that, sir.
Yeah.
Okay.
Mako Smart Robotics. What a journey it's been.
If you remember, the last time I was here, we announced the Mako acquisition.
Yeah, and how did that turn out?
A complete home run.
That's Mako Smart Robotics. 3D CT-based planning. AccuStop haptic technology. Insightful data analytics. Mako is backed by over 175 published peer-reviewed studies and has shown better outcomes for total knee, total hip, and partial knee patients. The latest upgrade to the Mako Total Hip application was designed to enhance the user experience with approach-specific, region-based pelvic registration. And the new virtual range of motion and pelvic tilt planning features give surgeons information they've never had before to create and execute surgical plans based on a patient's specific dynamic range of motion and pelvic tilt. Mako Smart Robotics is now available in 28 countries across the globe, with approximately
The pain. Can't move much? Swelled joints and chronic pain. The wear and tear of the connective tissue means that the bones grind against each other, causing the unbearable pain. In severe conditions, an implant procedure becomes the only logical treatment option.
कितनी खुशी मिलती है माँ बाप को जब एक बच्चा जन्म लेता है और वही बच्चा जब अपना पहला कदम बढ़ाता है, चलता है और फिर दौड़ना शुरू करता है और फिर वो थमता ही नहीं, चलता ही जाता है। मगर कभी-कभी जिंदगी करवट बदलती है और इंसान की परीक्षा लेना शुरू कर देती है। इससे कुछ लोगों की रफ्तार में कमी आती है, मगर इसका मतलब ये नहीं कि वो रुक जाएं या थम जाएं। ऐसी रुकावट को दूर किया जा सकता है कुशल और अनुभवी हाथों द्वारा। स्वागत है AIOR पटना में, जहां आधुनिक तकनीक की मदद से और अनुभवी डॉक्टरों की सहायता से आपकी जिंदगी की रफ्तार को फिर से वापस लाया जाता है, क्योंकि जिंदगी चलने का नाम है। AIOR चलना ही जिंदगी है।
है जात धर्म क्या सभी का ख्याल रखते हो, बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो। नहीं जान की परवाह, निकले हो जान बचाने को, तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। पड़ी मौत सांसों के पीछे, बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में, यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको।
Back in 2006, what was merely a dream has become the reality. As a leading global medical device company, what started with a few commodities now boasts of over 100 products. What was conceived in one country
Atul, close the door. I'm going to talk now. No, please. No, please. No, Kane, go down. Close the door.
Okay.
What drives us every day? The needs of today's world. The courage to explore new paths. The ambition to find new solutions that make a difference. At Venus, we make
We should start, sir. Geffels?
I think so, yeah.
Yes, sir. Now, just give me 2 seconds.
Yeah, sure. So Rajkumar, how are things in...
Yes, sir, you can start now.
Yes, sir. Here we are actually doing electives regularly, but not like pre-COVID situation.
Yeah, I think it'll take some more time, but
yeah, and yes, sir. But we are doing all screening like the RT-PCR and all those things. If it is negative, we are doing.
Awesome.
Okay, so they're ready to go, I think.
Yes, sir.
Sir, sir, 1 second.
Yeah, I'm
Just Sushil Singh is logging.
Yeah.
2 seconds.
Hello. Hello.
Yes, Sushil sir, start.
Yes,
Sir.
yes. So we move forward for the next session, and I just invite to Dr. Rajkumar Nathan sir to continue with the talk malalignment in THR, which can be corrected by robotics or technology as compared to the conventional methods. So over to you, sir.
Okay. Good evening to everyone. I would like to thank Dr. Ashish Singh and his team for inviting me this evening for a fantastic program on robotics. Even though I was not directly involved in the morning sessions, I was hearing all the sessions and the live surgery, which was really very good, and it is a need of the hour because people are really so much skeptical and debating whether in this situation, particularly after this pandemic, so going into the topic, my topic is like I have slightly mixed whatever the topic was given now or a few days back, a few days back. So I'll just try to talk on robotics in total hip replacement, purely on total hip replacement. So 1 second, it's not moving. Yeah. So my disclosures. Coming to robotic total hip replacement surgery, I have not performed by robotics. So robotic total hip replacement surgery is new to me. However, I have done a few total knee replacement surgeries with the help of robotics with a different system. So this is what I want to inform everybody. So then who are the experts to talk about robotic total hip replacements? So obviously the young and energetic by robotics. So if you ask me, I'm not an expert in robotics total hip replacement, but I have watched a lot of YouTube videos and went through a lot of literature, so which made me an expertise but without experience. So if you Google evolution of man, then it says man becomes machine. The evolution of man is revisited now and it has become a machine. So the current situation of man is with a smartphone. Everywhere, anywhere, anytime, people are roaming with smartphones. Future, everywhere it is going to be probably robotics, and we won't be surprised if robotics are getting married and having kids. So that is what now Google is predicting. There can be a possibility. So if man is evolving total hip replacement started by Chanley in the year 1976. Look at the cementing technique which was done in 1976. That was the state. Okay, but still 32 years have followed. When when robotics can evolve that way from man, why not a total hip replacement started by Chanley should not evolve into a robotic total hip replacement? That is my point. So total hip replacement, if you look at it, it's become a highly successful procedure. Why? Because it gives excellent pain relief. Patient can return to function as early as possible, and the quality of life is absolutely fantastic. There is no doubt about it. So because of this highly successful procedure, the numbers are skyrocketing. 174% increase every day, everywhere across the globe, the numbers are going up and up. So look at this X-ray, bilateral hip arthritis, obvious. No, it definitely needs was done by me, a bilateral conventional total hip replacement done. If you look at the post-operative X-ray, I don't think there is nothing much to really say there is any problematic here, because the the implant positioning, the alignment, limb length, almost everything is achieved perfectly. one more example of a hip arthritis, again done by a conventional total method, uncemented total hip replacement. The very good post-operative X-ray, the alignment is good, positioning is good, offset, everything is achieved. So even though this kind of results are achieved with our conventional total hip replacement, still if you look at the revision rate, less than 65 years, the revision rates are going up and up. 32.9% of revision is happening in the age group of less than 65 years. Why? As a surgeon, we need to be very cautious. Even though we are getting good results with conventional hip replacement, this because total hip replacement also comes with problems. What is that? The instability and malalignment is, apart from infection, instability and malalignment is a very big problem. This instability is not happens by itself. Almost always it is created by the surgeon. So if you look at instability in THR, the Australian Joint Registry quotes 14.4% of revisions in the 1 year 2015 alone. The readmission rate is 32.4%, and in hip replacement due to instability, revisions due to instability is 22.5%. It's really huge. Because of this instability, revisions, the cost goes up, morbidity increases, there is a lengthy hospital stay, and infection happens. Everything put together, it puts enormous burden on the patient and his economic resources, and also the. To summarize the instability, abductor insufficiency and component malpositioning, everybody will accept that these are the two most important causes of recurrent instability. So in total hip replacement, whether it is done by conventional method or robotics, component position, abductor tension, offset, all these three are the most crucial, important point which goes hands in hand. To achieve a good result, to have a very good outcome after the total hip replacement, you have to get all these three correct. Both the component position and offset and the soft tissue tension. Dr. John Mukhopadhyay sir was very much telling about the soft tissue tension, which the robotics cannot achieve. The surgeon has to achieve that. So all these things, if we have to address these three things to get a good result. So this is, if that all these three things are not achieved, then this happens. What is that? Instability. So any problem goes in those three things, this happens. So how to avoid this? How to prevent this? By templating. So once you start templating, we can achieve these kind of good results. So what does templating provides us? It determines the choice of implants before surgery, identifies the potential difficulties preoperatively, and the most important point here is it restores the favorable biomechanics to the joint. So what is that favorable biomechanics? The joint reaction force has to be reduced. How is that can be reduced? By getting the correct abductor tension. So once you get the abductor tension and the offset correct, automatically the joint reaction force is reduced. So the longevity of the implants are achieved. So good outcome in a total hip replacement, predominantly, if you want to put it in a nutshell, the good outcome is based on the offset and the limb length. If you achieve both, very good in a patient. So that is achieved by getting the template, doing a templating. So even in spite of doing all these things, complications happens, which becomes an inevitable in any joint replacement surgery. So in that, if you look at that, recurrent instability again is a very, very important complication. And in this article by Javed Parvezi, he has very clearly mentioned that you have to be aware of the subtle component malpositioning. Radiologically, we might think that everything looks okay, but still there is something going on. Instability is going on. Why? Because of the subtle component malpositioning. So component malpositioning is a crucial step in the management of instability. So we have to be aware, or we have to think that there can be a small malposition if anything happens or any problem is going on without any obvious radiological changes. So again, by Faraz Haddad, recently published total hip replacement. He concludes that robotic total hip replacement improves the accuracy. That is very, very key point here. Everybody should understand that it improves the accuracy and also it improves the precision and reduces the outliers. So if you get these two correct, then the center of rotation, hip rotation, and the cup positioning of the acetabulum can be achieved. So once you achieve these two things, correct acetabular cup position and the center of rotation, the offset is achieved. Once offset is achieved, then limb length is achieved. So good clinical outcome and the longevity of the implant. So that is what he concludes, that the robotics helps in these things. So accuracy of implant positioning, which was very nicely demonstrated by Dr. Ashish in his live surgery. The robotic hip replacement uses intraoperative mapping. So because of that, the manual subjective errors are avoided. So this of restoring the hip biomechanics. How that can be achieved? By getting the reaming correct. So you cannot do over reaming or under reaming. The reaming has to be perfect. Why? To get the cup position proper. Once you get the cup position proper, the biomechanics is achieved by getting the offset and the center of rotation correct. So you have to be very careful in your reaming, and that is achieved by your robotics. So look at this conventional total hip replacement done in elsewhere in Bangladesh. Both sides done, and one side it is a component malposition, and one side it is over reaming of the acetabulum. So both places the offset is gone, the center of rotation is changed. So definitely this patient will goes in for a failure. So this is not at all accepted. So we have to be very careful in getting all the three things correct. So what is that? After a successful total hip replacement, procedure by looking at the x-ray, but the patient thinks the other way around. Patient is not happy in spite of surgeon thinking that he has done a good job. So what is that? Both differ and poor correlation between them. The surgeon thinks one way and the patient thinks the other way. Why is that? The functional outcome scores does not necessarily correlate with the patient satisfaction. So nowadays we need to use prompts, that is that patient reported pain and functional scores post-operatively, which helps to measure the patient satisfaction. So what is that functional outcome after robotic THR? Perez et al. In his 162 patients in a OA hip undergoing robotic hip replacements, he has concluded that patients have reduced hip pain, increased patient satisfaction, and improved functional outcomes. So with the robotic THRs, there is a very high chance of improved accuracy, which results in more natural feeling of the knee replacement. The patient feels his hip or knee is very much natural, then his satisfaction level improves a lot. So, and our next thing is, people all say that it is a very big learning curve and it takes longer time to learn this newer technology. But contradictory to that, Faraz Haddad, again, he has concluded in this recent article that robotic arm assisted total hip replacement does not have a very big learning curve. It is very quick to adapt. Surgeons, young surgeons can learn very quickly because the technology is so advanced and so user-friendly. But still, however, there are some limitations of robotic hip replacements. What is that? The robotic system is definitely expensive. Any surgeon, now you ask them, do you have a robotic system at your center? No, because it is expensive. They might refuse it because it is expensive. Then for whom it is possible? Probably the only people who can have a robotic hip replacement. But still, we have to wait for many like few years, or maybe few months, or maybe many years, whether if the system will reduce the price or not. But what are the other limitations? The technology is also only compatible with the select implant designs from the manufacturer. So if you have a Mako robotics, so you have to use only the Mako striker products like the triathlon and Oculate systems. Whereas if you are using a Navio, then you have to use only Genesis or a Legion system. So like that is a limitation. So we cannot have one single robotic system and use any implant which we want to. So that is again a limitations of a robotic joint replacement surgery. Patients with advanced OA often have a abnormal spinopelvic alignment. But all robotic systems or the software does not currently use dynamic preoperative the recent software helps in doing even that kind of complex cases, which Dr. Ashish was mentioning, that he regularly does ankylosing hip replacement surgeries in ankylosed hips, where they have a lot of spinopelvic deformities. So to summarize, definitely there is deficiency of long-term clinical and radiological data on robotic hip replacements. We have to accept that. So we have to wait for some more time for the robotic technology to offer more and more data on how the outcomes are going to be. So the robotic technology offers promise in the early stages, but we need to wait for further studies for reporting on long-term functional outcomes, implant survivorship, and complications, which we have to wait and see. But however, there are enough promising data. Definitely in future, robotic systems might be able to give all this data and convince that this is going to be the future. Thank you.
Thank you, Dr. Rajkumar sir, for giving the valuable opinion regarding the further adaptation of the robotic surgery. Now, I would like to invite Dr. Kamaldeep sir for discussion over the evidence-based surgery and planning. Dr. Kamaldeep sir.
Yes, thank you. Right, is the screen visible, the presentation?
Yes, sir.
Yeah, it is.
Okay, good. Still morning in the UK. So good morning to those who are in UK. Firstly, thank you, Dr. Ashish and Dr. Singh for inviting me again for this wonderful course. It's always great to interact with Indian faculty and others. So most of the actual evidence has been discussed since the morning in different talks, and some in the previous talk as well by Dr. Raja. So these are my brief conflicts of interest which you have to show. I'm going to mainly talk about the evidence on the Mako robot using the hip replacement. Is what you see yourself, what has been best in your own practice. In the literature, there can be some studies which are saying something, there can be studies which are saying opposite. So you'll find everything in the literature for and against. The best ones are those where multiple centers have shown repeatedly the same findings. So we have to interpret the literature with caution as to which paper you're relying on. I think a single paper we cannot rely on. And if something is shown repeatedly by different centers, different specialists, that's the evidence we need to work on. And as I said, best evidence is where you have seen it work for yourself in your own practice for your own kind of patients. For the robotics, I think the main advantages one is pre-planning and two is preventing the surgeon from doing errors during the surgery. Now, Mako robot actually does help in both of these very important steps of your surgery. In the pre-op planning, all the three dimensions, your component, where you're going to place, especially anterior-posteriorly, which on 2D templating, you cannot see the anterior-posterior wall, the green component, where you want to place it, how much anteversion you want to place here, depending on your walls and margins of the acetabulum, how much bone you want to resect, how medial to go. So your surgery, you actually have an idea of how much bone you will be resecting, how much change of the center of the rotation you'll be doing. That is very, very important. And the robot actually does help to execute. Similarly, on the femoral side, if you're using uncemented accolade, using enhanced software, you can plan your neck cut, which will be helpful in determining your leg length. And you can your anteversion beforehand what is the original anteversion of the stem. If you see in this case, it's 4 degree. Most of the cases I have seen, the femoral stems are not that much anteverted as we normally think that they are. If you know it beforehand, when you put your first rasp in, you can actually change that anteversion and help with the combined anteversion values that we actually aim for. So it's very important that when you put your first rasp into the femur, you change that anteversion and actually create a slot which will take the successive rasps going up to the size that you have measured on the planning. It goes for the exitor stem. It can take both cemented and uncemented stems. It actually gives you the x-ray before you actually start your surgery. This is how your x-ray is going to look. And you have carried on the surgical steps precisely as is indicated. These are some of my pre-op plans. On the is very, very important is to match your CT anatomy to your intraoperative anatomy. And it has to be achievable within 0.5 millimeters. Otherwise, it won't let you proceed, which is great. So that's preventing errors, which is an important part of the step. Setup, as you've seen with the Ashish already, I keep the camera on the surgeon side, on the between the anesthetic and the surgeon. What comes from actually the opposite side, from the front, as you can see the robot holding this is the robotic arm holding the cup in position, and we just hammer in the cup. Also gives you an indication of how much intraoperatively you are going in, how much you should go, how much you should not go. And as I was talking to Dr. Johan Prince during the live surgery, it gives you 3 kinds of feedback. And that's where it becomes actually very important to prevent the surgical errors. In the visual feedback, it'll give you the green zone, which you have to cut, and you reach to the white zone. And if you go beyond the white zone, it turns red, which is a very good visual feedback. There's also a haptic feedback. That means it starts to resist what you're doing if you try to go beyond the safety margins. And if you try to go, if you actually push it to go beyond that, it will also give you a warning by beeping. So this is very important in preventing the surgical errors. The difference from navigation is that navigation is the guiding system for both. Both get intraoperative feedback, robotics as well as navigation. In the navigated surgery, surgeon is complete control, but in the robotics, with the semi-echo, the robot actually helps the surgeon by restricting his fields, so preventing his errors. Now, the various papers that have been quoted already, we saw in the last paper, talks. One is the main hallmark paper by Dom, which was published in Core in 2014, is comparison of 2 cohorts of patients using 126 patients, 59 robotic, 67 manual, and we plotted on the Levenec safe zone in both the sides. You can see the robotics are all within the safe zone of Levenec, and mostly in Callanan as well. And in the manual, they are scattered beyond that as well. And this was statistically significant. So the accuracy of the procedure is actually not in question, that it places the implant accurate. There are multiple studies which have shown this already. Another study by Jarabek, and they looked at 20 patients. They did the pre-op CT scans and the post-op CT scans and measured various points, hip length, leg length, and offset, and it correlated very well with the accuracy which the robot was showing during the surgery using the 3D models. Another paper by Marco Viggi and they showed the retrospective study, and they included 3 centers using 362 patients, and they measured the femoral neck anteversion, acetabular anteversion, and combined anteversion, and they showed that femoral neck very variable, which is essential then to know preoperatively how much your neck is having anteversion, so you can change it during the surgery if needed. Then this paper quoted by from Faris's group, looking at the center of rotation and reproducibility of the vertical and horizontal center of rotation, as well as the leg lengths and offset and combined offset. And they found use 25 robotics versus 50 manual total hip replacements, that robotic hip replacement was associated with improved accuracy, which was statistically significant with the values of 0.001 in both center of rotation as well as the offset and inclination anteversion, but they did not find any difference in the leg lengths between the 2 groups. Another paper by Suarez, it showed that there is preservation of bone because you know the CT scan beforehand, so you're able to actually use a smaller cup compared to a bigger ring to reach the floor. So you don't have to use bigger reamers to reach the floor and then create your cup. They were able to use a cup smaller, one size smaller, and hence the preservation of bone, which may or may clinically, to be honest, but that's a study there. Then going on to the functional outcomes, we've done the clinical, the anatomy gives you actually good accuracy about. But does it translate into functional outcomes? There are not many studies yet, but there are very few. And this is one of them by Bukowski. And they found up in 200 hip replacements, which compared 100 manual versus 100 robotic, again, retrospective study. They found that at 1 year, the Harris hip score and UCLA scores were actually higher in the robotic group compared to the manual group, hence the functional outcomes being better compared to the manual group. Another paper that was presented in Chaos in New York last year, we're using Mako total hip outcomes at 5 years. And they use all the hip scores and satisfaction scores. And they found that the robotic hips were performing better compared to the manual ones. Again, from the same paper, the DOMS group, as the initial paper was. Then looking at the another study, which was a prospective cohort study. It had 162 hips, but 151 patients, so quite a number of patients, although no comparative group, but they showed that their scores were very good, and forgotten joint score was very good as well. They found there were lesser complications, which is any leg length discrepancies and no dislocations. So it does help with reducing your complications as well. But again, the studies are only few and far till now needed. Looking from my own experience in the using the Mako robotic in the initial cases, I looked at the timings at different stages of the procedure. And at the something that can be actually improved. It takes about 7.5 minutes to match the femoral anatomy in the enhanced software when we are matching it to the CT scan anatomy. And it takes about 8.4 minutes to the pelvic acetabular anatomy to the CT scan. And if you're using a cemented stem, then that adds further 14 minutes. In the navigation hip, it takes about 60 minutes for the uncemented and 72 minutes for the cemented stems for me. Then to the navigation, it takes me 10 minutes longer when I'm using the robot. And this is actually correctable. You can improve this. There is room for improvement because using technology and enhancing it further, not take that much of a time to match the anatomy, which will perhaps come in the version that come in the future. We should be able to reduce this matching time. It does pose an ethical dilemma if you want to use an uncemented stem just to save time, just to save a few minutes. Also, it does pose an ethical dilemma if you do not use a robotic surgery, if you have access, and just to save time, that I don't want to use a technology assisted surgery and will just go conventional when you know very well that it's going to help with your accuracy, what you have planned. So should you or should not supersede the accuracy when you have the time constraints, or should you change the implant from cemented to uncemented? It's up to the surgeon, obviously, ultimately what he considers is the best. But this does pose this dilemma in the mind. Another thing which I found very helpful, which we published as well recently, is that the pre-operative plan, you get the implant sizes very, very correctly in the hip replacements. And in 100% of the cases, we were able to match the acetabular cup size and stem size and the head diameter and offset as we had predicted. We did not have to change a single size. And this, when you compare to the plain radiographic pre-op planning templating, only 40% of the femoral sites and 37% of the acetabular site go for the same size as predicted, and 87% of the femur go to size plus minus 1 or down. But compared to that, if you are actually short of your inventory, or the companies are not able to provide to many hospitals all the sizes of the implants, in those situations it can be better because you know what size you're going to put, and that there it predicts. What has been variable though is the neck length, and in some cases we had to change the neck length by up to 2 sizes for and stability that we felt clinically was important. But the definitive component size remained the same. So going into the summary, accuracy is no question. It improves the accuracy. Literature supports that. Outcome is favorable. Short-term patient-reported outcomes in some of the studies, although we still need much more large studies to actually prove that outcomes are better. Complications, again, only some studies have shown that it reduced the dislocation and leg length discrepancy. Not many studies have actually shown that. In the long term, we still await. It's a multifactorial thing, the outcomes in the long term. But for Mako Robot, we still await that. It's been actually last 10 years in October this year that the first Mako implant was done, but Mako hips came later, so we do await the long-term outcomes. Technology adoption is slow to come by, and we are still in the early adopters phase, and there's still a long way to go up the curve. So let's watch the space, how it pans out. Personally, and control what my robots are doing. Thank you. Any questions? Anything to know?
Kamal, I've got a question.
Yes.
Regarding the hips, I can understand it's like a ball and socket, and if you get things right, and if they look right, you normally get a good result. What is happening with knees? I mean, even John's talk was about the same. There is this 20% people we are just not getting happy about, and even alignment doesn't seem to be changing their happiness. I mean, this can be answered by other faculties also. Where you think we are not getting it right with knees?
Yes, that's a very good question, Rakesh. It's in the knees. The problem is not where we want to put it. Now with the navigation and robotics, we can put the implant where we want it, but it's the ultimate target which is questionable.
So what is the
Actually when you look at the original normal anatomy? Yes, that's the golden question. What is the target? In the absence of actual optimal individualized target, still aim for a neutral, but that is not to say that neutral is the best. It is what I can say is safe option, but it's not the best option for each individual.
Rakesh?
Normal leg, which is in varus already, it's going to be probably less optimal outcome with the neutral axis.
Rajkumar, you want to say something?
Yeah, that was an excellent talk, Dr. Kamaldeep. Answering to your, just not answering, just adding a point to your question, Dr. Rakesh. What I feel is, in a hip replacement, it has been universally accepted, whether it is by navigation or manually or robotic. Certain parameters are now accepted that gives good results, like the cup position, implant, femoral stem position. We should not have a varus. You should not have a valgus. It has to be neutral. Everything is accepted. But unlike in knee, so many things keeps changing. Previously, 90 degrees mechanical axis, 90 degrees to mechanical axis was the gold standard. Now people are telling kinematic alignment. You can put the tray in a little varus, this much of valgus, femoral component, external rotation, this much can be accepted, that cannot be accepted. So there is no universal acceptance in the knee side. So that really puts a lot of debate on which is the most accurate positioning of the implant or the ligament balance. So that is why there is a big percentage of 20% of patients unhappy. So there needs a lot of research on that. And I don't know when we can come to a conclusion on that part, I believe.
I think also some of it is related to expectations. I think because for the hip patients, I think by the time we do them, they are usually pretty crippled.
Yes.
And they're able to get up and walk reasonably well. They are quite happy. While in knee, a lot of them are able to do their functions for when the knee is radiologically pretty badly damaged, especially in India. You find them able to squat and things like that. When you look at the x-rays, you'll be wondering how they do it. And as long as they've not developed significant deformities, they are managing okay. And so maybe the improvement they get is not matching what they're expecting. And that may be one of the issues, apart from the fact that it's a more superficial joint. So I guess the soft tissues don't take so kindly to the same surgery. But
correct, sir, correct. And that comes to the point of correctly indicated cases in a total knee. Grade 2, grade 3, probably even some cases in grade 3, but grade 2 patient, if you do a total knee, definitely they are not happy.
Not happy.
But whereas a severely crippled, severe varus with bone loss or a valgus, if you do a total knee, even if whatever the implant might be in a odd position, but the patient is happy and they are all doing well also.
Well, Rajkumar is when the surgeon is happy and the patient is unhappy.
I didn't get you, Dr. Rakesh.
I was saying the problem is when the surgeon is happy, he looks at the X-ray, he looks at the movement.
That's what,
and he says,
that's what I mentioned
the patient's
in my talk.
moaning about,
Yeah, that's what I mentioned in the talk. See, X-ray, if it looks good and surgeon says, oh, I've done a fantastic job. But that is where you have to look at the prompts, patient-related outcome measures. Nowadays, it is picking up everywhere. we have to use prompts in our day-to-day post-operative patients and assess exactly whether the patient is able to do their post-operative day-to-day activities or daily living. That is where we miss. We just look at the functional outcome and say, okay, it is good, the results are good, but the prompts are the one which will give us exactly whether the patient is happy or not.
And also pre-op counseling, I think matters a lot.
Yes, sir. Yes, sir.
You
Definitely.
need to tell them what to expect, and sometimes really the expectations are kind of, they expect that they'll be perfectly normal once the surgery is done, and if they're not perfectly okay, they are not happy with it. Yeah, come on.
We have done.
I have a question for Dr. Kamaldeep.
Yeah.
Like
we have done a study on satisfaction rates in the patients in our institution, and we found that up to 96% of patients are actually satisfied when we are using navigation. And that's goes to say that pre-op counseling is very important. We do a lot of that in our clinic. As said, using technology only helps to a certain extent. It cannot completely abolish the dissatisfaction. The 20% dissatisfaction rates are overrated, and the industry uses 20% dissatisfaction rates to actually sell their new implants rather than actually improve on the results by
Yeah, I think if you look at all the literature, it's something probably 10% is closer to the actual
more realistic,
who are really dissatisfied. But I think that, and if you look at knees which are done properly, it's probably a bit less. But the very fact that you have some where everything looks perfect and they're not happy makes you wonder what the cause is.
Yeah, that also adds to that. In the immediate post-operative period, total knee patients are the one who requires more of pain management, whereas total hip replacement, they are absolutely pain-free immediately after the surgery also. Once the wound heals, they are almost back to normal.
Dr. Kamaldeep, just a question. Very nice talk there. I wondered if you're using the express mode or the enhanced workflow mode in your hips.
Yeah, thank you, Dr. Mohan. Mode, but before coming to this meeting, I used the express mode so that I'm able to understand that better. But mostly I'm using enhanced mode.
Thank
you. It does take more time, but gives you more information and better results, I think.
More accuracy.
Yes.
Yeah, one more question, Dr. Kamaldeep. Is that regarding that software for the patients to where we use for the spinopelvic deformity, is it like even it is available in India, Dr. Mohan also?
Well, Ashish is going to talk on this point, I think, in the talk.
Okay.
So I will leave it to him. I won't take away the next talk thing.
Okay, thank you, sir. Thank you, Dr. Kamaldeep, sir, for giving the wonderful talk and have a wonderful discussion about the knee.
Thank you, Doctor.
And I would like to invite Dr. Ashish Singh for presentation of what can we do more with the robotics. Dr. Ashish Singh, sir.
Thank you, Dr. Sushil, sir, and thank you everybody present in this auditorium for patient listening, and the level of discussion is really what we expect. So, am I first of all loud and clear to everybody? Yes. Okay. So, Mako, the robot, is it the next level? What can we do more? Yes. So, what do we aim in arthroplasty is accuracy, confidence, reproducibility, and of course, flexibility. Now, surgical treatment, we all know that total hip replacement is one of the best century of last few decades, best surgery, and patients are definitely happier than the knee patients. we do understand that computer-assisted surgery helps surgeons to align their implants with computer monitoring, and it does help in improve the overall function of the new joint. What I feel the things which are going a wee bit haywire is the understanding. So I would we will focus on the CAOS body. So basically, computer-assisted orthopedic surgery is defined as the use of computers and robotic technology in providing MSK care, musculoskeletal care. Now, the computers you can see everywhere, and they add geometric precision, reproducibility, perfect memory, and lack of fatigue. But the second dilemma which the patients and quite a few surgeons have, that is it the robot doing it? So at the moment, no, it's not the robot doing it. It does not replace the eye of the surgeon, which Dr. John Mukhopadhyay said, Dr. Frederick Picard, and everybody has reiterated. And it actually does not require dedicated technician or facilities. Of course, getting the robot, otherwise you have to do it yourself. Now, the second important understanding is the system. We have active system, semi-active system, and the passive system. Now, active robots are the assembly line production of cars, aeroplanes, where robotic tools are making hundreds of iPhones with 0.001 mm efficacy, I mean the precision, as they say on the ads. But humans are involved, sitting in somewhere of the room. But semi-active are controlled robotic tools where the system restricts within a predetermined frame. That is known as a haptic boundary in case of any robotic arm Mako. Actually, the Mako falls in this category. Now, the passive is that things are done, but under the guidance and control of the surgeons, like the navigation. Navigation, advanced navigation, the split navigation, you have a burr and your hand can go anywhere, but your burr will not go anywhere apart from where you are dealing, because it segments the articular cartilage into 3 haptic boundaries. And but if your hand goes outside the knee frame, it will definitely do something or mechanically damage the capsule. Another important understanding is, because in the nowadays you have Zimmer coming up with a robot, you have Smith & Nephew coming up with a robot, you have the Stryker company coming, and you will have so many Merrill company has come up with a robot. So basically the modalities, how do you give data to the computer? Because here we have to have an understanding of a computer, because a computer is an electronic data processing machine which processes data under control of predefined instructions. You have softwares, you go to your hospital, you have HMIS. Somebody feeds, somebody prepares. So basically here also either we give MRI data. So if you remember the Zookni, which was MRI based planning, patient specific instrumentations. So we used to have the MRI being segmented at Belgium, and then we used to have the patient specific implant, and then we used to go ahead. Then Stryker came up with the patient specific instrument, which was CT based. So the image modality was CT based. If you see the development, it was X-ray, then CT, then MRI, and the latest Zimmer robot which has come, it is also X-ray based. And one of the company, Merrill, also has launched a robot which is also CT based. So if in trauma, everybody is shifting to a 3D technology, a 3D imaging in almost all articular traumas, everybody of us gets it done. So if in joint replacement, we can have 3D imaging and something that would help in achieving your whatever numbers or angles you want, then I think that's the way. Because I had a lecture, we had a lecture in one of the talks with one of the person from Hong Kong. He was talking about 3D printing, the jigs. I agree, that's a good thing. But here, in this Mako system, or in this system, the modality of input is a CT scan and a 3D dimensional what is matched in the theater and confirmed by the blue dots, which is in the range of 0.05 mm to the bone. And then you have a plan. And then it is the semi-active robot, as I told you, the semi-active robot, which is enforced control robot within a haptic boundary, and you take it from there. just a basic understanding. But I will focus my talk on some cases and what we can get more. Because I have heard Dr. John Mukhopadhyay says talks, failing to plan is planning to fail. And I like this line because in India, we don't have ortho-view. The company do not provide us templates. We talk, this is a striker knee, this is a Zimmer knee, this is a Depew knee. Nobody talks, it is a single axis knee, multiple radii knee. Nobody talks that this is the exeter stem, it is a stem which has a broad shoulder. Nobody talks, so we are more like company oriented. So we have to have an understanding. So let's discuss some cases. So this was a case of a lady, I think 53 years old, and she had absolutely stiff hip with supralateral migration of the hip, and we planned it. So if it would have been a normal hip, I mean without anything, we would have got our cup somewhere near the teardrop. And then after we got the CT scan, we had more planning. We did more planning, and planning also helped by the 3D modeling and the implant specific positioning. So for example, we planned the cup, you had supralateral deficiency, which we knew. We didn't want to neutralize. We tried to get the cup inclination to 43 degrees rather than 40, and version of 19 degrees because that was fitting well, and it was on enhanced software. So we knew that we have to go achieve 43 to have the best fit cup, and stem something like this to match the center of rotation. And through a digital ruler, we planned, and we have to match this center of rotation to pre-op X, post-op X is seen on pre-op planning, and then we executed. So basically, what I would like to say that you plan more, and if you plan more for anything, the things are going to be successful. You don't need robot, you don't need, but you need to plan, what I would say. But especially in these cases, when you have so much options, so this case we planned ultimately that we should keep roof plasty, that is grafting in the roof with long screws, or if the patient can afford augments, that was the back of the mind. I knew that we won't be requiring. But if you medialize too much, then you can cover the supralateral margin. But we did not want to medialize, and it was 5 mm just lateral to the teardrop. So these are the things which we know in advance. So this was planned. And ultimately, what we gave inclination of 42, version of 17. So we went there. It was stable. But as I reiterated in my talk, that whatever numbers you have to have a stability, the abductor function, shucks test, low planar test, leg length, do it manually, and gradually you learn that yes, the shucks test tension, and this is the post-operative stuff which we got. It was less than 30%, no need to add any additional hardware, patient mobilized. But when we come to do something like this, where you see a shallow acetabulum, the small acetabulum, the CT scans, the X-rays are like this. The CT scans, you see that the proximal migration of the femur, and it was sort of ankylosed. We had done this. We had some intra complication, not because of the stem, but it was due to reduction that we had a fracture. Stem was fixed and it was later realized. So we had solution ready, but we did it. So it is very important to also enumerate your complications, because if you start doing things, you will have complications. But one of my teachers, Mr. Martin Sarungi from Golden Jubilee, has always told, it is always important to know how to bail out from a situation. Doing a knee or a hip is easy, or for that matter, any surgery. But what is the plan, backup plan? That should be always in your hand. Now, let's come to this case. Now, this is a young boy, 23 years old male. Absolutely, the last 3 cases were fibrous ankylosis. This case is a bony ankylosed hip. Now, in bony ankylosed hip, we have, see, the planning here is done with the help of whole team. And actually, I'm in India, so things happen like this. They take less than 24 hours to plan a CT, segment a CT, plan it. and then we discuss with them. So my segmentation is done either in Florida or in Hong Kong at the moment, or in Delhi. Now, in this case, we had no boundaries, nothing where to go and how much to rim. Because if it would have been a normal hip, what we would have done, cut the neck, start rimming, and then you're eyeballing. You don't know, are you right, wrong? You have a C-arm tool in place, and then you are not able to judge. But in the robotic software, you have additional things in which you have software for the fused hips. So you take lesser points, but computer guides you in a better way. So this was a bony ankylosed hip, no questions about it. Very young boy, you can see the age, roughly 23. So, and the CT confirms the diagnosis of bony ankylosed. Yes, we did cut the neck because otherwise we wouldn't have be able to rotate the femur. But from there, we did the marking, and apart from the marking, we started use the special platform where we mark in an ankylosed hip. Now, once the ankylosed hip done, marking done, the ankylosed hip marking done. I mean, this was a complex case because we were online discussing with the people at Hong Kong, but we discussed everything, and then the robotic arm in which we use the freehand tool of the Mako. In Mako, there is one good thing is that you don't want to be fixed that it will go in 40-20. You can use the free arm and keep your angles clear, and it will actually stop where it wants to stop. So actually, I did not need the C-arm, but I use as we go for the normal hip replacement. Like for example, 54 cup, we started from 46, 48. And in this case, we just did 52 and came out. But in this case, I used the freehand technique and took it from there. But at the end of the day, this was planned and this was achieved. So you have in this enhanced version also, or in this version, you can plan with the ankylosed hip planning. You have to tell them and they guide you, and you plan more. So failing to plan is planning to fail. So planning takes you there, and it was executed, patient mobilizing within 6 hours actually. 8 hours, that's the standard time when we have started full weight bearing mobilization. This was 6 weeks follow-up, patient happy, we are happy, because nowadays, as we were discussing in the last talks, what I have felt, I am not very senior, but when I was doing my MS in 2000 decade, 2008, 2001 to 10 decade, more things were on the plastic, the backside wear. The next decade, it was on the PROM scores. And that is what I believe in. So for every patient, you have to have forgotten joint score, WOMAC score, the SF36 scores. And if the patient is happy, we are happy. But we are also happy because yes, we achieved something what we planned. Let's discuss this case. So this was also an ankylosed case because there was no movement, and I did simultaneously a case of ankylosed hip. So, and in this case, I did single sitting, bilateral, totally hip replacement because his spine was fixed. So in these cases, I will answer Dr. Rajkumar sir's question that what do we have more? So these cases, single sitting done, and believe me, the lateral X-rays are fantabulous when you see. And the patients, you don't require a screw most of the time. But it's not that you put in a screw. If you have doubt even to 1%, my assistant said, no, I said, I have doubt, I'll put a screw on the left. But right, we were very happy. Follow-ups, 6 weeks follow-ups, lateral views, and see the patient. So patient having bilateral ankylosed hip, life changes after 8 weeks, cycling. Poor patient. So in these types of patient, the very good question which remains unanswered is that what do we want to achieve? Now, there are papers which say that dislocation rates is higher in THR in patients with a fused spine. Either it may be due to ankylosing spondylitis or post-surgical procedure done. In cases of increased pelvic tilt, some people have increased pelvic tilt. So what is the target range? Actually, when we are doing more planning and when we are seeing more things virtually before the operation. There has been a very good paper by Pragano and what are the safe zones and what is the target. So 40-20 works. I do agree to Rajkumar sir that over the past couple of decades, we are happy with 40-23 as per Dr. Tile relationships. But when it doesn't, then we are in a problem. And dislocations are more common in patients with, you can see the lower end of the L5S1, or you can see some instrumentations. So basically, in the enhanced software and the version 4, which is going to come to India ASAP, we can analyze in planning that yes, we have planned to 41-26, but there is impingement. The hip won't go practically till that range, but still we have doubt, and you can change your degree of inclination to 42 or 43. So that will, if that makes a difference, we can just change and see it right away if it is making a difference. So things can be done in a better way. So the target will change in some time, what I believe. Now coming to the next slide. This is actually not my slide, but this is what we are going to get in some time. We will do the, as per Dr. Natesan sir's answer, and we don't have the version 4 now in India, launched in the US. It's basically in the paperwork, and probably ASAP is the answer which I would like to give, probably by early next year. So we have the virtual range of motion pre-op, and then accordingly we plan that how much you take the everything. Now I will just do a pause here, because what happens is that when we started doing with the enhanced version, the express which I did today, enhanced version, you do the stem first. You have a digital ruler by which we mark the green line, and we mark it with a cautery and then take the cut. So you cut the neck and then you set your broach accordingly, and you have 3 points on the trial of the accolade cemented, accolade 2 uncemented, sorry, and you match your anti-version, and then you plan your established version according to the native and your requirement. So you have the digital ruler, you have the enhanced software, which you give a combined anti-version test, and we are very happy before that it's not 40-20, it is sometimes 41-25, 41-24, and you can see the green angle. The robotic arm has got free arm as well, and the angle dimmer. So if in heavy patients, sometimes I have also felt it better that you angle dimmer and take it from there. So these are the things which are newer, but this is more just a video, small. So before I end, that was the last slide. So as per Dr. Rajkumar sir question, we have so much to plan. We don't have a target because last week, 13th of this month, I was listening to the launch ceremony of all these and some by Farah Sadad and people at America, the talks. They are showing the target that we don't have a target, but we have to make it lesser. But before I end, what I would like to say, what I felt, that choose lesser recovery time, because no patients, I don't know why, they are in less pain. I think others would be able to explain more. Lesser hospital stay, and at the end of the day, you have less is everything, lesser pain, lesser blood loss, and doing studies in which we are calculating pain values, VAS score, and lot of things. Patients are moving within 6 hours, leaving home in 3 days. In Indian scenario, yes, it is minimally invasive, very precise, and we are happy. Even if the patient can't afford a Mako, we get the CT scan ourselves and do with a Mako or on the robot platform, not to achieve what we want in numbers, but to give enhanced confidence. Yes, we have achieved what we wanted. And just thanks a lot to everybody for, and still the same question, why are then we still using traditional conventional technique despite evidences? If you are a patient, would you choose 60, 70, 95% accuracy or more than 100% accuracy? Let's think the other way around and take it from there. Being the organizing chairman, I would first of all like to give you a big thank you for attending the Anup Masters Course 2020. Yes, it was tough to collaborate with so many people, one team in Pune, Calcutta, Patna, Delhi. But thank you, and I'm very thankful to everybody for making this successful, being here with me and being here for this session. Thank you, sir. Next is Adarsh. I'm stopping my share.
Thank you, Dr. Ashish. Any questions?
So I think certainly in the patients with sort of severe hip and spinal deformities, alignment becomes a bit difficult. So before sort of robotics, etc., we used to do it by not actually fixing our components. So you do your trials and then try to dial it around to the correct position before you actually fix your components. So I think the Mako is kind of working in the same way, but telling you on images, yeah, now you're okay. So you need to kind of adjust the anti-version of both your components before deciding to fix them. So that's another way of doing it if you don't have access to this technology, I guess.
Dr. Yadav here.
Yeah, sure.
Good
Dr.
afternoon, sir.
Ashish.
Yes, Dr. Yadav, good afternoon.
Good afternoon. Ashish, you are doing commendable job in Patna and Bihar. Really salute you. And most important thing which we are missing over here, it is most important thing. It is very much bone preserving by robo. You preserve bone on acetabular side and you preserve bone in unicondylar. Preservation of bone in unicondylar is very important. And robo is very useful for unicondylar. I have been opposing since decades navigation. But in robo, I have some faith. And reason is that navigation, like driving a car, you can drive car whatever way you want. Navigation will guide you, but robo prevent you from committing the mistake. That is the most important part. And definitely there is a precise placement, no doubt, but we do not know whether it translate into the function or not and longevity or not. Data has to come on these issue, but definitely component placement is good and bone preservation, especially in unicondylar, that is most important. And unicondylar also need precision. That is especially what I feel robo is excellent for unicondylar. In total knee, we have to keep our finger crossed and it overall preserve the bone on whatever surgery you do. And there is also function soft tissue balancing. probably it may be better with robo. So this is my take about the robo. And especially in complex hip, you sometimes tend to damage a lot of bone on the acetabular side. So in this situation, if you are an experienced surgeon, then you can come out with the similar result. But definitely for the surgeon, those who are not very much familiar with the large volume of surgery, robo may be better once you know your subject. After that, not start from the robo. It is not like that.
Yeah, true. I mean,
Sir,
absolutely.
one question when Dr. Yadav is already talking. Ashish, when you were doing your live surgery, I saw you doing shunt test and placing a lot of importance on shunt test. So I'll just ask the other faculty, how much importance do they really place to this shunt test? Or do you template it to your preoperative laxity or tightness? So Dr. Yadav, I think I'd like to hear from you first.
Dr. Rajput, excellent question. I do not believe in suck test. I rarely look for suck test. I basically see throughout range of motion. If my hip is stable, though it is loose, I am not bothered. I believe more in the combined antiversion and seeing the range of motion throughout. So if it is stable, even if my hip is loose, I will not lengthen the limb just because of looseness of that suck test. I used to say at AMC, boss, after surgery, a lot of people used to do lengthening at the cost of stability. I do not believe in this concept. For me, lengthening is foremost important. And if loosening is a little bit there, I will accept that.
I'd like to hear from others also. Rajkumar, you, Kamal, or Dr. Picard?
No, I also wanted to
Yeah.
ask, will this point be addressed by robot regarding this, whether the shuck test is loose but component wise placed properly, and range of motion wise the hip is stable but the chuck test is loose, then why Ashish Singh should check for the chuck test perioperatively?
Well, I think so. I personally do the shuck test, but I place more importance on stability through the range of motion. If I can adduct the hip, and so I don't go by the posterior approach. So it's adduction and external rotation. If the hip is stable in that position, I'm happy with that. Professor,
I think for John, it will be an extension then, I think.
Yeah, so it's
for you, it will be extension. I think for posterior, it is flexion.
Yeah, so here we actually look at adduction and external rotation is what we test in the thing. Professor Picard, you wanted to say something?
Yes, I've got a question for you, Ashish, but before that, I'd like to say to Dr. Shekhar that the comparison between CAS and navigation is great, except when there is a lot of fog out there. I'm in Scotland, and when we are on the road, sometimes we don't even see where is the road. So this is why navigation is useful, at least that's what I feel. Okay, and the question is for you and for you, Ashish, and for you guys who have the robot, the Mako robots or any other robots on site. It's two questions. The first one is about the costs, how your institutions and your hospitals are dealing with that. And the second question is about the marketing effect of the robot. In other words, do you have any patients coming to your office asking to have the surgery with the robots? Thank you.
At present, in India, the robots can be bought only by doctors like Ashish and others, not anybody else.
But if it's a hospital, then even Ganga can buy it.
Ashish have lot of money.
Adarsh and Ashish.
He can even buy me. He can come to CS Yadav, come to Patna, practice over here with me. He can buy me as well.
I would answer everything, sir. Sir, first of all, Dr. Rajkumar Natesan's question, that even being on robotic platform, I did a such test and the co-planar test. So in hips, my personal preference, I do not bother for the leg length. I bother for the instability, and I am very particular for shuck test and the coplanar test should be in range. So I'm happy. If test happy, coplanar bit out of range. But in robotic platform, I'm still doing it because it's an habit which I have been doing it. So even if you have your car going on autopilot mode, still you are hearing the handle. So it was the robot told yes -4, happy -4, but still I did the success because after every technology, the human brain is on top of it. Now, this is my perception regarding the cost of the robot. Yes, it's a costly affair, and I was in one of CS Yadav sir's meeting when I met these people, and it was a dream for my father to Bihar should be given services at par with National Golden Jubilee Scotland or America or the best technology, and we have got no extra cost for the robotic surgery. Most of the hospitals 20%, 30% hike. And regarding marketing, we don't have a marketing team in Patna. It's what I do, videos and all, that's it.
I think Dr. Yadav should charge royalty for that then. Sir, aapne inspired.
You know, a striker is like government company, they give nothing.
No, but if Dr. Yadav was asking about data, we need a lot of data. So if he buys one robotics, the data will be available
automatically there.
Yeah,
We'll get data in no time.
Yeah, for the numbers he does.
Sir, regarding data, sir, I would like to highlight one more thing, which Dr. Adarsh will also highlight. Yes, sir, number one, so we are doing some studies which is registered with the ICMR trial committee. All the patients blood loss se leke proper ethics committee approval from our institute, and we will be giving genuine data in next 2.5 years. So every patient is investigated with Harris hips, Oxford hip, WOMAC score, forgotten joint score, VAS, and SF36. 2.5 years, we'll have data, real genuine data. And the cost is great, but service is important. So that's why we bought the robot.
Yes. So I think it has to prove that it's a better system in terms of sort of function and longevity. And once it does that, the cost then becomes secondary. I would say that.
Yes, sir. Yes, sir.
Yeah.
If you can afford that, there is no harm in using navigation.
Sure.
Sorry,
so that's
robotic. There is no harm in. Definitely, you will be at advantageous point if you can afford that. Simply.
Sure.
If you use it, there is no harm.
No, but what I'm trying to say is that once it proves longevity and function,
functionality,
then the cost will automatically be of less importance. Yeah.
Valid point.
Yes, sir. So we have others for next talks. So should we hand over?
Thank you, Dr. Ashish, for giving the wonderful talk. Now I would like to invite Dr. Adarsh for give the overview about the patient of robotic joint replacement follow-up and its outcomes.
Yeah. Thank you, Dr. Sushil. I would like to first thank Dr. Ashish for inviting me here today. Amongst a lot of my seniors and my teachers are here, so it's an honor to be speaking here amongst all of you. I'll be departing a little from what has been discussed most of the evening, most of the day. I think most of the talks were about the total hip. So today we haven't launched our hip yet. We'll be launching in December. We've been doing a lot of TKRs and unis. And also Dr. Ashish had mentioned to me to present our own outcomes. We haven't got the full data yet published. We are in the process. So we will just be presenting about what we have seen, what we have noticed in the last few months since we started. So my topic is our patient outcomes following robotic total joint replacement. So I'll just quickly run through our journey. We were also quite skeptical about the adopting robotic technology initially, but then the Stryker team convinced us finally to go to Australia in Jan 2019, and we visited these 3 hospitals where we saw the robotic TKR, robotic uni, as well as the robotic total hip. And that was really an eye-opener. Then we realized how much of a difference it could make, especially in unicondylar, as Dr. C.S. Yadav sir said, and also a total hip replacement. Then we finally took the plunge. We went to the US in November 2019, and we did our training over there. And on February 1st, we launched our robotic department. It's Sunshine Orthobotics. So we are the 4 certified surgeons there, Dr. Guraredi, myself, Dr. Kushal, and Dr. Suhas. So Dr. Thomas Kuhn, who is one of the designer surgeons for Mako, he had come over. You can see him doing our breaking of the coconut in our style. I'm not going to play this video. He's just mentioning about how this experience was. And then we started doing our total knees and partial knees in full swing. In 2 months, we managed to get the fastest 100 Mako surgeries, I guess, worldwide, because we have large numbers. And we were quite happy. Initially, as I said, the skepticism started turning into, we were very, very happy with our results. So the present numbers are looking like this. At the moment, we have done 271 surgeries. There was a big break in between because of the nationwide lockdown, but the numbers have picked up again after the lockdown ended. So 271 surgeries, out of which 245 are total knees and 26 are partial knees. And the average procedure time for the total knee has come to around 1 hour. And I'll be speaking a little bit more about this in the later slides. The average time for registration. So a lot of people say it's going to take a long time. It takes much longer when you're doing robotic. There's so many more steps involved. But if you see the average time for registration, around 5 minutes. The average time for the ligament balancing is around 6.5 minutes. And the bone preparation itself just takes around 13 minutes. So it's not taking more than 20 minutes overall after we get used to it. So this is just a little bit of numbers, statistics. As I said, we have done around 245 totally. And out of these, we have something known as the CMR, where we're doing one side robotic and one side manual for one of our studies, which I'll mention a little later. Bilateral staggered of 50. Staggered is when we do after 4 or 5 days, the second side. Bilateral simultaneous, we did 70, 79 unilateral. So that comes to a total of 245 total knees and 26 partial knees. Triathlon, we're using the most of our knees are PS and a few of them are CR. And the poly size maximum, we managed to stay in 9 mm and 11 mm. Very few cases we had to go above 11. So what have we learned? The most important part of what I'm trying to tell you is what have we learned in the last 200 knees, 250 knees? The first thing is we found that people embrace the technology much quicker than we thought. That is the biggest surprise to us. When we bought the robot, as Dr. Ashish said, it's not a cheap proposition. It's quite expensive. And we were a little worried. I mean, Dr. Gurvaredi was quite, confident, but the rest of us were a little bit apprehensive about how people are going to accept. There is a marginally increased cost for these surgeries. So are they really going to accept this? But if you notice the numbers that I showed you just now, they really embraced it. Just 2 minutes, just mentioning about the accuracy and mentioning about the less bone cuts that are required and the ligament releases, and patients are quite sold on it. And we found even more surprising in the recent few months, patients themselves are coming and asking us about this surgery. And that's the first point that we learned. The second thing that we learned is the learning curve is not that steep. It's not as steep as we expect. And again, I'll be showing you a few slides about each of these 4 points. The next thing was less pain. Fourth point was much faster rehabilitation. And the fifth most important thing is we can do complex cases as well. Initially, we thought that, okay, let's take the robot. We'll be able to have more precision for the more simple cases. But no, even the complex cases we're managing to do pretty well with less amount of soft tissue release with the robot. So let's talk about the first point that the point that I mentioned. The learning curve is not that steep. So if you see our Mako total knee procedure time, we've made a graph over here with the help of our Stryker friends who have been noting the times for all the surgeries that we have done. The first 50 cases, the average time was around 1 hour, 5 minutes. But then if you see the next 50 and onwards, it's come down around 50 and 53. And now we're hovering around 45 minutes. So that's really reduced our, I won't say faster than a conventional, but at least time neutral, that's for sure. It's not taking longer than a conventional knee would take. The next thing I spoke about is less pain. Now, if you see this lady, we had done a partial knee replacement for her. And this is just day 2. See how she's walking. Not only is she walking so happily and comfortably in the second day, she's able to sit down and squat and speak to us. This is the very next day after surgery. So there's definitely less pain. And this is a gentleman who I did bilateral partial knee replacement with the robot. And this is 1 week after surgery. His daughter sent me this video from his home. He's happily walking outside his house. The next thing is faster recovery. As I said, this patient, this is the day of the surgery, the same evening. He's able to happily move his knee. without much of discomfort at all. Okay, so the next thing that we spoke about is the complexity of cases. We're able to cover a wide array of different kind of complex cases. And if you see this range of our angulations, we had a 37-degree of varus, a severe varus with 18 degrees of FFD, and ranged up to even 10 degrees of valgus with 20 degrees of hyperextension. This is a wide range of joints that we could do successfully with the Mako. I'll show you a few of these complex cases. This is a bilateral gross varus in a 65-year-old lady. You can see that completely worn out and completely eroded as well. And this is her walking. And this is one of the first complex cases that we did with the robot. So we did go in with a bit of trepidation, but after the surgery, we were quite happy. Now, this is intraoperative. As I said, we can plan everything beforehand. It is showing 22 degrees of limb varus. So we were wondering, can we actually get neutral alignment? And at the end of the day, we managed to get all the gaps equal, the extension and flexion gaps, 22, 22, 22, 22. And we managed to get a perfectly well-aligned knee with just 3 degrees of varus. And we used just a 13 mm insert. This is the post-operative X-ray. And this is the patient. Oh, sorry, I don't have the video of that patient, but this is another patient who had a severe varus knee. And this is post-operative. And another severe varus knee. And we managed to get complete neutral alignment. So the next thing is the valgus. Can we actually do good things with the valgus knees as well? So this is a 47-year-old man with a right knee gross valgus deformity. This is the walking videos. I don't know if you're able to see them. He has hyperextension as well. Okay, so when we went ahead, we managed to, yeah, this is the intraoperative, sorry. This is after anesthesia, if you can see the amount of laxity that's there and the amount of hyperextension that is there. So with the robot, we can plan how much gaps we want to give, how much we do the whole ligament balancing as well. And at the end, we managed to get a nicely aligned TKR after the surgery. And this is 10th day post-operative. He's walking very comfortably with a nicely aligned knee. And this is the front view and this is the lateral view of him walking. Very comfortable, and we were very, very happy with this. This is our first valgus knee that we had done. So this is another gentleman, a friend of Dr. Gurvareddy's, a classmate, who is a 61-year-old orthopedic surgeon himself with a valgus knee, bilateral valgus knees. And this was his preoperative walking. He's a hemophiliac. We kept the blood reserves and everything, but we didn't have to use anything. And this is the post-operative walking. This is we just like 2-3 days after the surgery. We did this simultaneously. Okay, and another severe valgus. This is another lady. This is one we've done recently. Got a nice alignment. She has a little bit of a lurch still, but we're starting a physiotherapy for her, and she should get rid of that very soon. It's more at the pelvis region. Okay, so our patients, this is 1 month. This is the first set of patients that we did with the robot. They came, they were very happy. So they came and they wanted to do a nice small TV program and to tell how happy they are about it. So the question we asked ourselves is, why are we getting these better results? I mean, yes, we are seeing that people are doing better. There's less amount of pain. There's faster recovery. They're able to go home faster. They're coming back very satisfied. But why? So we asked ourselves this question, and we kind of boiled it down to these 4 points. We don't know if it's true yet. We're still doing some studies to determine these, but this is what we think. First thing, we're maintaining the internal homeostasis of the knee. We're hardly touching any of the ligaments at all. The titration of the bone cuts, that is functional alignment, leads to less ligament release. The same severe varus, we would have had to do a lot of medial release to get proper alignment if you're going for mechanical alignment. But here we can give some amount of varus on the tibia, and then we can make a nice mechanical alignment to a functional alignment and reduce the amount of soft tissue release that is required medially. Next thing is, of course, the haptic control. This is the beautiful part of this. It doesn't allow a saw to go anywhere outside the boundaries. So the soft tissues, which are medial and lateral, are not touched at all. And finally, the less time with the knee subluxated. So in a regular conventional TKR, we have to subluxate our knee earlier in the procedure when we're doing a tibial preparation and everything and tibial cuts. We don't have to do any of that here. Only at the end when we're doing our tibial final tibial keel preparation is when we have to subluxate the knee. So maybe these things are giving us less amount of pain. We're not sure. There is a paper by Dr. Faris Haddad and Kayani, and they have this has been accepted in the Journal of Arthroplasty. The title of this is Iatrogenic Bone and Soft Tissue Trauma in Robotic Arm-Assisted Total Knee Arthroplasty compared to conventional jig-based total knee arthroplasty. So they created their own classification system for macroscopic soft tissue injury called the MASTI classification. And they found that there is definitely less amount of injury to the soft tissues in the robotic assisted total knee arthroplasty. So that is it's kind of, this is what we were trying to say, but they have published it and we are trying to also get these kind of results in our studies as well. So they said there is reduced medial soft tissue injury, there is more pristine femoral and tibial bone resection cuts, and the MASTI scores are better with the robotic compared to the conventional. They concluded that there's reduced bone and periarticular soft tissue injury in patients undergoing robotic TKR compared to conventional TKR. And so basically, this is kind of confirming what we discussed in the previous slide. So we are doing our own studies now. 2 studies are ongoing already. One is a prospective double-blinded controlled trial comparing patient satisfaction, early rehab, and functional outcomes of robotic versus conventional TKR in a simultaneous bilateral TKR. That means one side we're doing a robotic, one side we're doing the manual. And the patient is blinded and the assessors are also blinded. We have devised a way where we put the tibial pins also in the wound and the femoral arrays also in the wound, so that there's no way to know which side is robotically operated. We've already got 21 cases now, and we're studying this, and we will be hoping to get 100 cases to get our results. The other study, we're studying on one side, we're doing robotic on both the knees, but on one side we're doing a mechanical alignment, and one side we're doing a functional alignment, and we want to see the different outcomes in terms of early outcomes in terms of pain and rehab, and late outcomes in terms of functional outcomes. So which knee feels more natural? Here we've already got 26 knees, and we're waiting for follow-ups to start publishing these. Future topics, we're trying to assess the variation in coronal alignment from intraoperative supine position to the postoperative weight bearing in RATCA. And are equal flexion extension gaps imperative for optimal functional outcomes is another question we're asking. Another point is the learning curve associated with simultaneous bilateral RATCA. We want to do 100 patients to prove that our learning curve is definitely improved. And in difficult primary knees with gross deformities, what are our functional outcomes? Thank you so much.
Thank you, Dr. Adarsh. And any questions?
Yeah, so yeah, that was great. So you guys, do you not use a frame assisted walking at all after your total knee replacements? Because your third day you're walking without frame, so you start.
You mean with the walker, Dr. John?
Yeah.
The walker? Yeah, we do. It depends on the patient's comfort. We're not forcing them to use it. A lot of them are quite comfortable without it, and they're having a very natural.
Without it straight away.
Yeah, if they're comfortable with it. We try out with, it depends on how much pain they're having.
I think, John, the UKR ones do very well, actually. They
especially the UKR, exactly.
Yeah. Is the TKR
No, I'm not talking about UKR, I'm talking about the TKRs.
Yeah.
UKR, of course, I wouldn't expect them, but with the TKRs,
not all of
you're
them,
able to walk.
not all of them, but definitely a few of them without walkers.
Just a question here. Yeah, our total hips are mobilizing with a tripod stick post of day 0.
Yeah, but it's still
they're climbing day 1.
Dr. Frederick wanted to say something, I think.
Yeah.
Doctor.
You need to unmute yourself. Yeah.
Okay, so can I? Yes, I've got 2 questions. The first one is about the learning curve, because you said that it was not as bad as you expected, and I've got a question for you, which is: did you have any experience with any kind of technology prior to that? So, which meant that
navigation.
Where did you use navigation before? So, which meant that I guess the pins. All the technology, the understanding behind was maybe already there or not. And the second question, before I'll let you answer, is when you said that you had 1 hour surgery, is it skin to skin?
Yes, it's skin to skin. And the thing is, the first question, the answer to the first question is, Dr. Gurva Reddy, the senior most of our team, he was one of the first people to start in Hyderabad, the navigation. So he has a lot of experience with navigation. The rest of us don't have any experience with navigation, but we still didn't find it too difficult to pick it up.
I add something, sir.
Yeah,
May I
Doctor.
also, yeah. Thank you for the good question, Dr. Pikar, sir. Actually, yes, people who are not using navigation, they have some hesitation. But fortunately, I have been trained first by Dr. David Allen, for which I will be grateful, and by yourself, and by Kamaldeep sir and team Golden Jubilee. So when I started with the robot, what I felt, everything was the same, and the good thing was that even the cut was taken with the help of robot within the haptic boundary. So learning curve was definitely less. My first total hip replacement took 1 hour 15 minutes skin to skin, and the second, because of Corona pandemic, we were on live and zooming, all those things. It just took 45 skin to skin. Like today also, we were in 45-50 minutes. We're out with the case. So yes, if you are a navigator, things becomes easier. If you are using all these things, the robotic helps just in haptic and more precision. But yes, as I sent some papers to Dr. Picard, navigation does have its role. Sometimes I feel, yes, that case I would like to go by navigation platform. And sometimes, no, that is a robot case. But thank you, Picard sir, Kamaldeep sir, and everybody, because these are my teachers. And whatever I am speaking now, doing now, is their teachings. That's I would like to say.
Okay.
Any questions? Anybody else?
Yeah, when is John buying one?
I can't afford it. My hospital has to buy it. That's what.
Just a question as well for you, Adarsh, if I can.
Yes, Dr. Picard.
Did you use do you use the tourniquet for all your patients or not?
Yes, we do use the tourniquet. Yeah, we remove it just before cementation.
So
just after cementation.
There was an interesting paper recently from the US where they actually compared the use of tourniquet and not using tourniquet, and really didn't find any significant
no difference
between the two groups. Yeah.
It's a very good paper, yes, in the GBG.
In terms of even post-operative pain, etc., which you would have expected the non-tourniquet group to have less.
Yeah,
it was interesting. Okay, so
thank you, Dr. Dr. Adas, thank you for the beautiful.
Thank you, Dr. Sushil.
Providing the beautiful data related to the robotics knee replacement. I handed mic to the Dr. C.S. Yadav sir for closing statements. Dr. C.S. Yadav sir.
Thank you. I have already mentioned few points. It is a wonderful technology. It definitely will enhance the field of arthroplasty, and in many terms, especially bone preservation and accurate placement of the component. And probably in the if it is an accurate placement, then longevity as well, that we have to see. And it is much scores many points over the navigation, and that I have to say. And I have to give a lot of applause for the Ashish in a small state, a small town. He has guts to purchase, even to do the regular cases by robotic surgery. And I am very much convinced it is very useful for the unicondylar total knee arthroplasty, because I have done within this lockdown period at least 4 or 5 failed unicondylar because of poor implantation, because of poor soft tissue balancing from the big guys, big names in the country. I have revised them as a total knee arthroplasty. If you are doing uni, It is a great tool to have robotic surgery, and especially it preserves the bone as well. If you are doing revision in the uni and you have done it from the like robotic, you can very easily come out with the CR implant, just with the CR implant, if you want to convert that. So it is great. I enjoyed. I am thankful to the Ashish and Anup, master course organizer, for giving me this opportunity. I am sorry I joined late because today is the marriage of my bhanja, and so I have just checked in the hotel. I am talking from the hotel, and I all the time enjoy Anup master course. It is full of academics, full of information. Even I pick up many things from Anup master course. Thank you, everybody. Thank you, Dr. Ashish.
Thank you, sir. So it's now my turn to give the vote of thanks. Now, this is a very much tougher than presenting a talk, because first of all, what happens that planning is essential. One second. Planning is essential. And I was, in each and every step, I was helped by Dr. Purushottam, who has been there from the past 3 courses and executes things, helps me. Then Dr. Sushil Singh, Dr. Pankaj, an entire executive committee and the scientific committee. But the second thing is that getting so many people from UK, from South Africa, from Mumbai, from Coimbatore, others from Hyderabad and Pune, I would like to thank, number one, the Consoft team, Mr. Vijay Surana, and apart from him, the camera team, who has actually helped us in zooming everything. Because last night they came and told me that there are some issues in things, then they sorted it out. And these are beyond our scope, because we prepare lectures, we can do surgeries, but getting things, the most important person is IT, because even if we are talking, IT is active. So, and thank you to each and every one of you for giving your valuable time, coming to this conference. Thank you, Dr. K. Sancheti sir, who inaugurated the conference, and to everyone. And one thing I would like to request everybody, that this whole template was picked up from American Academy of Hip and Knee Surgeons. So if you log into Anup Master's course, you have all the stalls of all the companies. You can go do web chatting, talk to them, see their videos, and which I'll keep beaming on this YouTube link, because they have actually backed us up for in terms of money, because anyways, taking the robot has made me bankrupt. Organizing this conference, it required money, so they have sponsored bits and pieces, and we all have gathered from different parts of the world. And last but not the least, I would like to thank my father, who has always backed me up, Dr. R.N. Singh, and the entire Anup Institute team. And on behalf of everybody, I would like to thank all the faculty, and thank you, sir, for joining and blessing us. And so that Anup Master Course has been a successful event in 2020. Even in pandemic, we at least had more than 2K views. Thank you, sir. Thank you, sir.
Great, Ashish. Great. Keep it
Thank you.
up. Great.
Thank you,
Ashish.
sir.
Well done.
Yes, sir.
Thank you, everybody.
Well done,
Thank you.
Ashish. Thank you very much.
Okay, bye everybody. Bye, Kamal.
Dr.
Bye.
Rajkumar,
Very good to
Bye,
see you all.
Rakesh.
And
Good to see you.
Dr.
Rajkumar.
Even if it's
Thank you,
virtual, I'm
next year.
Rajkumar. Okay.
I think it was
Yeah, thank you.
great, sir, because Kamal, I think, hasn't moved from his sofa at all.
I know.
He's been focused completely on the course.
He's in one position, in fact.
Yeah, same position, sir.
He is teacher of Dr. Ashish.
Yeah.
Okay. Dr. Ashish has to be appreciated for his energy. He's full of energy always.
In Scotland, they say he's full of beans.
Energy without alcohol in dry Bihar.
We have Coca-Cola. Sir, actually, Dr. Fred Picard and Kamal Dev sir